is a mother's heartbeat and a baby's first breath. Good morning, namaste, and a warm welcome to all the distinguished speakers, invited guests, members of the Shimoga OBG Society, and dear colleagues. Here we are in the second annual CME by the Division of Fetal Medicine and Genetics, Malnad High-Tech Diagnostic Center, in association with Shimoga Obstetrics and Gynecological Society. I am Dr. Raksha Ram, and I will be taking you along this jam-packed academic feat. Today we gather here with a shared mission to ensure that every mother and every newborn not only survives but thrives. The CME's theme of improving perinatal outcomes isn't just a clinical goal, it's a promise we make to the future generation. Despite great strides in obstetrics, preventable complications still challenge us. Today, we are here to strengthen our knowledge, update our practices, and refine strategies by listening to the experts in the field, thereby refining our strategies that can help truly change outcomes. Let us straight away begin session 1 on antepartum worries. I request the chairpersons of the session, Dr. Shivamogga ma'am and Dr. Swati Kishore, to grace the dais. Shimoga OBG Society in 2018 and President of Women Doctors Wing IME 2023 to 2025, and she has chaired many scientific sessions in state and national conferences. Currently, she is working as a senior OB-GYN consultant since 2006 at Nanjappa Super Speciality Hospital. A hearty welcome to ma'am. Dr. Swati Kishore ma'am, she is currently working at SIMS, and she is also the consultant gynecologist at Karthik Consultation Center, Shimoga. She is a research fellow UNICEF 1998-2000, recipient of Praveen Mehta Foxy Fellowship and Deccan Herald Doctors Felicitation in 2021. And she has participated as a guest speaker at several state and national conferences. A hearty welcome to you, ma'am. I kindly request the two chairpersons to start the sessions.
Shimoga, and without delay, we'll start with the first sessions today. The topic that we're going to start off with is something which bothers us every day, day in and day out. It's about antepartum worries, and the first session is going to be by none other than Dr. Jyoti Shetty. She will be talking about optimizing perinatal outcome in medical disorders of pregnancy. As we all know, Dr. Jyoti Shetty madam, who has done her MBBS and MD, is Professor and Unit Chief of Kasturba Medical College, Manipal, Mahe, in Manipal, Karnataka. She has more than 60 publications in indexed national and international journals. She is the current president of Manipal OBG Society. She has been awarded twice for excellence in teaching Mahe. She has also got the Foxy Imaging Science Award, the Karan Gupta Memorial Prize for Best Poster Presentation, and her field of interest is high-risk obstetrics, endoscopy, Mullerian abnormalities, and intrapartal ultrasound. Over to you, madam.
All the delegates. When Sri Lakshmi gave this topic, she said specifically to cover perinatal outcome in preeclampsia and diabetes, because they are very common compared to others are being touched upon in the panel. So coming to these two conditions, I thought like we can improve the perinatal outcome by screening for preeclampsia all the women, antenatal women. If you screen antenatal women, you can add low dose aspirin and reduce the severity. So there are two ways of doing the screening. One is, all of us are familiar, even in government is encouraging us to do the gestosis score. That is, take all the risk factors and give them 1, 2 and 3 depending on the category which you just have to go on. And actually now the president of Kasturba also has introduced a QR code and through that you can do it in each visit. You can even train your nurse to enter and get a score. That is very easy in a smaller resource setting. And you can, if the score is more than 3, she is labeled as at risk for preeclampsia, and definitely you have to start her on low dose aspirin. So these are the risk factors. That is, one is like age. All of us are very familiar with this. So in the first visit, you have to calculate her BMI and see what is the inter-pregnancy interval, and you can just keep this chart, or otherwise you can go to the Kasoga website and that QR code is there. You can just go on, or in the Thai card also you can do it, and you will be given a score. Next, you will give, like suppose she has diabetes, gestational diabetes, her score becomes 2. This is a dynamic score actually. As the time passes by, if she develops 1 by 1 parameters, you can go on, and score 3 will be allocated for patients who have who are old diabetes, also those who are conceived with IVF and donor ovum. So this is a simple scoring which I told till now. The alternative to this is, like if you have facilities, you can do by doing uterine artery Doppler and combining it with a marker, biochemical marker. So this we are trying to do in our hospital by subjecting, or in Kasturba hospital, we are all the women are being subjected to uterine artery Doppler. So this goes like, if the trophoblastic invasion, it is done along with the nuchal translucency scan, and if you find that the trophoblastic invasion is faulty, it can be picked up by doing the uterine artery Doppler. So you can tell, you can request also, like if you are not doing it yourself, you can ask your fetal medicine specialist or radiologist to do the uterine artery Doppler along with the nuchal translucency scan, and you have to note down the pulsatility index of the uterine artery. Along with this, you can add the biochemical marker, that is placental growth factor. Actually it drops in patients who are destined to develop preeclampsia in future. So along with the dual marker form, you can do this estimation and try to find out whether she is likely to develop preeclampsia. So what are all the parameters to be filled in this form? One is pulsatility index of the uterine artery, then markers, pregnancy associated plasma protein A along with placental growth factor, and the mother's blood pressure. That is, in both arms you have to measure, and the mean arterial pressure is calculated. So there's a software which will analyze it, and this is how it looks. Like once you get the report, it will come whether she is likely to develop early preeclampsia or later preeclampsia. Whatever it is, you have to consider low dose aspirin. So in the counseling, you will recommend for her to you will be prescribing her 150 milligram of aspirin in the night time. This will suppress the thromboxane and make the prostacyclin, which is a vasodilator, to predominate, and this can be stopped around 34 to 36 weeks of gestation. So there is another way. Before the combined screening test became popular, we were using the FMF website and entering and getting the score. That's another way of doing. But now because of, we got a better method of doing. So either you can do, suppose you are in a rural area, you can either do gestosis score, and if you are in a better setup, you can order for combined screening test. Now once the lady develops blood pressure, we should always maintain the blood pressure you should start an antihypertensive and maintain the blood pressure, the systolic between 130 to 140 and the diastolic between 80 to 90. Otherwise, there is very high risk of her developing cerebral complications, which can, so that the patient can go into complications. So to minimize the complications, always keep the blood pressure below 140/90. So all of you know, actually this topic most of you are familiar with. I will just emphasize on certain points. That is, you can start with labetalol. It's the drug of choice. Either you can give, depending on the blood pressure range, 100 milligram or 200 milligrams. Start with twice daily, and as the blood pressure rises, you can make it 3 times, even 4 times a day. Nifedipine is the other drug which can be added. It is given as 10 milligram tablet orally, and it can be increased if required to 20 milligram twice daily. Now, preeclampsia with severe features, that is another, you have to see the gestational age. Now, if she is below 27 weeks, you know that it carries a very poor prognosis, because you have to see the weight of the baby. If baby weight is maybe below 800 grams, you have to tell them guarded prognosis, and maybe you can just wait for some time. Most of them will end up with some complication, and then you can terminate the pregnancy. We can save majority of the babies when they develop severe features between 28 to 33 weeks, and more than 34 weeks we deliver the patient in severe preeclampsia. So this tells you about all the severe features which the patient can develop. You are all familiar, so I won't go into detail of all this, because when a lady has even one severe feature, she is labeled as severe preeclampsia, and they are likely to develop complications. That is, they can develop very dreaded complications. You have to see every day whether the lady is at risk for these complications. So I will just tell you about the indications to deliver, which you should just the moment you see that the blood pressure is above 160/110, in spite of her having 2 antihypertensives, it is better to deliver. Imminent features like if she complains of headache, blurring of vision, epigastric pain. Eclampsia is preventable, provided when there are imminent features, if you deliver the patient. If you wait, she will end up with convulsions. If she complains of bleeding PV, she is having abrupt show, and immediately, if the fetal heart is present, you can do a cesarean. If when you do LFT and platelet is below 1 lakh, you label her as health. If she has developed urine output less than 500 ml, creatinine more than 1.5, and you should auscultate every day her lung bases and the lungs to look for pulmonary edema, or if she has gone into labor, or if she is complaining of leaking PV. These are the indications to deliver. Now, at the same time, you should also look for in the fetus for how is the baby. Like, you will do an ultrasound, and if the estimated fetal weight is below 3rd centile, it's an indication to deliver. If the amniotic fluid index is below 5, and when you do Doppler, if you find of the umbilical artery there is initially absent you can wait, but if it becomes reversal, as you can see in this picture, it shows reversal of the wave, it is indication to deliver. And we have to do pulsatility index of middle cerebral artery divided by the pulsatility index of the umbilical artery, and this gives as a ratio of cerebroplacental ratio. If it comes below 1, you order an NST, and if NST also shows late or variable decelerations or poor variability, better to deliver the patient. So when you have decided to deliver, you have to give antihypertensives, steroids, magnesium sulfate as neuroprophylaxis if she is below 32 weeks. Below 32 weeks, you will give neuroprophylaxis. So steroids promote the production of surfactant and it will reduce the chance of the baby developing RDS. So betamethasone is given as 12 milligram, 2 doses, 24 hours apart. Now if the lady is also having diabetes, most of them, sometimes you find that the lady is having diabetes with preeclampsia, then we prefer dexamethasone, that is 6 milligram. It is given once in 12 hours as 4 doses. Now by giving this, you can reduce the chance of RDS. The odds ratio is about 0.5, and you can reduce the chance of developing intraventricular hemorrhage, and it also decreases the chance of baby developing necrotizing enterocolitis. So these are the benefits to the fetus. So when the gestational age is below 34 weeks, you have to give corticosteroids and deliver the baby. Now, usually, ideally, like we had a patient who came with severe features, and then we gave corticosteroids, and as we got nearly 24 hours time for the after the steroid, and after 24 hours we delivered the baby, because again she started complaining of imminent features, and this baby was just 30 weeks, but because we had given corticosteroids, the baby did not require ventilator. It just required NICU care of maybe a month, but without any ventilatory support. So this is the benefit of giving corticosteroids. But sometimes as you are waiting, you may find that she is developing imminent features and you have to deliver before 24 hours of starting the corticosteroids. Still it is beneficial. Don't hesitate to give corticosteroids. Now one thing is, when you give corticosteroids, one problem will be that mother may complain of decreased movement. Also, when you do ultrasound, you will find the breathing movement has reduced. That is one of the biophysical profile will also show that breathing movement is less. This will last for about 72 hours, and then finally everything will revert back. The mother also will start appreciating fetal movements. Next is, you have to give magnesium sulfate. Now magnesium sulfate will be required if the patient's gestational age is below 32 weeks, so that it will reduce the chance of fetus developing cerebral palsy. We are now following the Zuspan regime, that is, we load 4 grams of magnesium sulfate and give it slowly IV over 20 minutes, and we can give later 1 gram per hour till 24 hours, or we can, suppose the mother is developing some other feature for delivery, you can take her up after 4 hours. So it is usually given when we anticipate the delivery within the next 24 hours. At least 4 hours of neuroprophylaxis is ideal, but you should never continue it beyond 24 hours. The chance of, when the fetus is below 32 weeks, the relative risk of reduction for cerebral palsy will be 0.6, and when it is below 30 weeks, it will be 0.5. Now, when the patient is in the HDU, you will sometimes find the patient has very high blood pressure. And what to do when a patient has very high blood pressure. So when it is persistently high, above 160, 110, we can use IV labetalol or nifedipine. Now, what we do is, you give 20 milligram of IV labetalol, check the blood pressure after 10 minutes. If it is still high, you can give 40. If still high, you can give 80. The other alternative is nifedipine, that is 10 milligram, then 20 milligram. After that also, if it persists to be high, you can give hydralazine. Hydralazine is the next drug, but most of the time we are able to manage with IV labetalol or nifedipine. So this is about preeclampsia. Now next is, we had a patient who actually, this was a patient who was 26 years, and at 30 weeks this patient developed preeclampsia. So usually, when we did the estimated weight, the baby was weighing about 1.1 kg. We gave corticosteroids and neuroprophylaxis, and the CP ratio also was borderline. And when we were waiting, we found that now most of the time, when the patient is admitted with preeclampsia, the question most of the relatives will ask is whether when we start the drugs, if blood pressure normalizes, can we go home? This question is very difficult to answer. So what we do is, there is one test by which we can predict whether a mild preeclampsia can go into severe preeclampsia. So there is one test. I will just mention this because most of us we are not routinely using it, but we should be familiar that there is a test by which you can predict the onset of severe preeclampsia. That is, you can estimate SFLT1. That is, what is the full form of this? The lady will produce, that is soluble form tyrosine kinase 1, and this will bind to the vascular endothelial growth factor and the placental growth factor and produce endothelial dysfunction, and as a result there will be vasospasm. So what will happen is, this will be more of anti-angiogenic. When the SFLT increases, she will have a severe vasospasm, and this ratio can be asked. Actually, it can be asked in LALPATH and all. You can do it, and you can predict what is the chance of her developing severe preeclampsia. So that when the SFLT to placental growth factor ratio is more than 38, it can predict within the next 4 weeks she can develop HELP with positive predictive value of 36 and with 66% sensitivity and 83% specificity. So this is one of the things which you can do, because otherwise every day patient will ask, can I go home? So you can estimate this and say whether she need to be in the inpatient as an inpatient. So next, going on to what are the things we have to do to optimize the neonatal outcome in gestational diabetes. Managing gestational diabetes is, I think, by universal screening. Like all of us, there's no point in doing random blood sugar. Understand? In the first visit only, we should, I think most of you are doing, like best practice to do will be a fasting blood sugar and a glycosylated hemoglobin. Otherwise, at least do glycosylated hemoglobin and do a RBS, so that you can screen in the first visit only whether she has diabetes. Because most of the time, like we had a patient recently who was in first visit glycosylated hemoglobin was 8. Okay, she did not know till then, a primary gravida, so we immediately sent her to the endocrinologist. So screening has to be universal, that's the main thing. We can't do by risk factor stratification. Like there are so many risk factors. It's better not to take chance in India because we are the capital of diabetes. So we find, it is just, the incidence is extremely high. If you just say, go on taking history and after that you screen, I don't think we'll be able to, get a very good glycemic control. So there are two ways of monitoring the glucose. That is, one is we do fast, once we label as diabetes, we do what is called 4-point sugar. That is, one is fasting sugar and we do postprandial sugar. Now whether to do it after 1 hour or whether to do it after 2 hours is a question. Now, if you involve an endocrinologist, they prefer 1 hour. Okay? Most of the endocrinologists will ask for postprandial after 1 hour. But our Society of Maternal Fetal Medicine still prefers 2 hours. So it depends on with whom you are consulting. Like if you are doing it yourself, you can just follow the maternal fetal medicine guideline and do it after 2 hours. So there is no consensus, but any method is okay. But if it's an endocrinologist, they will never agree with you for the 2 hour value. They want the 1 hour value. Now once you label her as diabetes, she has to be on diabetic diet, which is, that is, you have to make her understand the importance. You can involve a nutrition person, and say her that her total calories, 40% should be carbohydrates, 20 from protein, and fat will be about 40%. So 3 meals and 3 snacks, and she has to take low glycemic index food and lot of vegetables. That is the diet which she has to be. So after 2 weeks of diet, you can repeat the sugars. So regarding the calorie intake, if it depends on her BMI. So when the BMI is between 22 to 27, you can tell her to take 35 kilocalories. And if at all she is obese, you have to tell her to restrict to 25 kilocalories, but they should not have ketonuria. Like that's also important. And most of the time, they have to be very strict with their diet. They can never, indulge in eating sweets. Exercise is also an important component. So 150 minutes per week, and they have to walk after their meal for 30 minutes. This will also reduce the excessive gestational weight gain. If after 2 weeks the sugars are still deranged, you can add metformin. That is, you can start with 500 milligram or 1 gram, and total dose you can go up to 2 grams, and after a month again repeat the sugars. Now coming to pre-overt diabetes. Like in overt diabetes, you will find that most of the time you have to take the help of the endocrinologist, or if you don't have an endocrinologist, at least the medicine doctor can help you to titrate the insulin. So now I will just touch upon certain things which are important to prevent a stillborn baby. That is, you have to be very vigilant after 36 weeks of gestation, because after 36 weeks there is a very high chance you have to stress her on maintaining a daily fetal movement count, and you have to do at 36 weeks that 4-point sugar, and if you find it is deranged, you have to maybe admit her. If there is polyhydramnios and macrosomia, it denotes sugar is not under control, and check her blood pressure. Most of them also develop high blood pressure at this time of gestation. Macrosomia is evidence that sugars are not under control. Now, because of the maternal hyperglycemia, it crosses the placenta, produces fetal hyperglycemia, produces hyperinsulinemia, which increases the metabolic rate and increases the oxygen requirement in the fetus. As a result, the baby will be in distress most of the time. So a macrosomic baby is an indication for you to admit the patient and increase the antenatal monitoring. If the mother's BMI is high, you have to admit, because in obstetrics is always 1 plus 1 is not 2. I always say 1 plus 1 is 11. That much it magnifies the risk for the mother. Now, it is one more important point is, like if the mother has associated like overt diabetes with other features, like they can have sometimes vasculopathy, nephropathy, retinopathy and all. then they will develop not macrosomia but FGR. That is still more risky, because with this they will have, a decreased uteroplacental blood flow, and the IUFD may happen in the second trimester itself. So we have to be very vigilant, and most of the babies will have intrauterine hypoxia. This is made out by, actually they have done studies, and they have found out in post-mortem babies, when they found that there's a lot of hematopoiesis happening in these over-diabetic babies, and intrauterine hypoxia is a big culprit. That is why you'll find that the previous day you would have done an ultrasound, next day mother comes with decreased movement, and when you see the patient, she has an IUFD. So it is very shocking to both the obstetrician as well as the patient. Now another important thing is, you should also do a glycosylated hemoglobin along with the 4-point sugar what you are doing. If the glycosylated hemoglobin is high, above 6, it indicates that the oxygen release won't happen and the baby is at higher risk. This is what you have to remember, because the oxygen release won't happen at the placental level, and the baby is at very high risk for IUFD. This reduced blood flow will produce FGR in patients, I have already said that, because of the decreased uteroplacental blood flow. And another complication which the mother can develop is, suddenly she may come to you with ketoacidosis and hypertension. This will further aggravate the chance of her developing IUFD. Now once she is on insulin, you have to educate the patient about all these. That is, you have to involve the family members also, and you have to tell them that she should not have hypoglycemia. Actually, most of them are taught how to administer the insulin themselves, but otherwise sometimes they take the help of nurse and neighbor nurse or something. And when the glucose control is, you find that you are giving adequate dose, but still hyperglycemia is present. It is often she's eating too much. And one more thing is, you should tell them not to at weekend, so many times, they'll go at the weekend and then, they will eat, and then again the sugars will shoot. All this is not allowed after. You have to strictly tell the patient that once the regime, she has to follow that very strictly along with the diet and exercise. So while changing the insulin, always change, if there are 2 types of insulin, the short acting and the long acting, always change one at a time. And nowadays we prefer insulin analogs, and if a patient complains of nausea and vomiting, it's a sign that she's going probably for ketoacidosis, and any fever has to be addressed very in an aggressive manner. So we all know this from our postgraduate days. We all know that in the first trimester the requirement is 0.8, and in second trimester it will rise to 1, and in third trimester it may rise to 1.2. But sometimes in few patients there is something called falling insulin requirement. Okay, so it also depends on the 4-point sugar what you are doing. So just don't go on increasing because she has reached the trimester, because there is also, it depends on the sugar values. Sometimes we find it's not required. Okay, you can keep the same dose till the delivery also. And usually we give 50% of the total requirement as that short acting one, and short acting will be for the postprandial whatever increase will occur, that is given 3 times a day, and 50% is given as the long acting one. And usually the short acting is given along just before the food. Okay, just before the food she will take her. And nowadays the analog, that is Lispro and Aspart, is preferred, especially when you involve the endocrine person. They always give either Lispro or Aspart because they prefer this to the Act Rapid one. Okay, so they prefer this. And what is your goal at the end of starting insulin? The fasting should be between 60 to 95, and if you are following 1 hour, it should be below 140. If you are following the 2-hour regime, that is sugar profile, it should be below 120. And sometimes you have to just check in the midnight once, that is between 2 a.m. and 6 a.m. It should be more than 60 and less than 120. So this will be the way to manage a patient who is having overt diabetes.
Sorry to interrupt you, ma'am.
Last, I finished. We are going to deliver now. So after this, if she's well controlled, we'll deliver at 39 weeks. And if she has vasculopathy at 37 weeks, and if there is FGR, you may, depending on the centile or by the Doppler, you can decide. And in labor, always keep measuring the sugar and give short-acting insulin. And ketoacidosis, if a patient complains of nausea, vomiting, headache, abdominal pain, you have to admit and look for diabetic ketoacidosis, and always involve the endocrine person to treat ketoacidosis. It's a separate regime. You have to manage very aggressively. And any questions for because I did not summarize because I knew it was very lengthy. So I thought it's just a recapitulation of what we know. So
thank you, madam. Reduced after giving the steroids.
yes.
We better have to tell all the antenatal patients who take this, because if you don't tell, they definitely come back to you that fetal movements are reduced. That is one thing you highlighted. Thanks for that. And another one is there is unexplained IUD in case of diabetes, means gestational diabetes. Even though it is well controlled many times, as you said, it occurs IUD in as early as second trimester. But sometimes, even though it is well controlled, suddenly there may be unexplained IUD at around 34 and a half weeks. That is very important. So we have to be very vigilant at that time. So thank you, ma'am.
I request Swati ma'am to give a moment of appreciation to Jyoti ma'am.
And she is a EC member. She has co-opted fellow representatives, publications and awards from MR during MBBS, including 10 gold medals, college and maternal medicine and high-risk pregnancy, advanced labor ward management, clinical governance, guidelines and protocols development, teaching and training.
Thank you, ma'am. Thank you, chairpersons, for your kind words of introduction. Thank you, Dr. Sri Lakshmi, for giving me this opportunity. And good morning to everybody. So, the topic given to me is the role of antepartum fetal surveillance. And I think at the end you might be left wondering, what should I be doing? Am I doing anything right? Or what should I be doing? So please don't hate me if that is the situation I'm going to be in, because unfortunately evidences are not very strong in terms of what is the right thing to do in terms of monitoring the mother in the antenatal period. So why do we actually do, as ma'am already spoke about hypertension and diabetes, we know that these women are at risk of stillbirth. So why do we want to monitor them? We monitor them because we are hoping that we can reduce the risk of stillbirth happening. Because we know nearly 50 to 60%, though it can vary depending upon the setting we practice, but nearly 50% could happen in the antenatal period. So our whole aim is to see if we can reduce. I mean, it's not a perfect strategy which we have, but we are hoping that we can reduce the risk of stillbirth, at least a preventable stillbirth. Now, who needs surveillance? Again, as was already discussed, anybody who's at higher risk of stillbirth, like for example, hypertension, diabetes. So we know that there are quite a few factors which would increase the risk of having a stillbirth. So American College says that if anybody has a risk which is that they become high risk maybe because of the testosterone score, because of the sugars, etc. So I think screening for all pregnant women is universal, and based upon that you stratify them to low risk or high risk, and of course then you plan the surveillance strategy. So I am not going to be speaking about screening. So of course there are various screening methodologies which are available, and for various screening for HDP, preterm delivery, etc. So you have to do screening, some kind of a screening. It could be just a history based screening, but it's very, very important that we screen the lady, and it is a continuous process. So it is not just at the booking. At every visit you need to see what is her current screening, what is her current risk profile. Okay, so these are various, right down. Okay, so now going back to surveillance. So how does it work? So we know that there are two different problems. There could be acute compromise or chronic compromise. Acute compromise is when you have an abruption, when you have a cord prolapse, when you have a rupture. Okay, chronic is generally related to hypoxia. So what are we hoping to do? We are hoping to identify the fetal compromise so that we can either put in interventions, say for example if it's hypertension, controlling the hypertension, if it is diabetes, controlling the sugars, or if push comes to shove, you might have to deliver them. So you are hoping that you deliver them so that you can give them a live baby and you avoid an intrauterine death. Okay, so can you do that for acute changes? Unfortunately, no. You know that somebody is at a higher risk of abruption, but you cannot say that at this minute she is going to have an abruption. Or we know that if it is a multiparous lady, if it's a high head, she is at risk of cord collapse, but you cannot identify that she is going to have a risk of cord collapse now. So you cannot do a periodic test and say that this lady is at risk. So these are acute events which are unfortunately something which we cannot prevent. Though you could prevent abruption, you could take in strategies to prevent a cord collapse from happening. These are unfortunately not preventable by your antenatal testing. Okay, so what is then what we can do for chronic changes? Say for example, if there is an hypoxia which is going to happen, then definitely these babies could be monitored, surveillance can be put in, and hopefully you can then identify before they actually decompensate and end up having a death. Okay, so how do we do that? Because we know that there is a series of changes which happen, compensatory and decompensatory changes. So the first thing is they may not move a lot, or they may have changes in the fetal heart rate pattern, there may be changes in their tone, there may be changes in the breathing. So all of these things go through various stages, and we are hoping that we can pick up those babies who are at risk of decompensation and deliver them so that we can avoid a death. So only for chronic changes you would be able to do it, and here also there are pitfalls. Because if it's a preterm baby, then again there are going to be problems. Whereas if the mother has got some other problems like DKA, or if she has hypoglycemia, that can also affect the fetal condition. Or if the mother has been given some drugs, as we rightly saw, corticosteroids is a simple example. That can also affect your fetal movements, fetal breathing, etc. So there are lots of pitfalls in whatever strategy we are trying to do, and that is what I am trying to say. Okay, so please don't get me wrong. Yes, we have to monitor, but then these are the pitfalls which you would need to be aware of. Okay, so what are the surveillance methods? These are the things which we are always aware of. So I will take each one by one. Contraction stress test and biophysical profile are generally not very much preferred, though we tend to have a bit of sort of a love affair with biophysical profile, but unfortunately evidence is not very strong as it will come to. The one on the left side, fetal movements, non-stress test, modified BPP, umbilical Doppler velocimetry, in few situations they definitely have a role. Though we may be doing it day in and day out, I think it's important that we are aware of the false positives and the false negatives so that we don't get caught out. Okay, so what about contraction stress test? I'm not going to spend a lot of time because we don't do it. Maybe intrapartum it automatically happens that the fetus goes through a contraction stress test, but we don't usually do it as a routine in this day and era. So this was based upon the premise that if the baby is already hypoxic or if the baby is not able to compensate when there is a contraction, there is going to be a deceleration. So that is the premise. So either it could happen spontaneously or you give oxytocin, nipple stimulation, whatever, and we are aiming to have 3 contractions. Okay, and this is how you interpret. So if it is negative, means that there are no decelerations, we are happy. Whereas if it's positive, then there are lots of decelerations. But as I said, we usually do not perform it unless labor itself becomes a natural stress test for the baby. What about biophysical profile? This unfortunately is still being followed to a greater extent, but again if you look at the data says it is not very helpful, which I will come to in a minute. So we all know that biophysical profile comprises of 5 components. We have the non-stress test and we have the 4 components which we look on the ultrasound scan. And how do we interpret it? Each of them give a score of 0 or 2 and your best score is going to be 10. whereas anything less than that is going to be worrying. So what are the advantages? The advantages purported is that if you look at the NST and if you look at the other changes, for example, amniotic fluid would be a marker for chronic conditions, whereas your other 4 parameters which you look in would be an acute change. For example, movements, breathing, etc. They say it could be acute. So what they say is biophysical profile is better purely because it combines both your acute and the chronic events. Okay, not hypoxia, but what I am saying is acute events and chronic events, and you will be able to better monitor the baby. But the problems are it's time consuming, minimum of 30 minutes you might need for scan, 20 minutes for CTG, it is expensive. But beyond that, what I would be really looking at is there evidence? If I am going to do a biophysical profile, what is the evidence? Again, Cochrane has clearly said that performing a BPPS, we might feel it is good, but unfortunately data evidence is that there is no significant difference in the outcome for women who have undergone biophysical profile monitoring. Okay, so I will probably leave that and move on to the other common measures which we commonly use, which is the maternal fetal movement assessment. We all know that it is very, very important. We ask them about the key counts. But is there any evidence? Yes, we are hoping that if the baby is not well, the baby is just going to lie without moving around, which is what we do when we are not well also. So we are hoping that this would precede the fetal death. So if you are able to identify those women, we can put in interventions. So we have been doing it for a long time, qualitative and quantitative. Qualitative where we just tell the women, you just monitor the fetal movements, tell them what is normal. Whereas in quantitative, various quantitative, kick to 10, going for 2 hours, voting for 1 hour, etc., etc. So there are lots of methods available. Unfortunately, we don't have data to say which is the best method. The optimal number of movements nor the duration which needs to be done is not very clear. So what are the evidences? This was the AFFIRM study, which was a large RCT, and this showed that there was a very slight reduction in stillbirth rate for those women who have been asked to monitor the fetal movements and to report if the fetal movements are less. And this was followed up by a meta-analysis. Again, they found that there was no difference in perinatal outcome, though there was a weak but statistically significant increase in preterm delivery. So in fact, we are doing the opposite. We are asking them to monitor the fetal movements. They come in, you do some interventions and end up having a higher rate of preterm delivery. Unfortunately, this is what the evidence has proven. But having said that, we still want to give importance to the fetal movements. And this is part of the Saving Babies Lifescape bundle, which is being proposed in UK as well as in Australia. In that, as we can see, raising awareness of reduced fetal movement. So what they say is, you don't have to ask them to sit and count. Just educate them about the fetal movement pattern. As we know, it is more active in the night, and there will be a pattern for each baby. Ask them to keep an eye on the movements, and if they are concerned, to report. See, this is what, and to ask them at every visit whether they are happy with the fetal movements. But unfortunately, formal counting evidence is not very strong, but definitely you would want to educate them about the importance of looking at the background fetal movements, and if there is any concerns, to report. And this is also part of the Saving Babies Lifescape bundle. But what they also say is, it is not just the women reporting, but what the practitioner does in return. When the mother comes in with reduced fetal movements, how are you acting up? So which I will come to later. So definitely fetal movements play a role, but quantitative not much of an evidence. Qualitative you still want to do it, though the evidence is not very strong. Okay. So now what about NST? This is something which we are so used to doing it. Doing an NST, we look at accelerations and we are very happy. So are we happy with it? What are the problems? So if it's a preterm baby, are you happy? And how long are you going to? So if there are no accelerations, then how long are you going to wait? Because we know that the baby is going to go through a sleep-wake rhythm. So how many minutes are you going to wait before you call it a day? So these are the problems with the NST. So in preterm, what they said is, asking for an acceleration of 20 beats actually is associated with problems, because NST could be classed as non-reactive in many preterm babies. So what they proposed is, instead of having an acceleration of 15 to 20 minutes, let's take an acceleration of 10 beats. Okay, so this is what they say, 10 beats and for 10 seconds. So that is what is sort of proposed for preterm babies. Again, the evidence is not very strong, but less than 32 weeks, maybe you would want to, instead of having 15 beats, you have them as 10 beats. But once you have seen a 15 beats, say for example, you have monitored the mother at 30 weeks and you have found that there is good acceleration, then you are not going to go back to your 10 beats. But the first time when you are monitoring them, and if you find it's only 10 beats, and if the 10 beats is there and you're not getting a 20 beats, you don't, or a 15 beats, you don't have to be worried. So for preterm, that is an exception which we have. What about sleep pattern? Because babies go through sleep rhythm. So many times we say that the baby is asleep, we try to wake them up, we give them some glucose, etc. So what is the evidence for that? Okay, so we are hoping to do that. Majority of the fetuses would wake up within 40 minutes, but what we need to understand is sometimes it can take as long as 2 hours. So this is the normal sleep-wake rhythm. The babies go through various kinds of patterns. Quiet sleep, awake pattern, active sleep, active awake pattern. So as we can see, there are lots of physiological changes which happen in the baby. So if you see the baby in the beginning of the trace, you might be a bit worried because that baby is in the quiet sleep pattern. But if you carry it on, the baby is then going to move into an active sleep pattern. So how long are you going to wait? So that is a difficult situation because whether it's hypoxia or whether it's sleep. So how do we sort of come to that conclusion there? So for that, what they started doing is vibroacoustic stimulation. So there is no evidence for giving glucose, no evidence for giving IV fluids unless the mother is hypoglycemic or hypoxic, you're not going to do it. But definitely vibroacoustic stimulation seems to have evidence, though unfortunately I do not have any experience with that. But what they say is giving a vibroacoustic stimulation in the sense like waking up the baby, maybe just increasing the tone of the NST, giving a loud noise, giving some startling response, and if the baby wakes up and the baby has an acceleration. What they have found out is this reduces your time because we already saw minimum 40 or sometimes even up to 120 minutes the baby may be asleep. So if you want to shorten the time duration, you could do a vibroacoustic stimulation if the baby actually hasn't woken up. And what they have found out is it does reduce your time needed for taking the NST significantly if you are using a vibroacoustic stimulator. Of course, how frequently do you do it? What is the intensity? We do not have again data, but definitely there is evidence to say fast works. Manual stimulation, palpation, etc. we could try, but we don't have sufficient data to it. But definitely no glucose or no IV fluids. So what is the interpretation now? So this is the actual recommendation. If you have to have a reactive NST, 2 accelerations in 10 minutes. Of course, if there are no 2 accelerations in a 40-minute period, then you class it as non-reactive. And of course, if you are having an acoustic stimulation, then again, within 5 minutes you put the vibroacoustic stimulator, within 5 minutes you expect an acceleration, which means that the baby is reactive. Okay, so have we now solved all the problems? No, because you also have decelerations which can come in. This can happen spontaneously. Preterm babies also have decelerations. Nearly 50% of times they may have transient deceleration. So how do you account for that? Or if there is oligohydramnios, you are going to have decelerations. So how do you then take that into picture? So that comes a bit more difficulty in interpreting the NST. But what they have found out is there are repetitive decelerations, or if it's a prolonged deceleration, then that is worrying than a standalone deceleration, because one occasional deceleration with the rest of the CTG being normal or the NST being normal, you don't have to be so worried. So repetitive or a prolonged deceleration is what you're going to be worried about. So this is the newer interpretation which has come in, taking into account your decelerations, taking into account the length of time. And as I already said, for preterm you're going to have 10 beats. Okay, so this is the new criteria. So if you are going to do a CTG in the antenatal period, 2 accelerations in 10 minutes within a recording period of 120 minutes. Okay, so that is going to be nearly 2 hours you have to wait before you can say that the CTG is non-reactive. But of course, if you are having repetitive decelerations or a prolonged deceleration, that goes into a decelerative pattern. So honestly, are you going to wait for 2 hours doing an NST? Is it practical? This is what you need to be looking at and thinking at before you actually start doing a CTG for every woman, because you are going to increase your false positive rates. If you have time on your side and if you have patience and if you are going to wait for 2 hours, then do your NST. Okay, so these are the concerns with NST. Again, it's only going to be that period. It is not going to have a predictive nature for how the baby is going to be. And of course, preterm, those issues are coming in. Is there evidence? Unfortunately, again, there is no evidence to say doing a routine NST is going to help you in improving the outcomes for your population. We do it, maybe it is obstetrician satisfaction, we are happy that we have done a CTG, maybe medico-legally we are going to escape, we feel, but unfortunately the data is not there at all. There is no evidence to say, I'm sorry, that's why I told you before, why are you even talking, that is going to be a question, but I mean, we have to know the facts. so that we can manage them accordingly. So if you do an NST, then there is no evidence to say that it is going to improve the outcome for your lady. But if you're going to do a computerized CTG, then it's different. But unfortunately, we do not have computerized CTG in India. It is not freely available. So what is computerized CTG? This is what it is. You have the computer interpreting. This is different from the artificial intelligence. It's an inbuilt into the CTG machine. This gives you what is called as a Dawes-Redman criteria, which looks as the STV, the short-term variability, which we cannot interpret with our naked eyes. So the machine gives you the data, it only gives you the answer as well. Dawes-Redman criteria is met, it is not met. So it is very easy for you to interpret it. And computerized CTG, if you want to do an antenatal CTG, please do a computerized CTG, invest on a machine, do whatever, because you would benefit the lady, but not with your traditional CTG. So this is reproducible, this is consistent, look at short-term variability. Okay, and this is a Dawes-Redman criteria. It looks at 7 features, and then for all the 7 features, the CTG machine itself through the computer analysis gives you the outcome and then tells you Dawes-Redman criteria is met or it's not met. So this is a computerized CTG. As we can see, this is how it comes in. And normal CTG, we look at the short-term variability, which can vary based upon the gestational age. And do you have evidence for it? Definitely. Computerized CTG is definitely shown evidence to decrease the perinatal mortality. It is better than the traditional CTG in high-risk population. So if you want to do a CTG, do a computerized CTG. Okay? So now moving on. What about modified biophysical profile? So we spoke about biophysical profile and we said it's not going to be very helpful. So modified biophysical profile, again the same problems as we spoke about CTG earlier on. Isn't it? So here you combine the amniotic fluid alone and the CTG assessment. And what they say is, if you want to do a biophysical profile, you are so bent on doing it, do a modified rather than a full, because that has the same kind of a negative predictive value compared to your full biophysical profile. You save time, save expenses. And we all know the components, that is the NST and the amniotic fluid volume. And here again, amniotic fluid volume, we prefer the, see whether you are going to do a AFI or SDP. That again, there is lots of confusion going on. But the evidence is that whether you use the AFI or SDP is actually better rather than using an AFI, because you are going to decrease your false positive rates. So you prefer the SDP rather than an AFI. Okay, so this is about your modified biophysical profile. Again, as I already discussed, the evidence is not very strong. What about Dopplers? I am not going to touch a lot on it because Shilakshmi is going to speak about Dopplers and FGR. But Dopplers, universally doing for low risk population, no evidence. If you have a FGR, you are going to monitor it with Dopplers, definitely. You have to monitor with Dopplers. The frequency would vary depending upon what the Doppler findings are. But if it's a low risk population, if I do a Doppler, am I going to be happy? Unfortunately, again, the data is not strong. The data says that you shouldn't be doing it because it's not going to be helpful. Okay, so what actually are the evidences? This is what I said. So this is the evidence. Unfortunately, the false positive rates, as we can see, is as high as 90% with NST and easily as high as 60 to 65%. So this is what we are having. We don't have a perfect test, unfortunately. What we are hoping is that the false negative test, and we are hoping that we can reassure ourselves and the women. But unfortunately, this is what we have. We do not have a perfect test for this high-risk population. And what all we have, the level of evidence is, as we can see, maximum what we have is only B or C. So this is what we are doing to our population, unfortunately. But yes, here the, what shall I say, the silver lining in the cloud is your computerized CTG, because there is evidence which is emerging to say that it is definitely beneficial compared to your traditional CTG, again in high-risk population. Okay, so I will just briefly touch upon the few conditions. So what do you actually do? Already ma'am spoke about HDP and fetuses. So stillbirth is pretty common, and this is usually in association with FGR. So you would monitor based upon the FGR strategy. That is what you are going to do in a woman with a hypertensive disorder pregnancy. And as ma'am already discussed, control of hypertension is paramount in that population. Okay, so whenever you are doing a conservative management or if it's a preeclampsia, you would need to do some kind of fetal surveillance, but that is mainly in relationship with the FGR. Okay, so what about diabetes? Again, as ma'am said, hypoglycemia, hyperglycemia, these are the concerns. And of course, if it's a type 1 diabetic where we have vasculopathy, FGR comes in. So it is a complex interplay of factors which comes in. So definitely, if the baby is big macrosomia, you are worried about hyperinsulinemia causing hypoxemic damage. But the problem is, it could be a metabolic event combination with hypoxemia. So a CTG may not pick up. Even a couple of days back, we had a professor from UK and he was telling me the same thing. He had a lady with a diabetes, he did a computerized CTG, not even the traditional CTG, he did a computerized CTG, sent the lady home and he had his hands burnt. That lady, a couple of days later, came up with a stillbirth. So unfortunately here, the problem is it's a metabolic event. We may not be able to predict it or prevent it. Whatever antenatal surveillance we are doing it again is looks like more a comfort factor rather than anything. What we should be doing is making sure that you actually do the sugar monitoring properly and aim for optimal blood sugar optimization and hoping that we can avoid macrosomia. Okay, so yes, surveillance again as per the American colleges, they say twice weekly monitoring, and what they usually prefer is a modified biophysical profile. That's what they actually the American college swears by, and they say you should start by 32 weeks and you might have to do it 2 to 3 times a week. So again, as I said, we need to be careful. If you are doing a modified biophysical profile, take it with a pinch of salt and see how you are going to manage if it is coming as an abnormal biophysical profile. Post-dated pregnancies. When do we start? The recommendation by American college is 41 weeks, but we know it is too late for us Indians. Whether we should start at 39 weeks, again, is there evidence whether the Asian babies mature early? That we know. Asian babies mature early. But what kind of a surveillance are we going to do? Again, the evidence is not very clear, but having said that, we do have some evidences saying that monitoring the babies from 39 weeks with possibly a modified biophysical profile may help in reducing the perinatal mortality and the stillbirth, but again it's a only single center study which came from Australia. Okay, so again we're going on to FGR. So before we go on to FGR, previous stillbirth. Again, we know that they are at higher risk of having a repeat stillbirth. So again, doing surveillance may help but may not help. So what I'm trying to say is you do your surveillance, but please understand the physiology. Don't just take your one surveillance tool into consideration and put all your eggs in that basket and either deliver or reassure. I think it's a whole picture which you would need to be taking into consideration. That is the bottom line which I want to say. Fetal conditions, here I will just take a minute for reduced fetal movements. I think as I already discussed, fetal movements is your best bet. Speak to them about qualitative fetal movements, asking them to look at the pattern of the fetal movements, and when the lady comes in with reduced fetal movements, don't just ignore, do a complete assessment, stratify her whether she is low risk or high risk. If she is, based upon your stratification, if she has normal CTG, no risk factors, you could leave her alone. But of course, if she has risk factors, especially FGR, you follow her up accordingly as per the FGR protocol. Of course, if the MST is abnormal along with the fetal movements, it becomes a bit tricky. You may have to complement it with some other tools. Okay, as I said, the best bet is computerized CTG, but when you don't have a computerized CTG, what we have to go by is your NST and your modified biophysical profile. That is the best tool which we have, but use it prudently. But don't ignore a lady who is coming with reduced fetal movements, and especially if it's recurrent reduced fetal movements, based upon the gestational age, based upon how you have stratified it, you might have to put in a surveillance strategy for her. FGR, as I said, I am not going to touch upon that. Twins, again, we have a monitoring strategy based upon the Dopplers. Here it's definitely important, especially for MCDA, because we know that TTTS, SNGR are very common. So again, here monitoring with Dopplers rather than your CTGs. Okay, so now moving on. So how frequently are you going to do it and when do you start? Okay, as I already spoke, evidence is not clear, but generally we tend to start by around 32 weeks. Unless there are multiple comorbidities, when we might have to, like that lady who had a severe preeclampsia at 30 weeks, you may want to start it a bit early. And the general recommendation is weekly, and maybe by 36 weeks you might want to step it up to twice weekly. But if there is multiple comorbidities, maybe even 2 to 3 times a week. So that is the recommendation. But the key question is, how are you going to manage an abnormal test? Because we already saw high false positive rates. So please take it with a pinch of salt. Look at the gestational age, look at the background. If it is related to hypertension, control the hypertension. If it's related to diabetes, control the diabetes. See if she has been given any medications. Take into consideration the whole clinical situation rather than jumping and delivering that baby, because you're probably going to do more damage to the mother and the baby by delivering her very early without a strong evidence to say that delivery is really needed. Way forward, yes, as I spoke earlier, computerized CTG seems to be revolutionizing the care. So hopefully it will become more easier, more available. Artificial intelligence, machine learning could come in, and maybe we will then have an ideal antenatal screening test which is customized to that lady. And this is something which has come up, something called as a CANID, where they are looking at multiple parameters, but we do not know. We just have to wait for more and more evidences to say what would be the best tool for screening for our lady. So in summary, I would say, please take all your surveillance strategies which I have spoken with a pinch of salt. Look at the whole clinical situation, because we do not have an ideal test. Ideal test, unfortunately, is not existing in the current situation. Barring a computerized ETG, if it is available, maybe it will be a game changer. Please balance the risk to the mother and the fetus. Think once, twice, thrice before you are going to put a knife on that lady and delivering the baby. Will delivery improve the long-term outcome for the mother and for the baby, not just the short-term? And as I said, ideal test would be to allow intervention before the damages happen, which we do not have. But as of now, computer CTG and Dopplers seem to be having a big role, and especially for Dopplers in FGR. In low-risk population, again, we don't have a data. And preferable is to always look at the basic disease process and allow the pregnancy to continue. So I would want to conclude by saying, I'm sorry if I have confused you more than giving you clarity, but unfortunately tests of fetal being are still not reliable. They need to be interpreted in the context of risk assessment. There is no single best performing test. We are living in a land of utopia if you are expecting a single best performing test. Management decisions still have to go back and take it with consensus based upon a combination of factors. Thank you very much.
Thanks a lot for this. Thank you.
I now request Shivamogga ma'am to present a moment of appreciation to Dr. Shimogga.
Thank you.
And protocols, but what I have realized over a period of time is evidence keeps changing, and we need to keep on updating. That means we need to keep on studying every day. So evidence changes, and what we were taught as a postgraduate there is completely, maybe totally reverse now. So what we have done so far may or may not be correct.
I now take this opportunity to introduce Dr. Sri Lakshmi, our next speaker, who is going to talk about fetal growth restriction, simplifying the understanding. As we all know, she is a prominent OBGYN specialist. She worked as the HOD in Shivamogga Medical College in the Department of OBG. After her fellowship in medical genetics, she has been actively working as the fetal medicine consultant in Malnad High-Tech Diagnostic Center. She has also been the past office bearer of Shimoga OBG Society, and she has given the Dr. Kamira Oration and the Dr. MG Hiramathira Oration. She has received the Foxy Imaging Science Award, and I'm very happy to share that this year she has won the Foxy Shrimati Sharda and Dr. Sadhana Gupta Leadership Award and Foxy Movie Call Award. Over to you, Dr. Sri Lakshmi.
Half an hour. And our laptop is helping us to run a little more. I have made FGR guidelines in American English by taking London guidelines. I have written fetus everywhere FETUS and cesarean as CE, and it's not.
For the next 15-20 minutes. So my lecture objective is how do you diagnose FGR? Once you diagnose as FGR, how do you monitor and how do you deliver? So what is our aim? There are only two aims when we have this FGR. First is correct diagnosis or the optimal diagnosis of FGR, number one. Number two, I want to press upon this point that there is no treatment, definite treatment in utero for FGR. What we are doing, the whole scenario is to buy a little time, safer time in utero so that we do a timely delivery in taking the risk risk that there is no stillbirth. So that is our main aim. So, there are three terminologies that I will be using for the next 20 minutes. First is appropriate for gestational age, that is AGA, that is fetal size between 10th and 90th centile. So, what do I mean by that is, see, there are 30 students in first standard and we make them sit from, in height wise, from first chair to the last chair. What is our aim? Because the last person is very tall, they are able to see the board, and first one is short and they are not able to see the board if we have put them in the last. But what it means, even the shortest person and the tallest person all are in the first standard only. It doesn't mean that the shortest will not get first rank. It may get a first rank, but he is short, he is normal, he is in first standard. So our aim is it the first bench of the first standard or does he belong lesser than that? That is our aim. So appropriate for gestational age means all people who are from first chair to the last chair, that is 10th centile to the 90th centile. Small for gestational age means first chair of first standard, that is fetal size is less than 10th centile but they are small. From a 40 kg women who have had a weight gain of 5 kg, we can expect a 2.5 kg baby only. We cannot keep on monitoring every day NST telling small, 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 because we cannot expect an elephant from a rat mother, correct? So that is the thing that is small for gestational age. But the third one, I have put it in a red. This is the take-home message. When there is no forward growth velocity in estimated fetal weight or abdominal circumference measurement at least 14 days apart, they are definitely FGR. So I repeat this, there is no forward growth velocity in the estimated fetal weight or abdominal circumference measurement at least, I repeat, this is 14 days apart. Today you do fetal well-being, tomorrow you do fetal BLE and then plot a growth chart and don't tell it has not grown 30 grams, 40 grams or no. It needs at least 14 days for correct interpretation. This is very important. This, if we don't explain the patient, they'll just come back after 3 days, just see whether the weight has increased. I have taken rest, I have just lied down on the left lateral. So static growth is no forward growth velocity. So fetal growth restriction. Fetal growth restriction definition and diagnosis is the abdominal circumference less than 3rd centile or 10th centile with Doppler abnormalities. Early onset is detected before 31 weeks, late onset is after 32 weeks. See, this is what I was telling you, evidence changes. When we were postgraduates, we were taught that this is symmetrical IUGR and asymmetrical IUGR, because symmetrical is all circumferences, that is head circumference AC and FL. If they are small and is early, then there is a symmetrical IUGR, thinking that the cause is different, this is intrinsic. And late onset IUGR may be because of placental insufficiency and we have Doppler changes. So this is just slightly different now, early onset and late onset. So when there is FGR, even in the early onset there can be placental insufficiency and there can be clinical, pathological and ultrasound characteristics. So it is a pathological growth restriction of the genetic growth potential. Some but not all growth restricted infants are SGA, and FGR is likely or higher in fetuses which are smaller. So when there is a SGA, be alert that you are also dealing with a case of FGR. So when there is FGR, there can be reduced amniotic fluid, there is abnormal Doppler indices. See, this we are thinking that FGR is because of placental insufficiency. So I repeat, if FGR is due to placental insufficiency, then only we will get Doppler abnormalities and amniotic fluid changes. If there is no Doppler changes and reduced amniotic fluid, but still if there is FGR, you are more alert because there can be intrinsic causes like genetic causes or aneuploidy which is causing and which may have more adverse outcome than this. But this has better outcome if we do close monitoring. So the challenge is differentiating between an FGR and a SGA. So how do we define or diagnose an FGR? This is by suspect by symphysofungal height. I still appreciate very senior obstetricians. They just call me up telling symphysofungal height is lesser and send for ultrasound. So this is for a low risk population, still symphysofungal height plays a role, and this is but by ultrasound measurements it is Delphi based consensus, that is AC and estimated fetal weight less than third centile and uterine artery or umbilical artery Dopplers are abnormal. So what are the surveillance tools? So I repeat again that why are we doing surveillance? We are just buying time for the timely delivery. If at all, if we diagnose an FGR by 36 weeks, there is no point surveillance. Keep on doing umbilical artery Doppler, CP ratio. They are less sensitive after 36 weeks. You have to take a decision for delivery at the earliest. But if it is between less than 36 weeks and more than 32 weeks, there is definitely role for surveillance, that is Doppler, cardiotocograph and biophysical profile. So all we are doing for two purposes. One is for timely delivery and to prevent IUD. Okay, so Doppler, what are the vessels that we insonate? All of us know that it is the first umbilical artery. So as Dr. Srimati told, umbilical artery Doppler or any Doppler is not a screening tool. It is not beneficial for a normal fetus. It is beneficial only for monitoring of FGR. This is a diagnostic tool, not a screening tool. So it is the primary surveillance is by umbilical artery Doppler, and if we have doing a screening for FGR in high risk fetuses, you go for a uterine artery Doppler at 20 to 24 weeks. And if umbilical artery Doppler is abnormal, then you insonate a middle cerebral artery, then you go for ductus venosus and aortic isthmus. So does it follow the same line, that is first change in the umbilical, then MCA, then go for a ductus? Yes, most of the times it changes. It is very, very unlikely that there will be a change in the MCA and normal umbilical. It cannot happen like that. The best example, okay. So umbilical artery Doppler. So once we do, see, we have to know only two numbers, that is pulsatility index or standard deviation. Pulsatility index and standard deviation. That pulsatility standard again, when we were postgraduates, we were using standard deviation less than 3 at less than 28 weeks, less than 2 at 32 weeks, and less than 1 after 32 weeks. So that is good enough actually. But now they have made it pulsatility index. We will take it as 1. But some infinity, 0, all these problems. So we take it as pulse. PI of 1. So once you insonate, I am sure all obstetricians who are doing regular ultrasound do agree with me that once you insonate an umbilical artery Doppler, by the sound only we can make out this is normal or abnormal. That sound itself is very, very reassuring. And once you insonate, you take the numbers. It is automatic in the machine itself, and if PI is is less than 1 or 1.2, you are very reassured. So don't go for MCA and get confused. Don't do middle cerebral artery if it is an appropriate gestational age and or small for gestational age, normal Leica, normal umbilical artery Doppler. Don't do MCA and get confused. Don't do uterine artery and get confused. This is enough. Everything is fine, and you ask them to come after 2 weeks. Yeah. Okay, now when to do a middle cerebral artery. So the best example that can be given is in Mahabharata when Kunti got very less food. So she knew Bhima wanted the highest. He was very hungry, he was well built. The other 4 wanted less. So what she did, she divided the food into 2 parts, and one she gave it to Bhima, other 4 she divided into, the other part she divided into 4. So that the same thing that is happening in the FGR. So in the FGR, when the blood is less, what has to happen? The preferential organs should get normal blood flow. It cannot have a compromise. So brain and the heart, they won't get compromised till end. So that is what is happening in the middle cerebral artery. If it is normal, umbilical artery is abnormal. That means to say that there is a brain sparing effect. That is, brain is getting enough blood. There we have still more time to buy in utero. That's it. But if it is really less, then what happens? There is no other growth. Brain starts getting lesser blood flow, and that is where we have to take a decision for delivery. That is, in utero environment is no more safer. We have to deliver them. So this is we all want very easy, because in busy OPD we want to interpret. So this CP ratio is formed. It just means that MCA PI divided by umbilical PI. It is telling that brain is getting preferential blood flow. It is 1. 1 is the best number that can be given for the FGR. So is the ductus venosus. So when there is blood flow is compromising, the last one is going for the ductus venosus and for the umbilical vein. Heba sir has done one thesis on umbilical vein Doppler. We used to do Doppler of the umbilical vein vessels also. So when there is a compromise in the ductus venosus and umbilical vein, the prognosis is weaker, longer NICU admission, and most importantly, what neonatologists do is, when there is ductus venosus abnormal Doppler, there is compromised blood flow to the small intestine, so they make it parenteral nutrition and avoid oral feeds for a longer time, because there is compromised blood supply to the bowel, and they may go for a necrotizing enterocolitis. This is a very important point. And yes. So what is the role of the uterine artery Doppler? This is for screening for FGR. So if in the booking visit, I'll just show you the risk charting in RCOG guideline. Whenever we take a history at the booking and throughout the pregnancy, we categorize the pregnancy into low risk, moderate risk, and the high risk. And high risk population are the one wherein that means they are at high risk for FGR. So first blood flow to compromise is at the uterine artery at 20 to 24 weeks. So we want to detect it early. So this is for screening for FGR. What is the use of it? Maybe if we detect early very high PI, we can start aspirin 150 milligram. So prevention, most of the times it is not possible to prevent unless there are modifiable risk factors for FGR. For example, smoking, obesity, or previous FGR or previous preeclampsia. So in certain cases we think of it. Prediction is what is the FGR. So this is one slide, very important. Which pregnancies of FGR should be further investigated? See, I stress upon a point. This is further investigation. Doppler is not further investigation. Doppler is surveillance tool to give us a time when to deliver, what is the prognosis. But this is what is the cause of FGR. So if there is FGR, if estimated fetal weight is less than third centile at anomaly scan with no obvious structural abnormalities, is a definitive indication for invasive testing and to rule out aneuploidy. What test you are doing? We have to do microarray. There is no need for single gene testing unless there is a specific indication. So should we do torch screening? Yes. In a high risk population, if we are suspecting CMV, we have to do a serological screening, but mind you, we have to interpret it correctly. CMV IgG positive, don't terminate the pregnancy. CMV avidity testing should be positive. That means there should be rise of IgG in 4 weeks time to more than 2 times. And how about malaria and Zika? High risk population, go for it. Okay. So there is no role for any interventions. And how to monitor and delivery: ultrasound biometry and umbilical artery Dopplers. Okay, so postnatal investigations and pre-pregnancy counseling, histopathological examination of placenta is useful, and if you are thinking there can be APLA, it is worth doing testing. So let me summarize what I have spoken so far. Differentiation of SGA and FGR is important. Monitoring of FGR is to buy time, as period of gestation is more important predictor than estimated fetal weight. Other high-risk factors also contribute for the intact survival. See, many a times I feel we are converting IUD into neonatal death. Okay, so very severe IUGR, IVF pregnancy, 40 years, married life 20 years, and at 28 weeks baby is only 600 gram, and there is reversal of end diastolic flow. So you are also helpless. So you may convert an IUD into neonatal death, but more concerning is neonatal death is at least okay, but if there are long-term neurodevelopmental delay, then it is very, very unfortunate. So although we do recommend, all guidelines do recommend for induction of labor, we should be prepared for unplanned cesarean or emergency cesarean. Extreme preterm, severe IUGR, we may convert an IUD into neonatal death and delayed milestones. Doppler is definitely a useful tool and is for diagnosis and for monitoring. Useful to buy time for delivery and appropriate place for delivery. In utero transfer may be very essential. Less useful after 36 weeks. Not useful for other causes of FGR other than placental insufficiency. Not useful to detect a cascade. There can be sudden placental abruption. We may not be able to take it. CTG, yes, useful. Ma'am has I have spoken in detail. This is very important. If there is reduced or absent fetal movements in ultrasound, definitely it warrants further investigation. So what we are doing, everything is, the whole exercise is to prevent, to buy time in utero, to go for a safer delivery, and to prevent IUD. Yes. Thank you so much.
Thank you, Srimati, for the excellent talk. And also at this gesture, we want to thank you for the opportunities given to us, myself and Dr. Swati.
Thank you. Yes.
And
thank you. To give memento for both Dr. Swati and Mugi ma'am.
After the brainstorming session 1, let us move on to the keynote address. I first welcome the chairpersons onto the dais, Dr. Nagaraj H. So please come to the dais, Dr. Lata Venkatraman ma'am and Dr. Veena Bhatt ma'am. National and state OBG levels. Hearty welcome to you, sir. Dr. Lata Venkatraman ma'am has come all the way from Bangalore. She is the founder director of WMN Healthcare Services Private Limited. I heartily welcome you, ma'am, to this function. Dr. Veena Bhatt ma'am is the president of Shimoga OBG Society. I extend a warm welcome to you, ma'am. So we now have the keynote address by the most well-learned and humble Dr. Prahalad Kushtagi sir. He'll be talking on an overview of perinatal loss, concerns and considerations. I request the chairpersons to moderate. At the state and national levels, he has humbly refused to give his biodata, but he is well known. So over to you, sir.
So, to every one of you, I do wish. I have been asked to come here and give an overview. I think Dr. Raksha began with an opening sentence. That was enough for the overview to be given. And I should thank Dr. Sri Lakshmi for asking me to come over here, despite having told that I am retired and I don't need to come and talk to you. When we look into the improving the perinatal outcome, that itself makes one to look into what are you doing. That means, are we satisfied that the perinatal outcome has already improved? Then there's nothing much to speak to. And then probably it's already, we have just gone through 3 lectures wherein we already said that what are all the various tools that are available and how we can go about trying to improve, if it is not yet improved, the perinatal outcome. So one can look into 2 aspects of it when you say improving the perinatal outcome, whether what are the impacts or the importance of improving the perinatal outcome, and second, what is the perinatal outcome. So as far as the impact of it or importance of improving the perinatal outcome is concerned, I need not look into how all it will help us, probably either improving the maternal health or the neonatal health or at large to the society. That is all known, and probably I need not be talking about it. But coming to the perinatal outcome part of it, what I thought is I will try to look into what defines perinatal outcome and then try to give a situational analysis as an outsider. Now I am a layman. I am no more practicing obstetrics and gynecology. I have laid down the speculum about 5 years ago. So is the pen and also the scalpel. So probably what exactly is available as of now. And then was I associated when trying to bring down the perinatal or improve the perinatal outcome during the course when I was practicing, and then try to conclude it if possible, if the time permits. As you all know, the perinatal period is the one that starts from the period of viability in the prenatal life till a week after the delivery. And this perinatal loss, the perinatal period, and then the loss that occurs during the perinatal period, that can include stillbirths, that can have during the antenatal period or the intranatal period. I try to use, because usually I am used to speak of intrapartum, I stuck to intranatal because improving perinatal outcome is the theme of the day. So it could be before labor or after the onset of labor. And then when we look at this, the antenatal one, when you say from the period of viability, that varies from different regions. And then why I wanted to put that across is, when we say that, okay, so and so has achieved, let's say, the ones that had taken 20 weeks as the period of viability, and then the perinatal mortality rate there is around 3.5 to 4 per 1,000 births. Then if you want to go into that, and if I also say that at 28 weeks, if I am taking that as a period of viability, then can that, even if we get it in our states, the 3.5 as per 1,000 as the mortality, then can we say that we have reached to that level? So you'll have to look into this aspect, that is 20 weeks. They have taken 20 weeks as the denominator, and then for 28 weeks, if the 20 weekers were to come, would we have achieved that? Probably that has to be there whenever we interpret only the numbers. That is what is the perinatal mortality rate. Of course, we know that we, India, like various the other WHO, though we have been saying that we are already developed country, right? So, but still we continue with the 28 weeks as the start point of the stillbirth. And in coming to early neonatal deaths, it is the death of live born that dies within first 7 days of life, and then most of the 75% of the neonatal deaths are in the early period. If you take 1 month as the neonatal period, that is 75% of the babies die in the first 1 week. And the most causes that have been already put up is the preterm. Maybe when someone says, I think Sri Lakshmi said that we are transferring IUGR into a early neonatal death. Right? Then the intranatal issues will be there, and then also the infection that is more prominent in our part of the world. These early neonatal deaths are certainly showing a decline, but what is to be looked into is the right-hand side of the panel, wherein you will find that the proportion of the cases with the early neonatal death is expanding. That is, when compared to the overall child mortality, that is nearly going to 50% is accounted by the early neonatal deaths. So probably we need to address to this aspect. Are the obstetricians responsible for this? That we'll have to be keeping it in mind, because the index of healthcare is dependent on that. And then we all know the perinatal mortality is calculated. And then what we have found is, over the years, globally as well as in India, the perinatal mortality has been showing a decline. Probably that's, as the second speaker said, there is always a silver line on the cloud, so that is that. And what we have found is, in India, the decline is quite sharp. That is 70% fall from the earlier perinatal mortality in 1990, that is when the Alma Ata declaration began, to what it was in 2023 is 70% decline from the perinatal mortality rate. When compared to the global one is more or less saying it is only around 50% fall from what it was earlier. Then again here we'll have to take into account of what I tried to tell, that is the time that we take for the period of viability in classifying the perinatal death. The overall PNMR is decreasing, that we have said, and then the early neonatal mortality is much higher than the stillbirth rate, and then of these stillbirths, most of them occur in the third trimester. What do we do? Of these early neonatal, that is the antepartum or antenatal deaths. Okay. These early neonatal deaths, the fall in early neonatal deaths is much more than the stillbirth rates over the period of time, because stillbirth rate has remained static. And then the 90% of the stillbirths are antenatal. And then again, earlier someone said 60 to 70%, probably I stand to be corrected. And then of these stillbirths, and 2/3 of them are in preterm babies. And it is seen that more often it is in the low and mid-income group countries than in the high income group countries. So how do should I touch to change the slide? Shall I?
Down slide.
Alla muttidre hoguttalla. So this fall, that is when you compare this, that is under 5 mortality, infant mortality, and then the neonatal mortality. Neonatal mortality rate, that is the trend that is showing, is almost static. It is coming down, but it is not that obvious when compared to under 5 one. So this was like when the Alma Ata declaration came, neonatal mortality was around 37. The objective was to bring it down by 2020. That 2000, sorry. So that we have passed a long time back. It is around nearly 2.5 decades now. So even by 2015, when the Millennium Development Goals came, they didn't set up the number because they said that it is not possible to reach the target. So then they said, okay, we should bring it down by 2/3 of what it was in 1990. So with that, it came, so even then it was most of the countries, though the global under 5 mortality came down, the rest of the mortalities and most of the countries could not stick to that. Then of course, probably when they had to change their strategy, then what we have seen that whatever the fall that has been occurring is not uniform. It is again skewed. Maybe there are some countries that have got a single-digit perinatal mortality, and then there are even the 10 times more than that, like 30, 35 in different parts of the world. This just I wanted to tell that when the Alma Ata declaration came, one of the things that was set was by 2000 you have to have 30 to 35 as the mortality rate, but it was achieved at that time in the early 90s itself. In this part of the world is that it had come to 17.5. Of course, there are skewing. That's what I was trying to tell is that it is not uniform. When we say that the country has got this as the mortality rate, it is not uniform. So here what I have tried to put is this is again from the family health surveys 3 to 5. What they have looked into is in the left-hand panel, you will see that this is a percentage fall in the perinatal mortality rate has occurred over the years. That is over the 3 surveys. And on the right-hand side is the PNMR map of India. So you see it is so colorful. So it ranges from less than 10, single-digit approaches are also there. And then again there are few that have gone to 50 to 57 deaths per 1,000 deliveries. So it is so wide is the and for that, then we thought, do we have such a differentiation? It's only between the states or within the state? In the state also, if we look into, let us say, if we have in Karnataka, Dakshin Kannada as the one with the low perinatal mortality rate, and on the, let's say, Koppal, that again, Kustigi is from Koppal, and then that district, that has got a high perinatal mortality rate. Do we learn anything from analyzing the cause for the perinatal death? Of course, it just resulted in some patents and then some publications to be done from the survey that we did as an ICMR this thing. So what came out, or maybe when we tried to look in South Asia, wherein we compared Indian and Pakistani stillbirth analysis. So what it came out, there are causes that are risk factors that are attributable from the maternal point of view, than from the fetal, and then again socio-demographic one, when the elderly women with a higher body weight and then with access to poor antenatal care and then of their low shopping status, and of course not to leave out the smoking and drug abuse, they are also quite common in India and also in Pakistan. So these are all the factors that are contributing to the higher perinatal mortality rate in different parts of the region. So what one comes out is again the causes for the stillbirths and its contribution to perinatal death. So if you look at the causes, it again says that who is who of the contents page of any obstetrics book. So what one finds in any of these surveys, that is the population-based surveys, is making it available. That is, availability of the services. Are they available? If they are available, are they accepted? And then if they are accepted, are they aware that the facility is there and then they can take that help? And then the adequacy of the staff at those facilities. These are the main drawbacks that are found most often. Then these causes, whenever we look into, most of these have occurred after 37 weeks of the pregnancy. Probably that might put in a thought in the mind, or maybe that is it that okay, by 37 we should be ready to welcome the baby. Maybe 37 means not exactly at 37, maybe after that you are more vigilant, probably whatever the tools that you people talked about in the earlier 3 deliberations, probably they can be more intently put into practice. And then of the various causes that one tried to look into, wherein even it was more meticulous test, the analysis was done for the stillbirths when the South Asian women, the study was conducted. Again, Akhila was part of the team. She is, the people from Manipal would know about her. The 33% had no etiology. So the unknown etiology remains. So again, for that, probably we will not be able to do much unless we get to know into what is that unknown, is it possible to know the unknown from the unknown. And on the placental issues, here the study involved the submitting the placenta for histopathology, and there were stringent guidelines that were taken from the pathologists and then the perinatologists, and then that looked into. But most of them, that is 1/3 of the cases, had placental cause as the cause for the stillbirth, and then of course the rest of it was made up by anomalies, the cord related issues, and then the infections. Prematurity was the most of these other causes. Then what emerged out of it, or what will emerge at any time, is that antenatal care is a modifiable risk factor for stillbirths. Having said that, when in the earlier 3 lectures we did talk about the attributing or getting a woman that is the labeling as the particular pregnancy to be at risk. That at-risk approach has been going on since even when I was an undergraduate. We were talking about at-risk approach for the antenatal care in the community medicine classes. So what is that at-risk? In a pregnancy, when a woman comes to pregnancy, we need to look for, is this particular pregnancy at risk for a placental dysfunction? Probably in a generalistic view, if I can put it, what the definition of placental dysfunction is, it would be trying to find out a needle in a haystack. It is very difficult to explain, but again, it is there, and it is more often it is attributed to. And then we did talk about what are the various risk factors. I'm talking about the old ones that were present, given on the textbooks. Afterwards, we did talk about, or we were a witness to where the different bundles are there for even the hypertension, or be it the growth restriction, or the diabetes, or any risk factor that you take into consideration. You have got a bundle of care that is available, so that at-risk approach would, to some extent, can come down. And then again, these bundles were talked about quite well earlier, so I do not want to go into the details of it. Then again, each one has got a different risk stratification tools that are available. Then we will go into that last 5 or 6 centimeter of our first journey. That is the intrapartum care. That is about the antepartum. That's why I have tried to put it in a pelvis there, and I put in this thing. The earlier I had put in a gravidogram there. Right? So here the objective of an obstetrician is that the woman comes in labor. Is this labor at risk of developing distress or the birth asphyxia? There it was placental dysfunction. Here it is this. So objectives are simple, but the thing is tools are too complicated. When one tried to look into the risk, risk recognition, one finds that it is on 50% of the times one is not able to identify the risk, and then the lack of situational awareness, especially in South Asian countries, was quite high. It is nearly 50%. And then amongst us, there is a poor communication, maybe while referring to the other person or the other facility, or within the unit, the person changing over from the day to the night shift, again the communication fails. between the doctor and then the nursing staff, and then between the obstetrician and then the neonatologist, between the obstetrician and then the anesthesiologist. There is a communication gap. That is again a significant mighty, that is nearly 40 to 45%. So these are there, probably these need to be addressed to, rather than just talking about the other aspects of the individual, the academic causes of the stillbirth. So what one has found, that is in most of these field studies, is that what the significant factors is the pregnancies more often than not were unsupervised, came with an uncertain gestational length, and were at labor admissions, with some of them with pre-labor rupture of membranes. These were the 4 problems that one needed to address. So the question one needs to ask when a woman is there or when you are attending to a call is that, is the gestational age known? And then second, is the labor at risk? So these are the 2 questions. First, coming to the gestational age, known or not. Of course, we were taught that 37 to 42 weeks is the term. Is the term negotiable? That we need to look into. What has one seen that over the spread of 37 to 42 weeks, if one looks into, the perinatal outcome is quite variable. It changes from week to week. So maybe that is the one that made one to substratify the term into early, full, and then the late term by Sponget sometime back in early 2010s. And then of course it was made a mention that the Asian women, the fetuses mature much earlier. Again, probably one has to have in their own region of practice what could be is it possible to fix that, what is the duration of rupture, the duration of pregnancy, human pregnancy is not that the 280 days, but it might be much earlier. We have found that maybe our women, our fetuses mature about a week early. So when we have said that women, nearly 50% of the times the labor admissions are there, they are with the uncertain gestational length, and then they would be more often than not, they would be coming with pre-labor rupture of membranes. In that event, when that is the middle one, that is the gestational length is at this thing, and then the nearly South Asia and then Sub-Saharan, that is 60% of these are preterm entries. In that event, is it possible to find out or forecast the lung maturity in them? You might not be able to give the date the pregnancy at that stage, but is it possible to know whether do we need to be prepared with the surfactants to be given to them the moment the baby is born? Should the nursery be ready with ready to welcome those babies? So what we had put it in, I have not gone into the other various bundles and then their risk classification. Just for an example, I have just put it from one of the textbooks. These antenatal risk factors, if they are there, they are at risk. Then probably at risk, maybe you can take any of those labor surveillance tools, whether do you like, for example, if you take CTG, you would like to put in a continuous CTG, or is it an intermittent auscultation that you would go? If that is going to guide you that, then is it sufficient? So do we just recheck what was given the risk stratification, or do we need to, because what was found is, again it was mentioned that intrapartal fetal morbidity is not uncommon even in low risk pregnancies. And then the FHR changes that would occur in labor and also the fetal acidosis were almost equally poised between the low risk pregnancies and then the high risk pregnancies. Then probably not only recheck it, probably we might have to revise the admission risk factors. For that again various labor admission tools are available. I would not like to go into the details of it. Could it be admission CTG of 1 hour or a half an hour, whatever that you want to take it, or maybe the admission AFI that yesterday we were talking about, and then the sonofuniculogram, wherein you would say the coiling of the umbilical cord or the length of the umbilical cord, whatever that you want to look into, or even the rapid BPP, the people have tried to use it as an admission risk screening. Then apart from that, during the course of the labor, there could be some factors that are emanating, maybe the induction that one has taken, or maybe the various other factors that are already listed here. Oxytocin augmentation is given, or epidural is being practiced in that particular labor. These are all going to add in the course of labor to the risk status, as Jyoti was telling, that it is the risk stratification or triaging is going to be a dynamic one. It is not that once it is done with. So the various tools that are been already talked about, I don't intend going into the various surveillance tools that you have in labor. And maybe I will just touch upon before going that continuous CTG that we were talking about. And then what has said that, of course, they have brought down the proportion of cases with neonatal seizures, but the perinatal death or the cerebral palsy has not shown any change. And apart from that, there is increased operative and instrumental deliveries. And it's one of my friend who he is an RCOG chair, so he had brought out the analysis of the CTGs, and he said 20% of change that is, if it is given to the different peers, then 20% change their own interpretation that I had done earlier, and 25% disagree with what the interpretation was done by the colleague, and then these interpretations vary with the type of the pattern that you are given to. So that is, there is a subjectivity as far as the CTG reading is concerned. So how much importance to be added to the earlier, it has already been addressed to. So then, of course, the computerized CTG, can it be used to bring in some objectivity or subjectivity? Probably it is Dave's and Redmond's criteria are antenatal ones. Can they be extrapolated to the intrapartum? I do not know. And then again, what is said about them is that these will fail to identify the acute events. And then the overweight or the increased BMI or polyhydramnias may come in the way of the interpretation by the computerized this thing. Then of course, if one says that the internal monitoring might be better, then again, you know that the list of the problems that we have. And then you have got again the various bundles of care, even for the safer births that we have already talked about. I just wanted to tell that the innovations are required for training and for the clinical care, and also this particular intervention, and then one should have exercises for the continuous of the quality improvement, and then the infrastructure and then the competence should be sustained. That is improving the competence. And at the end of it, what we need is for the safer delivery of those initial 5 to 6 centimeters of our life journey is to ensure a skilled attendance and manage high-risk pregnancies, and then they provide a quality care. Not only that, we stop only at that. Probably we need to carry it in case the stillbirth occurs. Probably there should be a bereavement support as part of the care, and when the causal analysis is carried out, I think Sri Lakshmi will be talking about the analysis of the stillbirths later. So there it is always better to have the aggrieved party also on the panel, so that we will be able to interact best, and then we will be able to pass on the information whenever it can occur to someone else. So as it said that the light at the end of the day, parental mortality is declining. It is showing a declining trend. Early neonatal birth is slower fall when compared to the post-neonatal deaths, and then the stillbirth rate fall is much slower. Probably the drivers for this decline are, there is an increased access over the period of time. I'm talking about over the last 3 decades. And then there is an improvement in the quality of healthcare, the way the people are talking about what are all the various evidences and the things like that. That means the concern is there. And then there are socio-economic improvements. But the progress is uneven, that we have already seen. The challenges are still there if you need to progress to the single digits perinatal mortality rate. Probably they are not much. in that, but again, these are the ones that you see if we try to group ourselves in the low and mid-income countries, the birth asphyxia can be taken care of, and the sepsis can be addressed too. So since these can be done, probably time is not far when we will be again going into the same perinatal mortality rate as the high income group countries have. So since we could not meet the Millennium Development Goals, then they came up with the WHO Sustainable Development Goals, and that by 2030 we'll be reaching the 12 and 12 for neonatal deaths and then the stillbirths per 1,000 births. Okay, this I already talked about. The preventability is there. Probably we'll be able to prevent most of these deaths that are occurring with us. And then they need to bring out the awareness, because these are all the outcome of the studies that we had carried out earlier. Awareness is faulty, accessibility is not much, and then the awareness about the availability is also poor, and the sustainability is, again, it is not uniform. Maybe the government changes and then the funds come down and then it is not sustained. And then one more thing that I just wanted to add, whenever we went in for analysis, for example, if I'm in a rural area or if I'm from a low income group, that is a area with a high perinatal mortality, one would just say it is not a preventable death, because the death tools that we had brought up, we are supposed to give whether it is a preventable death or not. I, as a certifying officer, I will not write it as a preventable, because I will be questioned. We'll just write it as not preventable. So probably we need to bring in that integrity within ourselves. So these are the lessons that are learned. Probably if they are inculcated, probably days are not far when you would go in for attaining in that, and this cradle will not remain empty and every child will come. Have I overshot the time?
No, sir.
Do I have a time?
Yes.
If I have a time, so I thought I will just read out 2 lines that I have written it in Kannada. Hope any one of you understand Kannada? ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗಾಕಂತ, ಕುಂಚಿ ಕುಲಾವಿ ಹಚ್ಚಿದ್ದು ತೊಡಸೋಕಂತ, ಕೂಸ ನೆತ್ತೋ ಕನಸ ಕಂಡದ್ದು ಆಡಿಸೋಕಂತ, ಜಂತಿಗೆ ಕಟ್ಟಿದ್ದು ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗಾಕಂತ, ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗಾಕಂತ. ಆಡಿ ಕುಂಟು ಬಿಲ್ಲಿ ಆಟ, ಹಿಯರ್ ಐ ಆಮ್ ಟಾಕಿಂಗ್ ಅಬೌಟ್ ಇಂಟರ್ಪ್ಲೇ ಆಫ್ ದಿ ವೇರಿಯಸ್ ಹಾರ್ಮೋನ್ಸ್. ಆಡಿ ಕುಂಟು ಬಿಲ್ಲಿ ಆಟ ಚೋದ ಖಂಡಗಳ ಮತ್ತ ತಿವುದು. ವಿಲ್ ಹ್ಯಾವ್ ದಿ releasing hormones and then the stimulating hormones coming in something. They will stimulate and then they coming back. Rutuvannu tandu hiditaka, the regularization of the periods, and then the jeeviya kosha mooditanta, zygote is formed. ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗಾಕಂತ. ಎರಡು ಒಂದಾಗಿ, ನಾವು ದ ಡಿವಿಷನ್ ಅಕಸ್, 2 ಒಂದಾಗಿ, ಮತ್ತೆರಡು 4 ಆಗಿ, 8 16 ಆಗಿ, ಹಿಗ್ಗಿ ನಡುವ ಮೂಡಿ, ಯು ಗೆಟ್ ಎ ಕ್ಯಾವಿಟಿ ದೇರ್, ಗರ್ಭ ಸೇರಿತ್ತಂತ ಬೆಳೆಯಾಕಂತ. ದಟ್ ಈಸ್ ಅ ಬ್ಲಾಸ್ಟೋಸಿಸ್ ಸ್ಟೇಜ್. ದೆನ್ ಇಟ್ ಗೋಸ್ ಇನ್ ಫಾರ್ ಇಂಪ್ಲಾಂಟೇಷನ್. ಗರ್ಭ ಸೇರಿತ್ತಂತ ಬೆಳೆಯಾಕಂತ, ಮುಂದೆ ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗಾಕಂತ. ಬೆಳೀತಿರಲು ಶುಕ್ಲ ಚಂದಿರನಾಂಗ, ಸಾರಿ ಅದು ಶುಕ್ರ ಅಂತ ಬಂದಿದೆ, ಶುಕ್ಲ ಚಂದಿರನಾಂಗ, ಶುಕ್ಲ ಪಕ್ಷದ ಚಂದಿರನಾಂಗ ಬೆಳೀತಿರುತ್ತೆ ಮಗು. ಆವಾಗ ಯಾಕೆ ವಕ್ರಿಸಿ ಬಂತೋ ಹಿಂಗೆ, ದಟ್ ಈಸ್ ಏನು ಆಗಿತ್ತು ತಿಂಗಳ 8ರ ಮೊದಲ ಅರ್ಲಿ FGR, ಮತ್ತು ಆಮೇಲೆ ಬೆಳೆದೇನು ನಿಂತ ಲೇಟ್ FGR. ಏನು ಆಗಿತ್ತು ತಿಂಗಳ 8ರ ಮೊದಲ ಮತ್ತು ಆಮೇಲೆ ಬೆಳೆದೇನ ನಿಂತ, ತೊಟ್ಟಿಲು ಕಟ್ಟಿದ್ದು ತೂಗಿ ತೂಗಾಕಂತ. ಕೈ ಕಾಲು ನಿಂತಿತ್ತ ಒದಿಯದ ಹಂಗೆ, ಹಿಯರ್ ವಿ ಆರ್ ಟಾಕಿಂಗ್ ಅಬೌಟ್ ದ ಮಾನಿಟ್ರಿಂಗ್. ಕೈ ಕಾಲು ನಿಂತಿತ್ತ ಒದಿಯದ ಹಂಗೆ, ಎದಿ ಬಡತ ಏರಿಳಿದು ಉಸಿರು ಗಟ್ಟಿಸಿತ್ತ. ಇಟ್ಸ್ ಅಬೌಟ್ FHR. ತಾಯಿ ಎದಿ ಬತ್ತಿ ಹೊಟ್ಟಿ ಒಳಗಿಳಿದಿತ್ತ, ಸಣ್ಣ ಜೀವದ ಜೀವ ಹಾರಿ ಹೋಗಿತ್ತ, ತೊಟ್ಟಿಲು ತೂಗಿ ತೂಗದಂತ. ಹರ್ಷ ತುಂಬಿದ್ದಲ್ಲಿ ಮಸಣ ಬಂದಿಳಿದಿತ್ತ, ಬಾಡಿ ಮುಖವೆಲ್ಲರ ಮುರುಟಿ ಹೋಗಿತ್ತ. ಸರಿಯಲ್ಲ ನೋಡ ಕಣ್ಣಿಗೆ ಸುಣ್ಣ ಬಳದ್ರ ಹಿಂಗ, ಮೂಡಿದ್ದ ಜೀವ ಬೆಳೆದು ಬೆಳಗಲೇಬೇಕ, ತೊಟ್ಟಿಲು ಖಾಲಿರದ ತೂಗುತ್ತಿರಬೇಕ. ಹಿಯರ್ ಐ ಆಮ್ ಟಾಕಿಂಗ್ ಅಬೌಟ್ ಸ್ಟಿಲ್ ಬರ್ತ್ ಅಂಡ್ ಅರ್ಲಿ neonatal deaths. ಸತ್ತು ಹುಟ್ಟಿದರಷ್ಟ, ಹುಟ್ಟಿ ಸತ್ತರು ಅಷ್ಟ, ಹದಗೆಟ್ಟ ನೋಡು ಪರಿಲಕ್ಷಣವು ನೋಡ ಅಳಿ ಸಾಕ ಬೇಕ ಈ ಕಪ್ಪ ಚುಕ್ಕಿ ಹಾಕು ಆಣೀನ ನೀನು ತಡಿತೀನಿ ಅಂತ ನೆನಪಿರಲಿ. ತೊಟ್ಟೀಲು ಕಟ್ಟಿದ್ದು ತೂಗಾಕಂತ, ಕಟ್ಟಿದ್ದು ಕಟ್ಟೀಲು ತೂಗಾಕಂತ. ಐ ಥಾಟ್ ಇಟ್ ವಿಲ್ ಸಮರೈಸ್ ವಾಟ್ ಐ ಟ್ರೈ ಟು ಸ್ಪೀಕ್ ಅಬೌಟ್.
Thank you very much for the opportunity. We had a wonderful lecture by Dr. Study. He has given the overview of the perinatal outcome. The desire of all the applicants to have improved perinatal outcome, but we need to audit all the process as they are living in Kerala. We need to audit and improvise ourselves for the better outcome of the perinatal outcome. Thank you very much.
Well said.
He is the first speaker. Then Shimoga Society was born. He gave a lecture.
Whether abnormal uterine bleeding or hyperemesis.
Hyperemesis driver. He is the first person to deliver.
Because I was in an early state of pregnancy at that time.
He delivered first donation of Malay Memorial Donation. He is the first speaker. We are very happy that he has come again for the Shivamogga. Thank you, Mr.
Thank you very much, sir. As Nagraj sir told, it was a very good presentation, and incidentally we are celebrating our 25th anniversary of SOCS also. So you are coming again on for the Rajata Mahotsava also.
And I was in the neighboring district.
At the end, the song was really good, sir. ನನಗೆ ಯಾವಾಗಲೂ ನೆನಪಾಗೋದು ಸೂರಂ ಮೆಕ್ಕುಂಡಿ ಅವರದ್ದು ಒಂದು ಕವನ ಇದೆ. ಗುಡಿಗೆ ಹೊರಟ ಹಾದಿಯಲ್ಲಿ ಹೆಜ್ಜೆಗೊಂದು ಹೂವಿದೆ, ಪುಣ್ಯ ಪಯಣ ಸಾಗುವಲ್ಲಿ ನಿಮಿಷಕ್ಕೊಂದು ನೋವಿದೆ ಅನ್ನೋ ಹಾಗೆ ಹೆಣ್ಣಿನ ಜೀವನ ಅಂದರೆ ಯಾವಾಗಲೂ ಕಷ್ಟದ್ದೇ. ನೋವು ನಲಿವು ಎರಡನ್ನು ಸಮತೋಲನಗೊಳಿಸೋದೆ ಜೀವನ ಅಂತ ಸರ್ ತುಂಬ ಚೆನ್ನಾಗಿ ಹೇಳಿದ್ರಿ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
I think we should never lose the lesson. I think that is the gist of the whole keynote address on improving perinatal outcomes. I now request the chairpersons to hand over a token of appreciation to Dr. Prahlad sir. I also request Dr. Prahlad sir to hand over the mementos to our chairpersons, Dr. Nagraj sir, Dr. Lata ma'am and Dr. Veena Bhatt. Sir, please. Sir. Thank you so much. We'll have a short inauguration program, stage program. So kindly give us 2 minutes to get the stage ready for the same. Program. I invite onto the dais our very own Dr. Sri Lakshmi ma'am, known as an academician of very high caliber, heading the fetal medicine and genetics division at Malnad High-Tech Diagnostic Center, and who has been very instrumental in planning and arranging this CME. I extend a warm welcome to you, Dr. Sri Lakshmi ma'am. It's my pleasure to invite onto the dais Chairman and Director of Malnad High-Tech Diagnostic Center, Dr. S.I. Biradar sir. I extend a warm welcome to you, sir. I I also heartily welcome our founder president of OBG Society, Dr. Nagaraj H. Sir, onto the dais. We have distinguished very senior speakers from the state, Dr. Prahalad Kushtagi sir and Dr. Lata Venkatraman ma'am. I extend a warm welcome to you to the dais. Please sir and ma'am. I also welcome the president of Shimoga OBG Society, Dr. Veena Bhatt ma'am, onto the dais. So please sit down. It's my pleasure to heartily welcome everyone gathered here for the second annual CME from the Division of Fetal Medicine and Genetics conducted by Malnad High-Tech Diagnostic Center in association with Shimoga Obstetric and Gynec Society. I extend a warm welcome to all the dignitaries on the dais, the invited guest speakers of today, and members of the OBG Society, and my dear colleagues to this esteemed gathering. Before starting the inauguration, as you all are aware, it's very sad to note that we have lost our dear colleague, Dr. Jayashree Homareddy ma'am, 2 days back, a very unfortunate incident. And we pray that God gives, the Almighty gives strength to her family to bear with this loss. And we have also lost a great doyen, professor and researcher in the field of obstetrics and gynecology, Dr. Professor Tim Draycott, who recently passed away on the 24th November. So I kindly request everyone to stand for a minute of silence, praying for them. Thank you, everyone. I request you to be kindly seated. For the benefit of the audience, Professor Tim Draycott, he was a senior obstetrician and researcher at Bristol South Mid Hospital, and he had a profound effect and he helped countless births. He championed the idea that good outcomes happen when teams, that is doctors, nurses, and support staff work and train together. He has left a profound and enduring legacy through PROMPT, which is a pioneering training program for midwives designed to help them respond swiftly to signs of fetal distress during childbirth. I request Dr. Lata Venkatraman ma'am, who has seen Professor Draycott's work from close, to share a few insights about his work.
The great sadness, we remember Tim Draycott, who is no longer with us. He was such an inspiring and a very jovial person who taught or imparted skills through PROMPT course to a large, a large number of doctors, midwives, and other staff world over. It was a privilege to meet him, and we wanted to, on few occasions, and we wanted to bring PROMPT to India, and we were in the process through Mrs. Janhavi Nilekani, but unfortunately he is no longer with us. So we'll have to see how to bring PROMPT into our country, which will make an enormous difference in skills and drills training in India. And it would definitely save many more lives. Tim loved India, and India loved Tim, and he has contributed greatly to the field of obstetrics and gynecology, a man full of ideas. He welcomed ideas, and he was such a simple and humble person who will remain in our hearts forever. Thank you. Hari Om.
Thank you, ma'am. In the right light, at the right time, everything is extraordinary. I now request the dignitaries on the dais to light the lamp and inaugurate the CME.
Right after class 12, we are taking a package 20% placement secured career.
Shubham karoti kalyanam arogyam dhana sampada shatru buddhi vinashaya deepajyoti namostute divya divyare deepatkar kani kundala motihar divyala pahun namaskar tirache tel kapsachi vaat diva deve deva pashi उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतां पाशी ये ग लक्ष्मी बैस ग वादे माझं घर तुझ्या साथे घराची गिळाबिळा वाटे.
I thank the dignitaries for the inauguration. I now request the chairman of Malnad High-Tech Diagnostic Center, Dr. Biradar sir, to kindly share a few words and address the gathering.
The chief organizer of this function, Sri Lakshmi Madam, our senior most gynecologist, Dr. Nagaraj, our resource persons and experts, Dr. Prahlad Kusti, Dr. Lata Madam, and Dr. Veena Bhatt, the president and office bearers of this SOGS, and rest of the delegates. Today I have come here as a representative of MHDC. So Madam is working in our MHDC for the past 7-8 years. So with that one, and she has taken all the initiative to start this CME program from the last year. It's a wonderful thing she is doing right now. We have got all the support to her for this every year event. So this year also she has done this one. She has taken the initiative on her own. Only MHDC is supporting her. So everything is done by her only, and she is doing excellently. So first of all, I congratulate her for the excellent work done for the society and as well as for our MHDC. So other way around, she is an asset of our MHDC. For the past so many years, she is working here and doing excellent work, academic work, research work, and she has brought a good name and fame to our MHDC. I am very proud of her for doing all this work on behalf of our MHDC BOD. I thank her profusely for the work done. Secondly, so we are helping her in other way around. Physically, we are with her. Whatever we have got the free hand, we have given free hand to her. See whatever she is doing, excellent work she is doing. And ultimately, coming to the point, we may ask what the MHDC has done to her. So MHDC has done to her means the work she is doing for the past so many years. Into number of cases per day, it amounts to huge amount. It's a very big data. Nobody can imagine on the earth, probably. That amount of work is there, and she has utilized it. It's an excellent job, which has helped her in her academic work. This is from bottom of my heart. I am telling from very thankful to Madam for the excellent work she is conducting on behalf of us. So it's a memorable one. So in this occasion, I want to once again remind it and tell it. And this function also is going on very smoothly. I wish this function a great success, and also I wish her all the best in her future endeavors. Thank you, Madam.
Thank you, sir. We are aware that we have two distinguished guest speakers who Our regular resource persons and come and address our Shimoga OBG Society, Dr. Prahlad Kushtagi sir and Dr. Lata Venkatraman ma'am. I now request them to accept a small felicitation on behalf of Malnad High-Tech Diagnostic Center. OBG Society, Dr. Veena Bhatt ma'am, to kindly address the gathering.
Hari Om. Respected members on the dais and respected members of the dais and all the resource person of today's CME. ಕ್ಷಣಶಃ ಕಣಶಶ್ಚೈಮ ವಿದ್ಯಾಂ ಅರ್ಥಂಚ ಸಾಧಯೇತ್ ಅಂತ. ಕ್ಷಣ ಕ್ಷಣಕ್ಕೂ ವಿದ್ಯೆಯನ್ನು ಸಂಪಾದಿಸಬೇಕು, ಕಣ ಕಣನೂ ಹಣವನ್ನು ಸಂಪಾದಿಸಬೇಕು ಅಂತ ಎಲ್ರಿಗೂ ಗೊತ್ತಿದೆ. ಸೊ ದೀಸ್ CMEs are part of our enriching our knowledge. And we are very happy and extremely blessed to witness such a great quality CME from such an important persons, senior speakers. And Dr. Sri Lakshmi, our proud member of SOX and ex officio, along with the Malnad High-Tech and along with IMA and SOX, they have arranged this CME, and from morning we know how important today's talk is. And ultimate objective of every obstetrician is to have a healthy baby and healthy mother. And stillbirth is such an important upset in every one of our professional life. So how to overcome this? Still it is even in the research. So we are coming out with the newer thoughts. So we are extremely blessed. On this occasion, I would like to highlight one more thing. Our SOX is celebrating 25th anniversary, and we are extremely happy to note we have feather on our cap 2 individual awards. Of course, we got 2 society awards also. We are receiving in AICOG on Jan 15th. And along that is accomplished, that could be by all our members, including Dr. Bharti, Dr. Priyamada, and all ex-officials and all the members. But to mention, we have Dr. Kavya with us, who could do the MG Hiremat oration. So it was actually, she was supposed to deliver it 3 years back only at Hubli, but due to some constraint, it could not happen. It was given to her. But she could achieve it. There was so much tough competition for that, and she was selected, and she could do it in the last Kasoga Tumkur conference. So we are very much grateful to her. And at the same time, Dr. Sri Lakshmi, she is a proud member, and there is no substitution for hard work and honesty that we are witnessing every day. So Dr. Sri Lakshmi is one more example for the honesty and the hard work. So she has got 2 awards, Dr. Sadhana Gupta Award and Movikal Awards for her extreme she is very I would like to call Dr. Kavya on the stage and Dr. Sri Lakshmi to receive our honor as a token of respect from our society. I request our founder member Dr. Nagaraj sir and Dr. Lata Venkatram, Dr. Prahlad sir and Dr. Biradar sir to accompany the honor.
And this is the plaque that Kavya has received for Dr. M.G. Hiremat oration. I congratulate and thank both the distinguished stalwarts for accepting the felicitation. With this, we come to the end of the very short and sweet stage program. I thank all the distinguished dignitaries for having joined us. I kindly request them to grace the front chairs, please. Slight change in the scheduled program. We'll be going straight away to the panel discussion because Dr. Lata Venkatraman ma'am has to leave for the 3:30 train. So the panel discussion is on stillbirth, managing stillbirth, stillabirth. So I kindly request the moderator, Dr. Lata Venkatraman ma'am, to come on to the dais. Raju, chair na tegidu. Text still, ma'am. I'll get ready this. Yeah. 1, 2, 3, 4. I will just ಇದೆ ಮ್ಯಾಮ್ ಕೊಡ್ತಾರೆ ಜಸ್ಟ್ 2 minutes. ಟೀಪಾಯ್ ಬೇಡ ಅದೇ ನೋಡಕ್ಕೆ ಚೆನ್ನಾಗಿದೆ ಅಂತ ಇಟ್ಬಿಡಿ. 2 ಚೇರ್ ಅರೇಂಜ್ ಮಾಡಿ. Dr. Lata Venkatraman ma'am is well known to all of us at Shimoga OBG Society. She is one of the seniors and guiding force to all obstetricians and gynecologists. She is the lead consultant at Aryamba for Obstetric and Gynecological Research and Excellence. She is the president of Bangalore RCOG Trust and has been the past president of BSOG. Her areas of interest are medical disorders in pregnancy, vaginal surgeries, yoga and pregnancy. She has various innovations in obstetrics, mobile platform for high-risk pregnancies, and she has published more than 20 papers in national and international journals and authored many OB-GYN books. Her current position is as a trustee in Doctors for Seva, Matrika Trust, Sri Chaitanya Rajarama Kshetra Trust, Yoga Bharati. She is the Joint Secretary of Karnataka Medical Education Trust and consultant and advisor to NGOs and medical advisor to biomedical engineering companies, Blue Crimson, Janitri. She has had various awards and recognitions, Lifetime Achievement Award for BSOG from BSOG in 2020. Over to Lata ma'am. I kindly request her to invite her panelists and introduce them to the audience.
Reduce the perinatal morbidity and mortality. And it's so very important that we acknowledge your very sincere effort, especially in a district away from the major cities. You're bringing in such a change, and I'm so happy that you have been supported by Shimoga Society and of course Malnad Diagnostics, and so very happy to be here, and I'm privileged to be here, I would say. Thank you very much. May I request Dr. Jyoti Shetty, Professor Jyoti Shetty, who holds a very prestigious position in Manipal University of Medical Sciences, and Dr. Hebar, again from Manipal, KMC Manipal. Very privileged to have you, sir. Okay. Dr. Sri Lakshmi, of course. Dr. Srimati. Stillbirth is the topic. Okay. They can hear. Yeah. Slides.
ಕನೆಕ್ಟ್ ಆಗ್ತಿಲ್ಲ. ಸ್ಲೈಡ್ ಇದು ಕನೆಕ್ಟ್ ಆಗ್ತಿಲ್ಲಲ್ಲ. ಇಲ್ಲೊಂಚೂರು ಇದ್ರದ್ದು ಕನೆಕ್ಷನ್.
So it would be really a discussion, interaction, imparting some knowledge. I hope we will come to some conclusions rather than some confusions. Okay? Right. Now, without much of an introduction to stillbirth, you have heard a lot about stillbirth from the morning. So we will get on with some case discussions, antepartum stillbirth, intrapartum stillbirths, and many times intrapartum stillbirths or even antepartum stillbirths might be converted into neonatal deaths. So the incidence of stillbirth, that's why it can be variable. People are talking in Chitradurga itself, they say, the district itself, they are saying that it has come to less than 10. I don't know how to sort of view that statistics, because many stillbirths might be converted into neonatal deaths, because the neonatal deaths have not fallen much in Chitradurga district, because I happen to visit them and audit, go through their audit. Okay. Yeah.
1 minute.
Primigravida, at 34 weeks, we see her come with no fetal movements for nearly 12 hours. She has been well booked with us. Vitals are normal, uterus 32 centimeters. Fetal heart is absent on the Doppler. Uterus is soft, non-tender. Last scan was anomaly scan. What relevant points will you look for in the history so far, Dr. Hebar? How would you sort of look for at risk for stillbirth in her notes?
Yeah. Madam, you are telling she is a 27-year-old priming.
That's right.
Yeah, and for the current scenario, I think most of the women, it's a time to conceive and deliver also. So age is not a risk factor.
Yeah.
But if you go to the records, the height of the uterus also almost there is only 2 centimeter discrepancy. But book says that 2 centimeter discrepancy is not given that kind of importance. But still she has come with an IUFD. So nowadays what they say is when you look into the history, like nowadays the antenatal care is inverted triangle of antenatal care.
Yes.
Like more things has to be done in the beginning of the pregnancy rather than towards the end. So right from the beginning, we are telling she's a booked case. I would like to look at her at the time of NT scan, like whatever uterine Dopplers, And was there any risk factor? Did she enter you are telling she's a low risk, but did she enter the pregnancy with any high risk factor? Whether she was a known case of
No,
chronic hypertension?
nothing at all.
Nothing else. Okay. So the first trimester scan was normal according to you?
Yes.
Yeah. And I think she didn't have family history is very important. Any family history of thrombophilias or any in the
nothing
sisters?
At all.
Nothing at all. Okay.
Nothing at all.
But the second trimester scan also you are telling there no aneuploidies are detected.
Yes.
Because sometimes like undetected aneuploidies they can present in the stillbirth. But the only thing I don't understand is like she has come at 34 weeks. Why she has not been followed with the ultrasound between 20 weeks to 34 weeks of pregnancy? Because though you say, though you say like a good clinical examination, nowadays there are papers are coming out that a simple gravidogram maintaining the symphysis-fundal height is as good as doing a ultrasound. And because of the resource constraints, even in European countries, they are looking at less number of scans. But I think in India the scans are not very expensive. I think should have had some screening between.
Yeah. And if it is low risk on FTS, why would we need to do the scan is a question. That is the whole purpose of doing the inverted, rather looking at FTS and also the biomarker, which includes the biomarkers. If it's a low risk, then you don't necessarily have to. There's no evidence for that. Unless she is totally unlooked and she comes to you, yes, by all means. But in this case, I beg to disagree that we should have done a scan between 10th, 20th and 20th week to 34 weeks. Do you have anything to say, Shivamogga, as a fetal medicine specialist? It has been done by fetal medicine specialists. The scan quality has been good. That's also very important, isn't it?
So it means that 20 weeks anomaly scan was normal. There were no obvious structural abnormalities. So between 20 and 32 weeks, probably one ultrasound at 28 weeks, maybe there was a mild IUGR or AC was small, could have been picked up. That is the
pregnancy. FTS being normal and UAD normal, FAT normal. Everything normal. So why did you do a scan?
I would say if you have to do a scan, then it's mainly for detection of early onset FGR. And early onset FGR would have had high risk factors. Yes. So mainly late onset FGR is what we are worried about in terms of stillbirth. So I would definitely disagree and say we wouldn't have done a scan, because even if you're going to do a single scan, the evidence is that we have to probably do it at 36 weeks because you're going to pick up late onset FGR. And serial scans are more for picking up in high risk pregnancies and not for low risk pregnancies. Of course.
Pregnancy, if
so here
pregnancy or pre-existing medical disorders, yes, by all means. But doing a routine scan, because the resources might be might not be available, etc., etc. So I think, in this particular case, I don't think I would have done a scan.
We wouldn't have done a growth scan.
So comprehensive maternal, medical, social, family history, etc., etc. Even domestic violence is increasing. So I think for a low-risk pregnancy like this, we have to keep that in mind. And all the detailed history will definitely help plan the investigations and also might contribute to identifying the cause of death, at least in 1/3 of perinatal deaths. By history itself. Is there anything else that you wanted to add on? UAD, PAPA and growth, all these are important. PAPA is an important marker for adverse pregnancy outcomes. Abnormal uterine artery Doppler indices are associated with 3 to 4-fold increase in the risk of stillbirth. So it's very important that we look back into her notes and see whether she was at risk and whether we have missed out. As you said, maybe whether we should have considered a growth scan if any of these were positive. So, SGA, both SGA, small for gestation age and also FGR, were associated significantly with stillbirth in singleton pregnancies across all gestational ages at delivery. Odds ratio for SGA and FGR 2.3 and 2.6 respectively. So we have to pick up, in case we haven't picked up, that is the area to improve upon. Okay, is ultrasound confirmation of IUFD a must, Dr. Jyoti?
Once we examine the patient and fetal ultrasound is not heard, we have to do an ultrasound and document it. It's a must because it's something which has to be conveyed to the, usually, you know, in Indian scenario, it becomes very difficult to convey a bad news to the relatives because they will say, we were coming, as you said, like regularly for checkup, but why did this happen?
Yes.
Because though we say 40% may be unexplained, but you know, in the Indian scenario right now, the relatives will never accept a mishap. So the lady we may not be able to convey immediately because most of them go into grief, and some of them need counseling by the psychologist, clinical psychologist, because most of them don't accept it. It takes nearly 3 to 4 days for the lady to accept. Even if you say, are you feeling fetal moment, they'll say yes. And that's the usual scenario, denial. And most of the time they will not accept it, and it becomes very difficult, even for the obstetrician who was taking care till now, thinking that it was low risk, but suddenly, you know, we find we are not finding a cause for the IUFD.
Yeah. Do you want a fetal medicine specialist to scan her?
No. Like usually.
Or do you want yourself to confirm and say there is no FH?
Because the first anomaly scan was done by a fetal medicine specialist. Yes. And it has been categorized as low risk. So I may not want because I can do it because we are all doing it and then confirm it is IUFD. But I may do a survey to find whether, because there is something called, there can be evolving anomalies in second and third trimester. There are certain things like, ventriculomegaly, double bubble sign, and all these may appear in third trimester. So I may do a survey because I know how to do anomaly scan. I may do and document it, and I note it down. But it is very difficult to explain to relatives that an anomaly has cropped up in third trimester. We have to maybe show the evidence and say that these things can happen. That is why we always tell in anomaly scan that 90% it looks all normal, but 10% it's like a photo of the patient, of the baby.
This is a disclaimer.
Photo of the baby.
But do you feel that a fetal medicine specialist scanning, if there was an availability of
fetal medicine for an IUFD,
confirm, or would they look for something more, is what I want to ask you, Sri Lakshmi.
As such, fetal medicine specialist is not required for confirmation of IUFD.
Yes, agreed.
Yes, an obstetrician who are good at ultrasound, or a radiologist who are doing regular ultrasound are good to pick up or to document an IUFD.
Would you be able to sort of predict the time of death better as a fetal medicine specialist?
No, there are definite signs. Even radiologists and obstetricians, they do pick up telling there is a maceration and spalding sign, all these.
Anything else that you would be able to pick up? Would it be a sort of autopsy, non-invasive autopsy?
If she is a previously booked case, and if anomaly scan and growth scans were done correctly, then we may not get anything majorly new.
Agreed. If she was unbooked, do you think we would have added something here?
Unbooked, we couldn't add many things like that.
Absolutely.
Maybe a simple neural tube defect can cause, and hypoplastic left heart syndrome can cause, and sudden IUGR, oligohydramnios, placental insufficiency. Yes.
Yeah, oligohydramnios may be secondary to
IUFD.
So, but if this lady was not scanned by a fetal medicine specialist. Probably scanning her, a fetal medicine specialist scanning her would be more relevant. And even if you wanted to do a fetal autopsy to see whether something has gone amiss, like Dr. Jyoti Shetty said, late onset anomalies, though minor, they might not be lethal, but still we might be able to sort of throw some light. Okay, thanks. Stillbirth is common. 1 in 5, 200 babies are born dead. Yeah. How would you counsel them? Would you get them prepared from the time that they conceive? Oh, like we are born, we can be dead, sort of.
I think, not for stillbirth. There are calculators even for stillbirth in the first trimester FMF calculators, but somehow, calculating for preeclampsia, I think that is okay, but calculating for stillbirth and say this is your risk of stillbirth, I am a bit skeptical about it.
It's like contacting an astrologer and saying how long this baby is going to live.
So,
right.
So I'm not too sure, but of course now to counsel her, I think it's going to be difficult, as Dr. Jyoti was telling, because lots of questions happen. Have we made, were we negligent in giving care? What was the reason for the stillbirth? Plenty of questions crop up, and of course the lady is going to be in denial. So I think a bit of compassionate care, and of course telling them, the questions would be addressed a bit later, because of course, there are lots of going to be grief, anger, denial, all kinds of emotions. The Navarasa is going to come in. At
and
the
also
same time.
Navarasa from the mob is much more difficult. Okay. So, Navarasa and Kasa to the hospital. Okay.
So I think at this point, of course, we are going to be in a very difficult situation, because we as obstetricians also feel very upset, because the first question which comes to us is, were we negligent? Because even before the patients come and ask us, I think we tend to autopsy ourselves to see what we could have done better. But I think it's important that we give her a compassionate care. I think the cornerstones are conveying the news in a very compassionate manner, to looking at the maternal well-being to see whether she is safe, whether there were any acute events, and of course then planning the delivery. And then finally I think we need to think about what investigations we would need to do. I think we need to compartmentalize and see how we can plan it. So 1, breaking the news, making sure she is comfortable. 2, looking at her safety, because if it's a preeclampsia, if it's an abruption, or a sepsis, whether we need to plan a delivery immediately, whether we have to stabilize her. Of course, if that is not the case, then how are we going to plan her delivery? And then comes in investigations which you would need to do for finding out the cause.
Yeah, obviously the family will be harping on you, asking for the cause of death. So how will you put it across? Because most of the time patients won't agree if you said you don't know the cause of death. Dr. Jyoti.
We have to, objectively try to go through the papers and say that we have done the proper antenatal care for this patient. And that they may raise, because I have seen, when I restrict scan, patient usually comes and requests sometimes, because she would have seen, because most of them, they are having a group of women who are in care. They will say that obstetrician ordered a scan, and for me also you do one scan. This is usual, because I was also restricting sometimes. So then they will come, and when they are requesting, I order a scan, because maybe she has a concern, and by restricting and something goes wrong in another 2 weeks time, maybe it's justified in doing when she herself is asking. Because there are requests of patients many times, they themselves ask for a scan. They feel they are reassured by doing a growth scan. Growth scan, they feel, it's better to do it.
We say that we don't know the cause, but that is not very well accepted. So probably we will have to put it across in such a way that, look, we are going to look for the causes. At the moment, we don't know why it has succumbed. Those words are very important. When you break bad news, that is actually a very common, ASCII station for hematology examinations and even DNB examinations nowadays. So I think you should be, PTs are there, so you should be well adapted to that. Okay, now, would you deliver her, offer delivery immediately? And if she says, I want a section, no choice.
I think it is a very difficult situation because obviously they take lots of decisions in that emotional moment. I think if there are no immediate threat or any immediate emergency, we could give a bit of a time so that the information sinks in. But I would definitely counsel her for a vaginal delivery.
Dr. Heba, what would you say?
Yeah, as we all know, the moment the mother comes to know that the baby is dead, the relatives, they ask for immediate delivery because there is a notion that the dead baby inside can catch infection and later can cause problems to the mother. But the evidence says that once the IUD occurs, it is not that the relative, unless it is because of the, as Madam rightly said, either because of chorioamnionitis or because of acute abruption, it is because of solely the placental insufficiency. Okay, there is a long window wherein, like, if you wait, there is a good chance that spontaneously the cervix can ripe and most of the time they can get it to labor. Even the books say that the related complications such as sepsis and this secondary intravascular coagulation, it does not happen so suddenly and so dramatically. It takes around up to 4 weeks. But is it that having known that the IUD has already occurred, or you have the guts to wait till 4 weeks? And another thing you should ask yourself is, when did the IUD happen? Okay.
So we don't know.
Yeah,
Yes.
we don't know. Okay, it would have occurred a week ago because you don't have any scans or anything after 20 weeks. It would have already occurred, it will be already in that particular window. And nowadays, I think you all know that we have got a very good inducing agent and with good, very success rates. Earlier and all, we had always difficulty with induction. It was the old era of with oxytocin. Nowadays, they got very powerful prostaglandins.
Yes.
And most of the time, they do succeed. And good thing is that in case of IUFD, the baby is usually small and there are, most of the time they expel. 90-95% of the time expel. And they won't, but you have to have a screening. You have to, coagulation screening, you have to do it often. And make sure that, she has not gone into DIC. As long as the things are okay, we can always try.
Can we continue with you on what investigations will you perform? Yes, I think it's very important for them to absorb the fact that the baby is no longer alive, and then if there is no medical emergency, probably give them probably a few hours to mull over and then offer admission and then induction. You can ask them to come back and speak to you and things like that, because it can be very dicey, because stillbirth can be entirely, I mean, the obstetrician can be blamed for it, and also a lot of, I mean, we have faced more, I mean, just for stillbirth. Okay, so that too 27, 28 weeks stillbirth who went to the court later and things like that. Now, what do you want, what investigations, before the baby is born, what investigations would you like to do, Dr. Heba? She has been diagnosed as IUFD and she is getting admitted.
Yeah, your investigation should be oriented to what caused the IUD first, and whether she has a complication of IUD, such as I already told,
right,
or the DIC parameters.
Yes.
Yeah. So as you said rightly, when the IFT occurs, you have to again, like you have to read all the history. You have to look at her investigations. You should maybe in the aneuploidy time of aneuploidy screening at 13 weeks, you should have looked at her. All those mounts of those values.
So pre-existing comorbidities, complications of pregnancy, what was the screening in pregnancy like, whether she has had any events which could have caused IUFD. All these in the history, as you very rightly said, should be looked for. But now, investigations wise, what would you do? As you said, we want to know the cause for this IUFD. What are the investigations that you would like to do if at this stage, before the baby is born?
Yeah. So basically you have to do the investigations which look at maternal infections. Nowadays I think people are looking at all different kinds of viruses. The whatever it is, Zika virus, all those things, but where it's which or even for that matter measles also. But in those endemic areas, in the endemic areas, suppose she stays in the endemic areas, you have to do all those torch panels and all. And we do not know whether we have missed any pre-existing medical disorder. So maybe it's wiser to look at LFT parameters, RFT parameters.
Yes.
And many times that we do not routinely screen for ISCP, and many times that itching during the pregnancy is commonly mistaken for prologue of pregnancy.
Sometimes they can be asymptomatic also.
Yeah, asymptomatic.
So including bile salts. So complete blood count to see what her total count is, platelets are, and coagulation profile, just to make sure things are alright. And biochemistry, including bile salts, as you said, LFT, RFT, etc. And blood group and antibody titers, minor antibodies, would you do it? If there is hydrops, if there is hydrops,
Clinically, if there was an indication like fetal hydrops or a MCA Doppler, PSV, then it is indicated. Otherwise, it's not indicated.
Okay.
Because even the labs are not standardized they don't do routinely, so interpretation becomes difficult. So clinical indication, yes, definitely.
But even if there is no non-immune hydrops, okay, if we have not done MCA PSV, maybe there is an indication for us to do antibody titers, not easily available. It is available in major cities or some of the well-known labs. Okay. Would you screen for thalassemia and hemoglobin electrophoresis?
If her hemoglobin is normal, PC was in the normal range. Okay, so by chance if you have done a ferritin was in a normal range. And if there are no family history, probably would not.
Yeah.
But if it's a case of anemia who is not responding to regular iron therapy, all the time her hemoglobin is less than 10. In spite of good, many times, like she would have received even the parental iron. Okay, but still, then better to go for a screening. Because many times we find that the chronic anemias, we find beta thalassemia.
So, and if the partner has had thalassemia and because of thalassemia nature, that could be a cause for demise also. Okay. Here I am not saying that, but random blood sugar, glycosylated hemoglobin, thyroid, Klein-Hall Bedke test. Is it important? Especially in an unexplained low risk pregnancy having this problem. Do you think KB is important?
Yeah,
do you do it in Manipal?
No, if baby is born pale, at the time of delivery, we have to suspect feto-maternal hemorrhage, which can happen in sometimes, and can be a cause for stillborn baby.
Yeah, but sometimes when the baby is macerated, you might not be able to recognize whether it is pale. But worth doing KB if there are no other causes that you are finding, because twice before we have had this problem, huge amount of fetal-maternal transfusion. Okay. Serology for viral screen, as you said. Syphilis is not uncommon. It's coming back again. So that is another thing which could be a cause for IIFD. So please do screen. But in selected cases only you will do the other tests. Unfortunately, I don't have much time to go over it. But you should think of APLA and also, but hereditary thrombophilia screen has got very limited role to play. Okay, we'll come back to it a bit later. So, antiphospholipid syndrome, lupus anticoagulant, anticardiolipin, etc. Can it be done at the time of stillbirth, at delivery? Srimati or anybody wants to take the question?
Usually we prefer to send screening for anticardiolipin antibody and lupus anticoagulant at 6 weeks or at 3 months after delivery, because it is supposed to be usually repeated twice. So preferably it is done later, and it can be done in patient.
That's what I wanted to sort of emphasize, that it can be done.
And even anti-nuclear antibody screening for SLE is one of the things for ANA, anti-nuclear antibody.
That is immunofluorescence can also be done.
As a workup.
Sometimes in pregnancy it can be falsely positive.
So it needs to be repeated.
Low titers. Okay, so I think it's important that we understand that antiphospholipid screening can be, APLA screening can be done at the time of IUD also. Going to the next question, we did mention 10% of them within 4 weeks after the date of IUFD can develop DIC, and it raises to 30% thereafter, so you should be careful about it. So what would you examine at delivery? So now she has been induced and she delivers. What would you examine at delivery?
Examine the baby for phenotype. I mean, to see whether, compare it with the ultrasound, and though ultrasound was said to be normal, we would like to see grossly the back of the baby, the head, and like gross examination of the baby.
Do you want to do it, or do you want the neonatologist to do it?
I will take the help of neonatologist, but I would also like to have a look.
Certainly.
Because it is like just to know whether baby is looking normal, and like after that examine the placenta, because all these placental abnormalities like succensurate lobe,
so full autopsy,
circumvallate placenta.
Can we go back to the baby for a minute? So you want to examine the baby and see whether it is, whether there are any anomalies, obvious anomalies, and offer them autopsy?
Yes, definitely. We'll offer autopsy in all unexplained IUFD, because we may get some extra information which may help in planning their next pregnancy. So that is the reason.
Which might have evolved.
Might have evolved.
In this particular case. Otherwise, if she was unbooked, all the more. Okay, limited autopsy. Anything that you want to say, Srilakshmi? Limited autopsy. They don't want to have the autopsy, but what do you want to do?
Ma'am, limited autopsy is external examination. Many times it will be, if it is not screened, we might have missed a Down syndrome. So like a sandal gap or a low set ears and a nasal bridge, some small phenotype. It is very important to interpret properly. If it is a macerated IUD, interpretation of these also is difficult.
Okay.
So simian crease and sandal gap are definitely useful.
Fine, that is one external examination, but would you take a piece of tissue from the body?
That is always
microarray or whatever?
Yes. So what we should know is karyotype cannot be done in a dead tissue. So we have to store the DNA. So DNA can be taken from the skin of the thigh or shoulder. Anything. If it is macerated, take a piece of a liver from inside and we can store DNA. If DNA is stored, two labs do store DNA. One store for 1 year and the other stores up to 5 years. And they have an ID also for the patient. So after storing DNA, we can take out if it is a good quality and do microarray and exome, whatever test is relevant. So that is the advantage.
Okay. I want to ask you a very pertinent or a very basic question. If there are no anomalies in the baby, okay, and if it's intrauterine fetal death, and there is no history of previous abnormal babies or anything like that, would still microarray or exome sequencing help? In which conditions?
Yield is very low, ma'am. Yield is very low. That we have to explain to the patient. We may tell there may not be external examination finding and internal, but there may be hepatomegaly, which is seen in inborn error of metabolism.
So, do you think that will cause intrauterine death?
Not
metabolic
all
disorders. Very rare to cause
very
so because so much is spoken about microarrays, WES, people spend thousands of rupees, and we are in a dilemma, we are at crossroads. We ask the geneticists, they might say yes or no, and we don't know, we are in the dark many times. Do you agree with me?
Definitely, because first thing they will ask is cost. Autopsy is the cheapest of all, because microarray and whole exome sequencing, because the cost has to be explained, and the patient party, most of them will say will not agree for it. But certain times
we are going to miss a big number of problems.
No,
isn't it?
No, we may land up in more confusion than clarity, because exome we may get variants of unknown significance, so we don't know the reason. Then we end up doing couple exome sequencing, which we may not get anything. So if there is no definite indication, better not to do.
Isn't it? That's good. So if there are no
just to store DNA,
and if there is no previous history which can suggest genetic problems,
yes,
I think we should keep it in reserve. You can probably store the
store DNA.
Do they charge extra for storing DNA?
No. But they may start maybe 1,000 rupees.
That's it. Okay, that's great. Okay, so I think it's very important to examine the baby. Examination of the placenta, sir. Placenta, Dr. Hebbar.
I personally don't do it, but it is recommended that you have to do the placenta, and there is a way to take the biopsy also from the center, equivalent to one coin from the edge and all, and submit it for the histological examination. And the pathologist, expert pathologist will find out the sequence of abnormalities. But we have also recently done a study. We have done in a live pregnancy as well as in IUFDs. And the things that villus infarction, that this inflammation, it occurs in both the live as well as the IUFD placenta. So to what extent the placental this one, that gives light, I'm not very sure. But as a part of this one, that stillbirth evaluation, they do it.
And the other thing is the weight of the baby, weight of the placenta, the ratio. No, because when we are doing the external examination, that is also part of it.
Yes.
And of course, placenta, I think looking at the insertion, looking at how it was, I think that is important. Cord insertion.
Examine in detail.
And even at the placenta, looking at whether you can see any, as sir said, infarcts, clots, abruption, the size of the placenta, calcification.
Lakes and things like that. Do you think placenta can throw some more information? Yeah, baby's weight and placental weight and the ratio is important. Okay, I don't know, I can't remember what the ratio should be.
1:5. Fetal-placental ratio
is 1:5, is it? Okay, yeah.
But most of the things, like would have known antenatally only, the small placenta.
Yes.
So it may be more helpful for unbooked patients wherein we have not been able to. But at least placental histopathological examination, but again with a skilled pathologist, because otherwise what you are going to get, as sir said, is you may not find a major difference. But looking at fetal vascular malperfusion, maternal vascular malperfusion,
etc., I think it is important that we send the whole placenta. Not just a chunk of it, okay? And card, I think you should palpate the card. Sometimes you can find thrombus, sometimes, the card anomalies. Do you want to throw some light on card problems? Hypercoiling or straight coiling, straight short card, please.
Coiling index can be done. Actually, there one thesis was done in KMC Manipal in coiling index. That also, like more than 120 centimeter umbilical cord and less than 30 centimeter umbilical cord, they were supposed to be causing more chance of abruption actually. But we didn't find anything as such. My fellow PG only was doing less than 30 centimeter also babies were normal. So we cannot tell 100% sure the umbilical cord is the reason. But sometimes there may be constrictions, multiple constrictions, amniotic band syndrome. They are very rare, but if it is found, then yes, we are fortunate that we found a cause.
Actually. Sure. External examination, there is a proforma available. I think we should be using that proforma whenever there is a stillbirth, which talks about measurement of weight, length, head circumference, and also the placental weight, etc., etc. Okay. Now, counseling for autopsy, we did talk about it. Even though they are not agreeable for full autopsy, I think partial autopsy or non-invasive autopsy is very, very important. And when do you do MRI? When would you suggest? Because MRI is becoming, unfortunately, more common in Bangalore at least. Subjecting stillbirth babies to MRI.
I don't have any personal experience as such doing MRI, but for fetal autopsy, every fetus that comes for autopsy, we do X-ray.
X-ray?
Yes.
Okay.
And X-ray yield is very high if there is lethal skeletal dysplasia.
Okay, which could have been missed.
Which could have been missed. Actually, there was one case wherein an unbooked case, patient came for insurance, so she got a cesarean done. But at cesarean, they found short long bones and baby had respiratory distress and died. And when I took X-ray, it was a clear-cut case of a lethal skeletal dysplasia.
And further investigations were directed.
Yes.
Yeah.
That is a definite indication.
That's a definite indication. See, MRI, unless there is neurological abnormality, neurostructural abnormality, etc., maybe
we can do MRI, but how to correctly interpret
absolutely.
that
You need an expert, just not sort of keeping the baby under the machine, we will be keeping our
it is actually easy to do MRI, not make it, but how to interpret it correctly, it is, because see, we don't have nomograms even for the fetal liver.
Absolutely.
We may just see, liver is up to the umbilicus, and we may tell it is hepatomegaly, but how far it is true, because at 28 weeks liver is the main hematopoiesis, so it will be up to umbilicus. So we need to do nomograms and
for our population. Otherwise it's very difficult. It's like nasal bone. Hypoplastic compared to what? Compared to your nose or the fetal medicine specialist nose or what, I don't know. Anyway, short stretched card, and the card was sent for histology and umbilical artery thrombosis. This happened quite some time ago, but it was multiple segments. See, after death there could be thrombosis of the card.
Yes.
But it was in multiple segments and also occluding or something like that they had mentioned, and it was short, and I could palpate the thrombus actually, and it was a very fresh stillbirth. That was another difference. Okay, could we have diagnosed it earlier if she has come 12 hours later after not feeling the baby's movements? Do you think a scan when she came in would have helped diagnose umbilical artery thrombosis?
I think more than scan, NST would have helped, because there is thrombus means there is blood compromise. There will be definitely variable deceleration.
Wouldn't you have seen it on umbilical artery Doppler?
Umbilical artery Doppler diagnosing thrombosis, I am not sure, ma'am.
No, there would be reduced blood supply.
That means we are doing high resistance flow or absent end diastole.
That's right.
So at least if we had missed by scan, but NST we wouldn't have missed. Definitely.
I'm not sure. I think it would have been more on the Doppler rather than NST, because that's the last change to come out. Maybe you could have seen it on both if the baby was really.
But by scan, looking for an umbilical artery thrombosis.
No. I'm not saying that. No. Reduction in blood supply.
Reduction.
Okay. Was this preventable, Srimati?
I think it's difficult to say because we are saying it's umbilical artery thrombosis. Whether we could have prevented it, it's difficult. But why did she wait for 24 hours? This is what we were discussing about 12 hours for diminished fetal movements. So that's again a bit difficult to say, because even if she had come in earlier, if you have delivered her, because it's still preterm. So would we have taken a decision of delivering? I think it's a very difficult question to answer, whether we could have completely prevented it because she was a low risk one and we did not know what was the cause of the umbilical artery thrombosis.
That's right. And raising awareness of reduced fetal movements is very, very important if we have to prevent stillbirths. If somebody is unsure of fetal movements after 28 weeks of gestation, they should lie down on the side and focus on the fetal movements for 2 hours. If they didn't feel 10 or more discrete fetal movements in 2 hours, they should come and get examined, is what the Green Top guidelines of RCOG says. Would you agree with that?
First, very regarding the umbilical artery thrombosis, just I was thinking once, like the cord is 50 centimeter length. You have to examine right from the cord insertion to the placental insertion, and there are 2 umbilical arteries. It is not just one. And when I am doing umbilical artery Doppler, we put the gate on any vessel which is accessible. And I don't think that entire 50 centimeter length of this one, and both the umbilical arteries are not separately reported. It is one of the umbilical arteries.
Sir, overall reduction in umbilical artery flow.
But I don't know when one artery, because single umbilical artery also, when the one artery is compromised, the other artery can be still good. I really don't know. Shilakshmi should answer about it.
I still don't know whether that was the cause for death. That also I don't know. That was the only positive findings.
So you are conjecturing that is the cause.
Yes.
So many
and
times.
Also it was easy for me to sort of convey to the patient that it was not.
So we look for excuses, but many a time even in diabetic pregnancies we blame it on diabetes, but that may not be the cause. It could be because of various other factors. Right. So I think we cannot say that this is the cause unless we have proof and evidence to say that that is the cause.
That was the only positive finding. That's why I attributed it to it. And also, yes. So in 2 hours, if the movements are not there, they would come and probably have a CTG. If they didn't appreciate the movements, even then probably they would have a scan with Dopplers. Dopplers are an important part of investigation in the management of reduced fetal movements. Okay. So if FM can plateau by 32 weeks, but no reduction in the frequency of fetal movements, the quality of movements, it might not be so very strong, but still the quantity will be good. But quality, as you said, look, whenever the baby, it would have a behavior.
The qualitative aspect is what they say is more important than the quantitative aspect.
But there won't be a gross reduction in the frequency of movements. Okay. So,
and regarding the reduced fetal movements, madam,
yes, sir.
It has happened in our own hospital. Evening NST has been done, but morning there was an IUF.
Yes. That's right.
And because we don't monitor the baby in the night. Okay. And then 2 hours, like the guidelines about the regular what we count to 10, for example. What happens after feeling the 10 moment? The patient for that day is done. Yeah.
Yes.
And also the statistic scoring. Okay, once in that 1 hour, particular hour she felt, okay, it is not that every hour she will be calculating. Okay, I don't know unless she is that apprehensive. And also you rightly said that something called a fetal sleep wake cycle, 40 minutes to 120 minutes. So looking for the absent movement for 2 hours and reporting, and many times they come again. And again, no, it is the same story that NST is normal, the scan is normal, doctors are normal. You send her home, but still inside, it happens again. What to do? And that's why I think RCG also tells recurrent reduction in the fetal movements for 3 or more occasions.
Yes.
You don't know the cause, you take an action.
Yes, absolutely. Especially after 37 weeks. Okay. Now, primary 26 years, at 36 weeks of gestation with reduced fetal movements for 24 hours. CPG, uterus soft, no contractions. This is the trace when she comes in. Yeah. What is the probable diagnosis?
So obviously going back to the CTG, if we see, so obviously this is still an antenatal CTG, and of course as we already discussed, computer CTG would be better, but for want of...
She is showing some activities on the toe.
So then whether we're going to say it's antenatal or intrapartum, because you said uterus is soft, no contractions.
Yes, yeah.
So that is a problem with the TOCO,
That's
because
the
TOCO
problem
can
with
pick
TOCO.
up various things.
Yes,
So
that's why I just
I
wanted
would
to bring
probably
this point
feel
up.
more for the contractions in the hand rather than for the TOCO. So having said that, so whether it's an antenatal or intrapartum is difficult.
Variability probably, which we have not recognized.
So we do not know, but looking at the CTG, definitely we cannot make out accelerations. What is happening with this variability, we still do not know. So it is worrying, because definitely maybe an element of hypoxia, something is happening. But again, having said that, the false positives, false negatives of CTG comes in, but coming in with diminished fetal movements at 36 weeks, this kind of a CTG, I would definitely be worried whether there is something happening in the background, whether there is some hypoxia, whether there is some...
for 40 minutes.
Almost 40 minutes.
Sinusoidal pattern.
So this is definitely worrying.
You sort of determine the baseline.
So there is tachycardia and variability pattern shows a kind of a sinusoidal with no definite accelerations with reduced fetal movements. This is definitely worrying. So we'll have to think again about the cause.
So we were trying to organize some scan to see what is happening.
So this again could be a cause of fetal-maternal hemorrhage, the Klein bed case, but again the turnaround time is going to be higher.
Absolutely.
So
yeah, we don't know. So it's a sinusoidal pattern, whether there is fetal anemia or it is due to hypoxia. If we had a bedside scan and MCA-PSV, would it have helped here?
Definitely. Definitely MCA-PSV would have helped.
So when you have a trace like this, where you are unable to sort of decipher, jump and deliver her at 36 weeks, I mean, she should have been delivered by section only.
Yes, yes.
Okay, so probably worth considering a scan Dopplers is the message that I would like to give you. And parvo testing also, if you had time, Klein Betke, but this trace won't sustain. It took a nosedive within half an hour. We were sort of trying to see what's happening, that, this and that, and again there was some sort of better variability. Later on, I haven't put the trace here. Later on, some variability, improvement in variability, I thought. But unfortunately, it took a nosedive, and category 1 section, bradycardia on the table, baby came out query with a heartbeat. So we don't know whether it's a stillbirth or a neonatal death. So this is where, things can overlap. When you section, when you do a cesarean or deliver them in a hurry, and you are faced with a baby who has hardly any heartbeat, whether you want to call it a stillbirth or neonatal death, it's still very debatable. But look at the pH, 6.8. So there was definitely an intrauterine hypoxia for this, whatever may be the cause, and base excess of 19. What are your thoughts on this management of Jyoti?
This is severe hypoxic ischemic encephalopathy, and baby will do very badly. So usually, we have to involve the neonatologist and take their help in explaining the whole situation, because most of the time they will say you should have done 1 hour before the cesarean. This is the question thrown to us by the this one. Why did you wait doing the trace for 1 hour? You should have done it. But I think it won't save, because if pH is 6.8, most of the time there's a severe insult which may be a fetal-maternal hemorrhage, maybe, like we have to search for the cause. And usually, it's like it happens, like sometimes we rush and do a cesarean and take out a baby with pH less than 7.2, and we have to just take the help of neonatologist in explaining, and there's no point in supporting that baby also, because baby will do very badly in the ICU.
Again, was this preventable?
Preventable, we have to search for a cause, madam, because we have to help her in getting a realistic cause, so that which helps in next pregnancy planning.
But it was almost 1.5 to 2 hours after she came that we delivered, because we were in a real dilemma. What it was.
If you have
Delivered her earlier, we really don't know.
Baby, and
this sort of a trace, you would have
we should go through her whole antenatal course, find the cause. because the overall situation will give you the cause.
But we would have got a baby with the proper heartbeat, that's all.
Yeah.
That would have been the only advantage.
And always,
If she had come early, 24 hours.
little difficult to say
24 hours. She had come after.
Yeah, but I think we should keep telling mother about the importance of checking for fetal movement.
Absolutely.
And they should report early because they can't wait for 24 hours. So usually it is better early reporting and
that's right.
And take it.
Even if it is a red day or an overcall, it doesn't matter.
Overdoing certain things may help because so many times actually the RCOG says that reduced fetal movement at below 37 weeks. Like you have to see the overall situation, and if this one, because you're taking out a preterm baby,
yes,
so baby may have problems of prematurity. So that is why they say see the overall situation and check the blood pressure, check the sugars, check the glycated hemoglobin, and growth of the baby, because any growth between 3rd to 10th centile may be better to keep her in the hospital, because still we should go by Dopplers, because all that, everything like history taking, leaking, everything has to be taken, and even bile acids may have to be sent.
Yes.
Maybe overdoing things may help.
I think
the only other thing I wanted to bring about bile acids, many a time we blame the bile acids, and in fact we end up doing preterm deliveries as well. So there is definite evidence from the recent meta-analysis, unless the bile acids are more than 100, we don't have to worry in the preterm gestation, and more than 40 at the term gestation, because many a time we worry about bile acids and also bring out a preterm baby. So though bile acids have to be done, I think we need to take it with a pinch of salt and not overdo with the bile acids in delivery as well.
That's right. But retrospectively,
doing a bile acids is helpful, but at 32 weeks for that lady, even if you have done a bile acids, I mean, it may not have actually been the cause, though we have to do it as part of the completion.
Routine investigations for stillbirth. Okay, when you are on the growth restriction at term, FGR 10 centile at 36 weeks, there was increased resistance. She was asked to repeat the scan in 3 days, but it did not turn up. She comes in after a week with reduced fetal movements for 24 hours, no FH detected. No FH detected, blood pressure 140/90, albumin plus. So what do you think? No FH detected here.
No, it has already occurred and she is 38 years. That I think itself is a risk factor, and BP is also high. I think she had undiagnosed preeclampsia, because preeclampsia, late onset, she would have had it.
Probably she had some element
Probably she had.
And we have seen BP coming up in 24 hours. Many times, like after the delivery, I have seen a patient going into eclampsia. That means that the process was there. It is not detected. Maybe we went by the very strict guidelines of 140/90. In fact, look at her earlier blood pressure. It was 100/70, and for 130/85 also may be higher. And there is also proteinuria.
Yes.
So that means that she had preeclampsia.
38-year-old BMI.
Everything.
And she had FGR.
So we should have followed her up, or she should have followed her up.
At that time, when we had the diagnosis of umbilical artery increased resistance, what kind of a surveillance have we put in?
No, the blood pressure was normal.
Blood pressure could have been normal, but then she had all the high risk factors.
3 days she was asked to come. That was right, wasn't it?
Right.
Yeah. So she didn't come, and we lost the baby, unfortunately, in a 38-year-old. So such things can happen, and this was a preventable cause. Definitely a preventable. See, whenever a stillbirth happens, we have to ask ourselves, was this preventable? What are we going to say for the future pregnancy? So, I think there are a few more cases, but I think we will skip. And also this case, the lady had leptospira. She presented with sepsis, in fact. She had to be stabilized. It was a stillbirth, but had to be stabilized. So even if there is stillbirth, you have to stabilize them and deliver. But unfortunately, she had hemorrhage into the lungs and she had to be ventilated. So in order to promote the ventilation or reduce the burden of ventilation, we had to do a section for stillbirth. So there are some conditions where you might have to do a cesarean for a stillbirth. And also in that case, which we discussed earlier on, the KB test was highly positive. I think worth doing the Kleihar-Betke test, and I think antenatally only two things can be, what can I say, important to reduce the incidence of stillbirth. I won't even say prevent. One is the fetal surveillance by the mother. Okay, that is the fetal movement. Very, very important. And the next is fetal surveillance by the obstetricians, which has got a very limited role in the absence of CCTG, that is computerized CTG. But Dopplers, in case there is reduced fetal movements or FGR, etc., it might come to our rescue. Intrapartum, I think
also screening, ma'am, in the antenatal period. Screening in the antenatal period.
Yeah.
Risk stratification.
Risk stratification, that is inversion of the pyramid, as Dr. Eva said, should be done for all women, but it is sort of far from desired, unfortunately. And intrapartum stillbirth, if you want to prevent, it is only the CTGs. Still, we are depending on the CTGs. And you have to risk stratify when they come in labor and see whether the baby will tolerate the contractions or not, what other risk factors they have and they develop during labor. All these will have to be taken into consideration, and I think we should close the panel, otherwise people are really feeling hypoglycemic and
they have to be resuscitated.
Sorry?
They have to be resuscitated.
They have to be resuscitated, and I think it's very important that we prevent stillbirth by improving our antenatal and intrapartum care. Do you have anything to say as a take-home message, all of you?
We actually, keep telling all mothers to count the fetal movements, and if they are feeling there is less movements, they have to report immediately, irrespective of the time of the day. That is very important. Sometimes they think, okay, night, doctor may not be there. So we tell them, you report in the hospital, there are doctors to do the work. We work as a team. So all the time there are people to look after you, which has to be emphasized by, and if they report early, I think things can be better.
Sure. Dr. Heber.
Yeah. So another tendency I have seen, whenever there is a reduced fetal movements, many doctors tell, no, it may be that your baby may be hungry, you take some glucose, you eat. But most of the time, I have seen after taking food, that fetal movements becomes okay. But you should also remember that if it is a real acute emergencies, making her to eat, like you may not be able to do an immediate cesarean section also. So you should tell, if there is a decreased fetal movements, okay, no more trials at home, please come to the hospital at the earliest. Because we can offer, if the baby is really sick, okay, one intervention, may prevent the possible stillbirth.
Thank you so much.
Ma'am, I would still vouch for prevention, because though you said universal screening is still a long way ahead, simple history, risk stratification and planning surveillance I think would still work, because we can do better, because simple echosprin can go a long way in preventing hypertensive disorders, FGR and stillbirth complications.
Yes. With history and simple examination itself, 60 to 65%. You will be able to detect the complications of pregnancy and risks. Okay, nice.
Severe FGR gets all the attention and gets delivery, but what we miss is mild IUGR. And mild IUGR, 37 weeks, 2.2 kg baby comes with IUD. So that actually that the baby deserves more attention than severe FGR. So for them, yes, and for them, fetal movement count is very, very, very important.
Thank you very much. You have spared your precious time. Thank you for that. Thank you. exchanging our views. Thank you. Thank you. Thank you, Shivamogga, once again for preponing the panel, but we are running.
Venkatraman ma'am and all the panelists for a very insightful session and panel on stillbirth. We'll be concluding the morning session and we'll be taking a break after all this brainstorming sessions because our tummy is grumbling, a half an hour lunch break maybe. So to summarize the morning session, we have learned some preventive aspects in perinatal outcomes through all the monitoring and surveillance advised by the speakers, and also how not to lose a lesson from the babies we have lost. So the traumatic experience of stillbirth is not only to the parents and family but also for the obstetrician and team. So let's try to improve and prevent such unfortunate incidents. So we'll all meet after a very short break. We have 2 more interesting sessions in the afternoon on intrapartum concerns and postpartum disquiets. So let's meet at around 2:30. Thank you one and all. Extend a warm welcome to the afternoon session of this Perinatal CME. Despite great strides in obstetrics, preventable complications still challenge us. Today we are here to strengthen our knowledge, update our practices and define strategies that will truly change outcomes. So we have this intrapartum concerns session now. I request chairpersons Dr. Ashwini Pai ma'am and Dr. Geeta Sushil Kumar to kindly come over to the dais. Dr. Ashwini Pai ma'am is the professor and head of the unit Obstetric and Gynecology at Subaya Institute of Medical Sciences, and Dr. Geeta Sushil Kumar is a senior specialist and consultant at Megan Hospital, Shimoga. I extend a very warm welcome to both of you. I kindly request you to moderate the session and take over.
Post-lunch session. Our first speaker in this session is Dr. Shripad Hebasar. He is a professor and head department of OBG KMC Manipal. He is a member and past secretary of Manipal OBG Society. He has won Best Teacher Award 3 times. He has got 100 publications, out of which more than 40 are Scopus and PubMed indexed, and 50 plus presentations. He has also won Best Paper and Poster Awards 2 times, and he has been awarded the course certificate by the Federation of Royal College of Physicians in March 2019 for management of vascular complications in pregnancy. He has also received a state award in 2021 for performing highest number of surgeries for HIV positive women. Over to you, sir.
Thank you for that nice introduction. First of all, I thank Dr. Srilakshmi for calling me here, and we are all students of Dr. Prahlad Kustagi here. And Dr. Srilakshmi was a postgraduate when I was an assistant professor. And later on we moved up in the ladder, and I was associate somewhere in 2016. Till then I was doing only the gynecological work, and once in 10-15 days I used to get calls. That's why I was the second on call. And obstetric was never interesting to me, and I think I did not show much interest also in that. But in 2016, I was given a unit chief of one of the unit, and whether he liked it or didn't like it, you have to do obstetrics. And you all know that whenever you are obstetrics, like when you are head of the unit, whatever happens in the unit, it is your responsibility. Still, I have some 1 or 2 cases pending against me. I would like to recapitulate that at this juncture. She was a primary gravida, low risk primary gravida. She was admitted for induction of labor. Normally we give myphagest, and on the second day we start inducing. And somehow the patient suddenly decided midway through the midway through the induction protocol, she opted for cesarean because she didn't want to have that pain was intolerable for her. But she had taken food also, and we had to wait for 4 hours because our anesthesia friends, they don't give anesthesia if the patient is full. And NST was the CT was going on, everything was perfect till the end, and we took her for cesarean as indication being CDMR. On the table there was thick meconium, and baby cried weakly. So fetal heart rate was there, it was 100 above 100, but baby had very severe meconium aspiration, and baby sucked on 21st day. and the case is still pending against me. They have sued us because only this one is that doctor has told them everything was fine till the end, till the time of cesarean, and suddenly they are giving us a moribund baby. And the pediatrician also nowadays, like we have a DM specialty, and they tell on the face of the patient that no, it's not our problem. Baby was born with meconial aspiration, the lungs were washed out, and it is a perinatal asphyxia, and they don't hesitate to write it as a perinatal asphyxia. Recently also one of my SRs, she conducted one delivery, fetal heartbeat till the end it is fine. On the second stage, that there was one loop of cord around the neck, loose loop of cord. Cord was, patient was delivered. Then the baby did not cry after the birth. Okay, and baby then afterwards, like the same story began. Baby was on perinatal. They again said that the perinatal hypoxia, it is a doctor mistake. He was after me. All these days we came to you for regular scans. I already spent 20,000-30,000 for antenatal care. Now you couldn't diagnose even a cord around the neck. Okay, it was a loose loop of cord, but during the process of descent, it became tight. But there are no NST changes, CTG changes. And baby had to undergo hypothermic protocol and all. And baby now it's neurologically intact, but all this time, like till the baby was discharged, he was coming and fighting with us. And nowadays, like whenever such a mishap occurs, I don't know from where the people come. Some that association, some political, they all gather and they literally harass you. Okay, they literally harass you. So now always I feel, like obstetrics is a very tough practice. Many people ask for, doctor, am I going to have a normal delivery? Okay, if you say yes also it is a problem because many of them, they will have a second cesarean. Recently there was this one. I saw a WhatsApp conversation. The lady, IT girl, asked a lady, another girl, okay, another mother, where to deliver. She says, okay, you deliver in a very best hospital, go to Cloud 9. Why is that? No, you ask for a normal delivery there, they'll try their level best, but something goes wrong, you can take them to court for a heavy compensation. Okay, yeah. So that's the thing, like especially in the IT, that's the thing. They demand for cesarean. They do have vaginal delivery. Many times you see in the labor room, patient wants cesarean delivery. The bystanders outside, they say, you try maximum. Why you want to do a cesarean? So sometimes, like the WHO says that you have to keep the cesarean rate at 15%. And nowadays, even in a government setup, I heard the cesarean rates have gone up to 60%. That's all because of, like one single intrapartum death, can ruin your practice. So what is the intrapartum stillbirth? It is defined as the death of the fetus during labor. It's a tragic outcome of the pregnancy. It is reflective of the care received by the mothers and the babies in labor. Investigating unexpected neonatal death that may be associated with an intrapartum event is also helpful to fully appraise the antenatal care. Because nowadays there is something wrong, which are not picked up during the antenatal period. Is it very common? Yes, it's very common. One stillbirth occurs once in 16 seconds worldwide. That's about 2 million babies are stillborn every year. What makes these deaths even more tragic is that the majority of them could have been prevented, though the quality of care, given during the pregnancy and the childbirth. Beyond the devastating loss of the life, the psychological and financial cost for the women, families and the societies are severe and long-lasting. As rightly said by our MC today, stillbirth is devastating not only for the patient but also for the doctor. Since 2000, there are an estimated 53 million babies have been stillborn. Stillbirth is a huge burden globally. 1 in 70 births end up in a stillbirth. Most of these stillbirths, they occur 8 to 10. It occurs in sub-Saharan developing countries. That's the sad part of it. And they say that over 40% of the stillbirths occur during the labor. If current trends continue, another 16 million, that is 1.4 babies, will be stillborn by the end of this decade. So this is every year the statistics are almost the same. In 2023, you can see here, it is almost the same statistics. Nearly 40 to 50% of the babies are stillborn during the labor. Before understanding, why baby, is it that the baby dies only during labor? Probably the answer is no. As sir rightly said in the morning, where the period of viability begins. If the period of viability begins at 22 weeks, and that criteria you take it for our country, our still rate will be very, very high. But if we take it at 28 weeks, probably we will be almost equal to them, but really it does not reflect the quality of care because even after 28 weeks, you are not able to meet the world standards. And remember that though it is an intrapartum stillbirth, it is not the baby has died just during the labor. There would have been a predisposing factor which are not picked up. The insult, the chronic hypoxic insult would have started in the antenatal period only, which are not picked up. And remember that even if you give a crying baby momentarily to the patient or the neonatologist, like even the early neonatal death within first 24 to 7 hours, like still consider as like for practical purposes stillbirth only, because the neonatologist will say definitely that okay, there was a intrapartum event which led to the earlier death. So that also has to be taken into consideration, because it is not just that you just give a baby with a heart rate to the pediatrician. That is not acceptable. Patient won't accept it even if there is a death within first 24 hours. And nowadays we are seeing the pediatrician also, we are running a DM course. They say that the death was because of perinatal hypoxia. And to have evidence, like they will have MRI evidence. The baby will have HIC stage 3, and many times you find that these babies, when they are born, the cord blood pH was less than 7. So what causes stillbirth? It mainly includes the events such as antepartum hemorrhage, infections, maternal medical conditions, and importantly FGR, late onset FGR, which are not picked up. Around 10% of the worldwide stillbirths are the result of obesity, diabetes, and hypertension. We all talk about women empowerment. What has happened now? Everybody wants to study. The age of marriage is postponed. By the time she is a primary gravida, she is already 30 years. Many times we find that she has some amount of obesity, hypertension, diabetes. We find that they have suddenly that the obstetric scenario has changed. The best age for the woman to deliver is between 20 to 25 years. But probably that is not happening. That is happening only probably in some of the government hospitals where it caters those girls who get married very early. So it's now the scenario is changing. Okay, earlier you said that boys only smoke. Nowadays girls also smoke. So that is one of the preventable factor, I would say. So smoking also increases the risk of stillbirth. So there are several ways to classify the stillbirth, recode classification and all, the condition relevant birth and all. But I think this is a good example, what you call an ICD-PM system, where it looks at the cause of intrapartum death as congenital malformation. Probably you have not diagnosed it. Okay, it may be undiagnosed aneuploidy. Birth trauma is very, very important, especially shoulder dystocia and all. If there is a delay, that can result in the antepartum or the postpartum death. Any acute intrapartum event, such as sudden abruption, can also result in intrapartum death. And sometimes as in amniotic fluid embolism occurring during labor, taking away the life of both the mother and the baby. Infections are also coming up. Then the disorders related to the fetal growth, probably they are the one which you have to concentrate, because they can be picked up, and any hypoxia because of fetal growth disorder, chronic placental insufficiency can be picked up earlier, and we can do some intervention to avoid the stillbirth. So many post-lectures are not there. These are the main causes of stillbirth, and it is all the basic the chapters which you deal with the undergraduates. So the first and foremost I would like to say for cause of stillbirth is fetal distress during labor, sudden placental abruption, prolonged labor, obstructed labor, uterine rupture. Nowadays you know that it is the era of increased cesarean rate, and sometimes nowadays they say that even VBAC can be tried, because I heard in Calcutta Medical College and all, I went there as an examiner, they deliver 60 babies every day, and out of them, like nearly 20-30, they are the case of previous cesarean, waiting in the queue, because there are only one OT, so they have to prioritize. And I have seen the rupture occurring during the waiting period. Cord prolapse, vasa previa, and the infection, mechanoaspiration, all can kill the fetus during delivery. Now I will come to the fetal distress, which is the foremost cause of intrapartum death. And you all know that, we all discussed in the morning. CTG can be a helpful tool, though do not have a computerized CTG. Even thoroughly analyzing whatever the available the machine CTG, like you can definitely look into and try to find out where it went wrong. So if at all, if in the CTG you want to look at, it should be the deceleration should be looking at. If there is a deceleration, you all know that deceleration defined as less than 15, the baseline fall up to 15 beats lasting for 15 seconds. But if it is more than 45 beats from the baseline heart rate and it is persisting for more than 60 seconds, and there is a slow recovery to the baseline, and you all know that though we say early, late and variable, late is because of chronic placental insufficiency, variable because of cord prolapse, even repetitive early deceleration, sometimes like you have to take a call, And when it occurs with more than 50% of the contraction, every time you don't say it is early deceleration and simply wait, you may have to take a call. Whenever there is deceleration, you have to look at whether there is a shouldering present or not. The presence of shouldering, it assures you that when the cord compression was, probably it was transient and the baseline heart rate came back to the normal. But if there is a deceleration with absent shouldering, probably you have to decide for early delivery. So wherever there are variable decelerations with concerning features such as a few things I already told you. If there is a slow recovery, if it is biphasic, reduced variability, baseline drops, and absent shouldering, it indicates that there is no compensatory mechanism, and you have to deliver the baby as early as possible. So you all know that we all call it as intrauterine resuscitation. So basically, it is a change of maternal position, hoping that the occurred cord prolapse, which should have been earlier there, would have disappeared by changing the position. And especially in the left lateral position, that uterine placental flow is very good. Check the blood pressure again. We have seen many times, like during the interpartum period, the BP shoots up. Though a day prior, the BP was normal. Give a fluid rush, and always remember, whenever there are deceleration, you have to do a PV examination to rule out cord prolapse. I will not get into the details. So there is a CTG classification of all these the heart rates. It should be on your labor room protocol, and ideally it should be pasted on the board, so that many times it is difficult to remember because the criteria it sounds like a mental maths. Every time you have to find out the criteria, and you have to find out where does it exactly fit into. So there is something called a baseline heart rate, which is assuring, non-assuring, and abnormal. So if the heart rate is between 110 to 160, it is assuring. 10 beats variation on either side, it is non-reassuring. But still, if it is only one facting, that still you can wait. But if there is a heart rate less than 100, more than 180, it indicates that it is an abnormal baseline heart rate. You only have to look at the baseline variability. So the certain criteria are given, and importantly the sinusoidal pattern. I'm already told, if there is a sinusoidal pattern, remember it is sinister. Similarly, you have to look at a deceleration, and all these things difficult to remember. There are nice charts, which are available. What you have to do is you have to just encircle it, and finally you have to add up, and you will know whether the CTG is assuring whether it is pathological or not. So if there are all reassuring features, that indicates that it is a normal CTG. You continue monitoring and try to aim at vaginal delivery in the absence of any CPD. If one non-reassuring feature is present or two reassuring feature is present, you have to be suspicious. Then you have to go for what is called as all this intrauterine resuscitation, change position, IV fluids, and stop oxytocin if there is uterine hyperstimulation. But if there is one abnormal feature and two non-reassuring features, you should somehow you should stop thinking that. Many times I have seen the obstetricians going for delayed decisions. There is already meconym. They say meconym alone is not the indication for cesarean delivery. Fetal heart rate is good. What fetal heart rate is good? Only auscultative fetal heart rate. That is not good enough. So you have to look at the CTG in toto, and you have to take a decision. And the manuals such as the testing like a fetal scalp, it itself is controversial. I don't know, the UK, they recommended it once upon a time, but now I heard that even they have given up on that, that doing a fetal but scalp pH monitoring. So most of the time there is a pathological features, and the patient is not nearing the second stage, like she is 4 to 5 centimeter. Don't continue the labor, you try to terminate it. So most of all, like we would say, if one factor is important, that is bradycardia. So there is a rule of multiplication of threes. If you find bradycardia lasting for 3 minutes, you have to call for help. Gone are those days, like obstetric used to be a solo practice. Now you should be a group practice. Don't hesitate to discuss the CTG in the group. If there are bradycardia lasting for 6 minutes, it is a wise decision to take the patient to the theatre. If bradycardia persists for 9 minutes, prepare for delivery, and definitely 12, it should be a crash cesarean. But I am very sure, though we are in Manipal, we are at the mercy of anesthetists. Many times they don't, because they are also busy in the different theatres, and performing a crash cesarean, I don't know whether it is possible in the routine setting. That means crash cesarean means you say cesarean now, and baby should be delivered within the next 6 minutes. I think very few, maybe 1 or 2 cases they will be able to do that. Otherwise, many times I have seen, you have done a study also, whenever there is a decision for cesarean taken, okay, sometimes the interval can be up to 1 to 2 hours depending upon the anesthesia, depending upon the OT availability. Sometimes, the two people, 2 or 3 people simultaneously, they will have fetal distress in labor. For us also, it becomes difficult to prioritize. Okay, many times we find that the baby who had really distress, according to CTG, when you open her up, nothing will be on the table. Baby will cry nicely. The other baby which did not show much, like suddenly have a meconium. So it is very tricky situation even on the table. So there is an algorithm called as Dr. Bravado. See, okay. So I will tell you that what is okay. Sinusoidal pattern, Sorry. Something happened. I pressed the wrong button. Can you help me? Display again, you have to go. Display. I'll do that. I'll do that, sir. This computer is a bit tricky. Close the display. Extend display, sir. Mouse icon. Mouse it. ಒಂದ್ಸಲ ನೀವು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀರಾ, ವಾಪಸ್ ಮಾಡ್ತೀರಾ, ಎಸ್ಕೇಪ್ ಇಲ್ಲ ಮೌಸ್ ಇದು ಕಾಣಿಸ್ತಾ ಇಲ್ಲ, ಅಲ್ಲೇ ಬರ್ತಾ ಅದು. Okay, it's PowerPoint is always like that. So other way to circumvent this is you have to save the file as PDF. Okay, and in PDF you should run the view full form. Okay, then your computer will not crash. Okay. This is a sinusoidal pattern. Which will do. Okay. So morning they were discussing, okay, the sinusoidal pattern in labor, it is very, very sinister. It indicates fetal anemia. Okay, so in the presence of the normal maternal heart rate, normal BP, everything is fine with the mother. But suddenly the CTG is showing variation. That means that it is the baby which is bleeding into the mother. Even small fetal bleed of 30 ml, like it is good enough. Because baby has a very small blood volume, as you all know that. Okay, even 30 to 40 ml of fetal bleed, can result in severe fetal anemia. And when there is a fetal anemia, this one will appear like this. Okay, so sinusoidal pattern is considered as a sinister, and you have to deliver immediately. Baby, as rightly madam said in the morning, it will be born very, very pale. There are two types of asphyxia: asphyxia livida and asphyxia pallida. You all remember that. Pallida means baby well born. Okay, whenever the baby is born very pale, remember you have to rule out fetal-maternal hemorrhage. Okay, so you all should remember this mnemonic, Dr. C. Bravado. Okay, doctor is not really doctor. Doctor means define risk. Okay, C for contraction. Look at the contraction. Study the baseline heart rate. Study the variability. Study the acceleration. Study the deceleration and overall impression. So accordingly, you have to risk satisfy and think over whether you have to do a cesarean delivery. Okay, so uterine rupture and also abruption has to be ruled out. Okay, okay. This chart probably is very useful in your labor room. Okay, so for each patient, like you have to mark this. And it is not, as madam said in the morning, Dr. Jyoti Shetty, it is not one time exercise. Okay, you have to do it now and then, because suddenly the things can change in the labor. Okay, at 8 o'clock everything can be reassuring. Suddenly at 10 o'clock, everything can be non-reassuring. Okay. The second reason, common reason, which can kill the baby during labor is abruption placenta. You all know that abruption can occur in the antepartum period and then also in the intrapartum period. I will not go into the details, but you remember there can be a sudden abruption. Okay, whenever there is a hydromnias, whenever the delivery of the second twin, or let us say you are doing any manipulation, or let us say like the patient already has a preeclampsia and patient has already had a PRM. Okay, these are the patients who are likely to experience acute abruption in labor. So these are the risk factors for abruption. I'm not going to the details. Okay. So remember, though we say the antepartum hemorrhage is after 28 weeks, most of the time the abruption occurs around 34 weeks. You all know the clinical features. Okay, these are the one we ask the undergraduates during their examination how to differentiate between bleeding from abruption placenta from that of placenta previa. Okay. So remember, the abruption per se, like sometimes, it can mimic preeclampsia like picture. I have seen BP is normal, but still patient having proteinuria. Okay, the uterine tenderness, the uterus larger than the period of gestation in concealed hemorrhage, woody toned uterus, cardboard-like rigidity, the uterus which does not relax during the labor. Okay, the pain is there at the onset of contraction and it continues even after that. It is possible only in two conditions. One is uterine hypertonus, the other one is abruption. Okay, in those cases, you have to act immediately, but luckily, the placenta has a very great reserve. For the baby to die, it nearly takes around 40% of the placenta has to be separated before the baby can die. So that's a good thing. Many times, timely cesarean can revive the baby if you do it in the crash cesarean. Okay, so nowadays you know that every LT, unless you have a labor room, unless you have a CTG machine, unless you have facility for interpartum ultrasound, probably it is very risky to conduct the delivery. So when you do the interpartum ultrasound, you may find a huge retroplacental clot. And always remember, okay, the small clot, don't neglect it. Okay, always what you see in abruption placenta, the clot, it is only 1/3 of what actually the patient has bled. Because you all know that when the clot occurs, like 1/3 it is only 1/3 of the hematocrit entire blood volume. The rest 2/3 is the serum. It gets absorbed. And the small clot also has to be given important consideration. And you can see in this CTG, the fetal heart rate, okay, it's nose diving. Okay, in those cases also, probably you have to consider crash cesarean. Another reason why there can be an intrapartum stillbirth is prolonged labor. Earlier days they said the woman in labor should not see 2 sunsets or 2 sunrises. That means the labor should not exceed 24 hours. But later on they said, okay, woman laboring for 24 hours is too much. So they brought down the criteria to 18 hours. Okay. Nowadays even they don't go by 18 hours, they go by stage wise. Okay. You know that there are different stages of labor. Okay. Latent phase, if there is a prolongation, probably it will not harm the mother or the baby. In the active phase of labor, the event starts leaking. So these are the upper limits for active phase of labor. In fact, the latest the WHO labor guide, it states how long you can wait at each cervical dilatation. I do not know whether you are practicing that kind of autogram or not, but most of the time you trace it. So whenever you feel that the labor is not progressing, okay, 3 things are possible. One is uterine inertia, the other one is undiagnosed CPT or occipito-posterior position. So if it is undiagnosed CPD, okay, probably you have to revise your decision. Occipito-posterior, you can give another 3 hours because you know that there is a long internal rotation can occur. That's why in the partogram, there is something called an action line which is 4 hours away from the alert line. And if it is because of uterine hypotonus, then you can start the patient on oxytocin. But remember, whenever there is a delay in progress of labor, you have to ask yourself, okay, whether you can safely continue the labor or not. Okay, so these are some of the risk factors whenever there is a prolonged labor. Okay, especially the second stage events are very, very important in determining the outcome of prolonged labor. If there is a slowing of the descent, arrest of the descent, they all say by centimeters, okay, less than 1 centimeter per hour in priming gravida, protracted descent, arrested descent and all. But I am not very sure whether your examining fingers, can determine 1 centimeter per hour so accurately. Okay, so many studies we have done also. There are nowadays what is called intrapartum determination of the fetal perineum to head distance. We ourselves have done. And we are correlated with the even senior obstetrician findings, and they don't correlate. Okay, so ultrasound is more objective, whereas clinical findings, somebody says above the spine, somebody says that spine, somebody says, sir, with contraction in the next half an hour the baby will come out. Okay, all can be wrong. Okay, so you should be able to understand the different types of the labor according to our partogram. Okay, so there is no simply like many times I see in my postgraduate writing the indication for the second stage cesarean as non-progressive labor. It is not. That it should not does not satisfy the criteria. You have to specify whether it was the secondary arrest of labor, secondary arrest of cervical dilatation, whether it was a prolonged dysfunctional labor, whether it was a secondary arrest or a prolonged protracted descent. Everything you have to quantify it. There is a almost prolonged labor. Okay, when left unattended can go for obstructed labor. There is a small difference between obstructed labor and a prolonged labor. In prolonged labor, okay, the uterine contraction can be weak, but in obstructed labor, Okay, uterine contractions always, they are strong contraction. So in spite of good uterine contraction, there is a progressive descent of the presenting party is arrested, then it is because of mechanical arrest, this obstruction. Don't venture. Many times what happens in obstructed labor, there is a caput, okay, and you feel that the caput is reaching the vulva. So you feel that, okay, now I apply a force, it will come out, okay, but it doesn't happen that way. So presence of a large caput, presence of a grade 3 molding and all, you should resist yourself from going for instrumental delivery. Since first applying for vacuum, then after applying forceps, again it fails, you take her to the OT, you have damaged the lower genital tract, you have damaged the baby also, and baby is very hypoxic and moribund. Okay, so these are some findings in obstructed labor. You should teach your undergraduates, okay, how to identify the obstructed labor. So you all know about okay, how you teach physiological distraction ring, pathological Bandel ring and all, no? You have to teach them nicely, okay, how the abdomen looks like when there is a obstructed labor. That you have to teach the undergraduates. Otherwise what will happen, like they simply prolong the labor. I've seen many times, we order for second cesarean and we find that the bladder has already reached up to the umbilicus. So what has happened? The lower segment was unnecessarily stretching all the time. Okay. So you should teach your undergraduates, postgraduates to identify all these rings. Okay. Okay. So they always say that before the rupture occurs, no, there is a state of threatened rupture. So usually what happens is the patient is at the height of the contraction and suddenly she says, doctor, all my pain gone. And within next time the fetal heart rate disappears, the patient goes into shock. So that means that she has ruptured. Okay, so sudden cessation of contraction, sudden disappearance of pain, in a suspected prolonged labor, you should always worry about ruptured uterus. Okay, so there will be signs of dehydration, maternal distress will be there. Okay, so on examination, these are the things which you teach our undergraduates. Okay, this is a classical picture from 10 teachers. Okay, how the junction of upper segment, lower segment, how the uterus appears in normal labor, what happens in obstructed labor. Initially the ring is horizontal, transverse, then it becomes oblique. Okay, there is a change in the contour of the abdomen. All these things should be taught to the undergraduates. Okay. So these are the vaginal exam. Vagina is very dry, vulva is so. I think these things are gone now. Okay, unless the patient, like in Nepal, I worked in Nepal for some time. There, the people stay in hilly area and there are no transport. So patient who is in labor, like sometimes is brought after 24 hours of labor and on a wooden stretcher. So usually I used to find these things, and also I have seen some obstetric fistula. But I think nowadays, nobody sees these kind of vaginal findings in obstetric labor because the patient is taken for cesarean much in advance. Okay, so this is how you have to manage the obstetric. There is something called general management. You all know about it. Okay, the bladder has to be emptied. Antibiotic you have to start. Most importantly, there is maternal distress. So you have to improve the maternal circulation, give fluid bolus, maintain the urine output, and in case patient is anemic, blood should be sent for. The possibility of triggering a massive transfer protocol can be there. Always remember, in obstetric labor, operated delivery is better than instrumental or vaginal delivery, even in the presence of dead baby. Remember that. Okay, even in the presence of dead baby. Okay. So the other thing, like why there can be interpartum death is uterine rupture. You all know that. Okay, the rate of cesarean sections are going up. Nearly 30 to 40%, I think up to 50% of primary gravida, they'll have they'll undergo cesarean, and these are the mothers who become pregnant in the next time. So when you see gravida 2, a population, half of them would have already had a scar on their uterus, and this scar has to be properly monitored. Though they say that like VBAC is possible, okay, but I really do not know. 1 or 2 cases have happened in Manipal, and usually it is the hospital says that always the case of previous cesarean should be posted for elective cesarean. I don't know how many people have the courage to put them for all those feedback. Okay, anybody in the private practice doing vaginal delivery for previous cesarean? Okay, okay. Sometimes you can burn your fingers. Okay. So most of the time, they say that if you use oxytocin wrongly, that fundal pressure to expedite the delivery of the fetus in the second stage. You all say don't give fundal pressure. Many people are agree, but baby is not coming out. Okay, what to do? Okay, okay. People say don't give fundal pressure. Baby, she is not pushing. Okay, what to do? Okay, I have seen many times. We also give fundal pressure, but we don't document it. Okay, but what to do? Book says that you should not give fundal pressure. Okay, yeah. but baby is not coming out. Okay, so what to do is a problem. So gentle fundal pressure, like without documenting it, sometimes, like I'm very sure out of 9 cases, 10 out of 9 cases, 9 out of 10 cases the baby gets delivered with fundal pressure, but they say that you should not give it. Okay. So there are some signs of impending rupture which I already told you. Actual rupture occurs. You all know that there is a sudden severe abdominal pain, suddenly session of the contraction stop. The patient can, because of hemoptysis, there can be a shoulder pain. And always remember, unexplained vaginal bleeding, unexplained hematuria, unexplained the fetal heart rate tracing. We should always alert you the possibility of uterine rupture. Okay.
Spontaneous rupture also.
Spontaneous rupture usually occurs in grand multigravida. Okay, you have got a false assurance because inlet, like sometimes is contracted because of spondylolisthesis, because they all know that they have calcium deficiency and all, and it can be traumatic also. Okay, it can be grand multigravida. No, they don't listen. Okay, so she has delivered 5 babies initially formed normally. Okay, now suddenly 6th baby, goes for obstruction. Always think about obstructive labor.
Posterior rupture.
Yeah. Okay. Okay, these are all undergraduate this one. Okay, so always remember in obstructed labor. Okay, always remember you stop the oxytocin, prepare for cesarean delivery. Okay, don't go for all those. Okay, forceps delivery, vacuum delivery, and all. No, sometimes you can burn your fingers. Okay, many times I have seen, like you are giving too pain to the parturient woman. Okay, you are giving her a big episiotomy to put the vacuum. Afterwards it slips. Then you go for sequential forceps. That also fails. Then you run her to the OD. Okay, there also cervical tear occurs. So the woman, like has suffered the pain of vaginal. You are giving double pain. Okay, so try to avoid that. Okay, if you want to do cesarean, do it early. Always think, like I recently heard a lecture by Edwin Chandraharan. They are also, they say go for reduced cesarean rates. But he says that, okay, nobody says what to do if there is such an event. Does the law and government protect you? They will say that no, doctor, you didn't take a timely decision. That's why there is one. They will say that she was the only one patient in the labor room and there are 10 doctors around her and nobody took the decision. Okay, so they will take 1-to-1. And always, like remember that your judge is not a doctor. Okay, they are all other people. It is always said, like very intelligent person, chooses MBBS to be MBBS doctor. Okay, who does BA, BCom and all, he becomes an IAS officer. And little bit in between, like they go for all this law and they become judges. And the one who doesn't study at all, he becomes a politician, but he is the one who dictates others. Okay, so far even these judges, always some I feel, like they have the feeling that the doctors are very rich and they can be milked easily. Okay, so like you take 100 rupees consultation, but the compensation they ask is in lakhs. Okay, so remember that. Okay, you have to think, okay, what is right for that particular patient and how can you save her, and also you can come out with a clean hand. Okay, this is the rupture, how it looks like. Okay, so remember that once there is the actual rupture, so entire thing is in a messy. Okay, when you go for ligation of uterine artery, invariably you will clamp the ureters. Okay, so always remember that. Okay, if you are managing with obstructed labor, okay, you should know also how to do a internal artery ligation. Okay, forget about this one. You straight away go and do the internal artery ligation, that will stop the bleeding. Another thing which can kill the fetus during labor is cord prolapse. Okay. You know that there is a difference between cord presentation and cord prolapse. In cord prolapse, the membranes are absent. Basically, remember that the cord dwells in the environment of 37 degree. The moment it gets exposed to the exterior, even if the baby 24, 26, like it is considered hypothermia for the cord contracts and there will be hypoxia. And you have to act very fast. Okay. So these are the risk factors for cord prolapse. Okay, they say that the cord prolapse, is less in vertex presentation, only 0.5%. But remember that if the cord prolapse occurs in vertex presentation, it has got a very bad prognosis because the baby cord, gets nipped between the two hard surfaces. The cord prolapse in breech presentation has the best favorable prognosis. Okay, so you all know that how to diagnose occult cord. Even in fact, they say that even after doing ARM, we should put the patient on CTG because sometimes there can be occult cord prolapse. Okay, may not be felt on PV, but it was slided by the side of the head. Okay, any CTG abnormality, variable decelerations, especially with shouldering. Okay, you should, which I already initially told you, you should be cautious about cord prolapse. Okay, always remember cord prolapse, vertex presentation, prognosis is very bad, and also the decision to deliver. If the delivery occurs within 30 minutes, okay, still 1 out of 10 babies die. But if the delivery occurs after 30 minutes, half the babies die. Okay, so remember that. whenever there is a cord prolapse, okay, you should see us, okay, we will be running around in the LT. Okay. Intern is running around, PG, everybody is running, okay, without any, sometimes we feel, okay, suddenly, like things have gone wrong, okay, all people, they are running around. That means that something has happened in the LT. Okay, these are the management, how do you do, okay, I don't know really, okay, whether you really put the patient in knee chest position, whether that putting her in that position and pulling her to the OT, whether she will like it or whether the bystanders will like it, but they say that the patient in knee chest position gets the cord back. Okay, raise the buttocks, that's also very important. There is a method, Bourre's bag it's called as, you fill the bladder with 500 ml of saline. Whenever you distend the bladder, it causes sympathetic stimulation, it relaxes the uterus. So that is one reason. Another reason is that probably the distended bladder, it displaces the head up. So probably that prevents the cord compression. Okay, so remember cord prolapse means, like unless the patient is fully dilated already, the head is out, okay, or it is the second of the twin, you can venture for vaginal delivery. Otherwise should be a crash cesarean delivery. Okay, but see the vaginal delivery is permissible only if you don't find the cord pulsation. But they also say that, okay, the cord pulsation, you should not feel it and say that there are no cord pulsation. Feeling the cord for cord pulsation again can damage, again it can cause vasospasm. Always you check with your Doppler or with the ultrasound. Okay, don't digitally palpate the cord, that it itself can initiate the vasospasm. Okay. Last few slides, you know that I already told you vasa previa can kill the fetus during labor, which you are not diagnosed. Nowadays, all the placenta abnormality, they say that the right time to diagnose is right at the time of the 13 to 14 week scan. Okay, they are only expert can comment about whether the placenta is low lying, whether the cord is low down. Okay, so remember earlier the gestation, it is easy to find out velamentous insertion. Towards the term, most of the time, after 34 weeks, who does endovaginal scan? Okay, it is all abdominal scans, and you may miss vasa previa. Okay, so there is a slight difference between velamentous section and vasa previa. In velamentous insertion, remember that when the vessels are opened, when they run over the internos, then only it is called as vasa previa. Basically, previa means in front. Okay, placenta previa means placenta is in front of the presenting part. Vasa previa means fetal vessels are in front of the presenting part. Okay, this is a velamentous extension of the cord. Okay, so they say that when you do the ultrasound, okay, you see pulsating structure. Sometimes you have a doubt whether it is a maternal artery or whether it is the umbilical artery. What you have to do? I just put a Doppler on that, study the wave pattern, and number 8, that will give the heart rate. Okay, when you put number 8, you get heart rate of 178. You put it on maternal vessels, heart rate of 76. That means that there is a difference, and probably the vessel what you are studying is a fetal vessel. Okay, so look at the pattern. Experts to this one, they can, by looking at the Doppler, they can say definitely this Doppler pattern belongs to the umbilical vessels. Okay, you know that there is a nice diastolic flow. There is no tall like maternal vessel. You know that they will have shooting sound. Okay, like shh, I think when you do a veterinary Doppler, you can differentiate. The maternal vessels will have a shooting sound, whereas the sound itself will tell you whether the baby's vessel or mother vessel. Okay. Always remember, whenever there is vasa previa, they say that we can diagnose with sinusoidal pattern on NST, and if I have a doubt, you can do a test called a AB test. Okay. So the principle is that fetal hemoglobin is, you all know the HbF, is alkali resistant, and when you add NaOH, it doesn't get discolored that easily, it remains pink, whereas maternal vessels, maternal blood, it always turns pink. Otherwise also you can do a peripheral smear, and if presence of nucleated RBCs on the peripheral, on that particular stain blood, probably it will tell you that it is of the fetal origin. Always remember in vasa previa, the maternal heart, everything is fine. Okay, it is only the baby which is bleeding. Small amount also is good enough to kill the baby. Okay, so actually this AB test, it was described by a pediatrician, not by obstetrician. Okay, so there was always a doubt he had whenever the baby vomited out the blood. He wanted to know whether the blood belonged to the baby or whether it is the maternal swallowed blood. Okay, so that's how the AB test was evolved. Okay, then finally, not to forget about fetal infection, maternal chorioamnionitis, meconium aspiration. Okay, can kill the baby, if not in the immediate intrapartum period, but later. And I went, because we had a meconium aspiration, I went through literature. The passing of meconium, it is very complex. Many times you find that the term babies will have meconium, but they are not hypoxic. Okay, so some people say that it is a sign of maturation, and it can be a normal finding in term babies. But for us, it is difficult whether it occurred because of fetal hypoxia or not. Okay, so always remember, whenever you manage a case of chorioamnionitis, they say that there are two parts of infection. One is maternal infection, which can detected by the maternal signs and symptoms (ERP), but also there is something called FIRS. Okay, the fetal inflammatory response syndrome. Okay, in which you will find only subtle changes in the NST, but maternal everything is fine. Okay, so that also can be this one. Remember that the stressed baby, either because of chronic hypoxia or because of FIRS. Okay, it may do bad even after birth. Okay, you may find the very good heart rate, but somehow it doesn't breathe. Okay, so always remember, okay, whenever there is a chorioamnionitis, it goes to a series of events. Okay, initially there will be increased metabolic rate as indicated by CTG, increased baseline, then sudden abrupt increase also very important. Loss of acceleration, loss of cycling, neuroinflammation, and there is a loss of cycling will be there. And in the end stage, there will be reduced baseline variability, sinusoidal pattern, and progressive reduction in the baseline heart rate. So always case of chorioamnionitis, before you say, okay, I will deliver vaginally, okay, closely monitor the baby. Okay, though they say that in chorioamnionitis, most of the time it occurs, which is associated with PRM, and PRM cesarean section is not a rule. Okay, but whenever you're dealing with a case of PRM, wherein rupture of membranes has occurred more than 12 hours, probably you have to take a call. Okay, in a case of PRM, ideally they should get into labor as early as possible. So I went through some of this because this topic was a bit difficult for me. Okay, intrapartum deaths, what all to search for. Okay, so there are different studies. So they have indicated these are the risk factors. Okay, one study said that in their study shoulder dystocia was an important risk factor. In another study say that major congenital malformation. Who is bothered with major congenital? It's good only for the baby. Definitely, if there is major congenital malformation, it is better that baby dies. But how you explain to the patient is a difficult thing, because the patient, you would have said that everything is normal. And as you said, some of the anomalies, they evolve in the third trimester. And some of the anomalies, such as trichoepithelial fistula and all, they remain undiagnosed even by an expert fetal medicine specialist. Okay. So other things, chorioamnionitis, APH, interpartum asphyxia, okay, they all can cause antepartum hemorrhage. Intrapartum fetal death. Okay, so I think I have touched upon the major cause of intrapartum deaths. But always remember, okay, the baby suddenly don't die during labor. Usually there is an intrapartum event, antepartum event. Okay, so finally, it is something you are not diagnosed in antepartum period, something you are not diagnosed in intrapartum period, and finally something you have missed in postpartum period. Okay, I don't know, in our hospital also, many times when the babies are born. The first person comes first year PG, he struggles, can't put the endotracheal tube, then succession of event occurs. Okay, in one of the patient, the baby was intubated after 30 minutes. But they don't say, okay, they say that there is a meconium, don't suck the throat. I really don't understand. But the protocol says that, okay, you should not suck out the throat in a case of meconium. Okay, you should do ambu bagging. I really don't, okay, with the meconium inside the throat, you do ambu bagging, does that, meconium doesn't get into the lungs, but they show the guidelines. Guidelines say that even in meconium aspiration, don't bag. Okay, you have to do, if at all you want to do, you do endotracheal intubation and suck out this. Don't bag. In front of us, baby is born with weak cry, baby heart rate is 110, and after 24 hours they say that the baby had perinatal hypoxia. And they tell the patient that, what to do, we got a sick baby, moribund baby. Okay, you are going and ask your obstetrician. Okay, so they put the blame on the obstetrician, and you have to okay, you were 3-4 days gone in convincing the patient. Okay, I think I have touched upon some important causes of intrapartum deaths. If anything is there, you can ask me.
Thank you, sir, for that informative talk. I think after this, we all understand how important it is to monitor the ladies when they are in labor. Also, like sir said, we have to document, and we have to really look for any other risk factors if they are there earlier on. Okay, so any questions from the audience?
Thank you. Thank you, sir.
I now request both the chairpersons to give a moment of appreciation to Heba sir.
Tilak, I'm in another Manipal. I'm in Manipal, I'm professor, Manipal is where I'm from.
Yeah, we're having a mini reunions.
After listening to this talk, now I know why MBBS students are so fond of Hebbar sir. Now, in between, sir keeps cracking jokes. All students of MBBS students in Manipal, they remember Hebbar sir's jokes more than his lectures. Both, yeah. Whenever I meet in any of the CMEs, they come and tell how is Hebbar sir. And they share sir's experience.
Shetty madam. Professor and Unit Chief, Kasturba Medical College, Manipal, and Manipal Academy of Higher Education. Madam has presented 60 publications in indexed national and international journals. President, Manipal OBG Society. She has got award for excellence in teaching twice, Poxy Imaging Science Award, and Karan Gupta Memorial Prize for Best Poster Presentation. Her field of interest is high-risk obstetrics, endoscopy, Mullerian anomalies, abnormalities, and intrapartum ultrasound. Over to you, ma'am.
Like one of the questions all the relatives, you have a patient in labor room, is will she deliver vaginally? So that's sometimes we can predict, but sometimes we have to wait till second stage whether rotation will occur. So that's the reason I started developing interest in this topic and started doing intrapartum ultrasound. Things in intrapartum, when it's ideal to have in labor room, I think in the present scenario, better to have a ultrasound machine in the labor room, because it will because the women are also becoming obese, and our traditional teaching of maneuvers to find out how much head is engaged, and majority of them enter into labor nowadays with mobile head because they have an unfavorable cervix, and we are inducing labor and making the cervix favorable and dilate. So first and foremost, we would like to see 3 things when we do ultrasound, so that it helps in better decision making and safe vaginal delivery. One is position of the fetal head. See, we all learned from the beginning in obstetrics that occipito-posterior position takes a longer time. But if you happen to see in the first stage, you need not scare the patient that she is having occipito-posterior, because we have to wait till second stage. For example, I had one second gravida. I had done sweeping for her in OPD. She was already second gravida. So first time she has delivered in our unit. So second time also when I did, she was already 2 to 3 centimeters dilated. I told her, if you go into labor, come in labor. But she did not go into labor. So 3 days later, she came back. I admitted her. I said, okay, now you are already 3 centimeters. So let me induce with oral misoprostol solution. And that head remained in occipito-posterior till second stage. And in second stage, it turned and nicely delivered. So we have to have a lot of patience. So you can see here, it is like how you do is you locate the back of the baby. First you have to locate always the back of the baby, and then keep the for locating the back, you have to place longitudinally. Then when you come near the pubic symphysis, you make it 90 degree. Okay, and then see the head of the baby. Okay, then try to see some landmarks which will help you to make a decision whether it is occipito, because whichever is from 4 o'clock to 8 o'clock becomes occipito posterior. So here you can see the thalamus. All of us know that that's the thalamus, and that is pointing towards left of the mother. Okay, so that is the midline forks, and this will tell you that here the spine also will be on the left side, and you know that this is left occipito transverse. So in the beginning of labor, you just note down the position just to be sure how much time she'll take in labor, because when it's little bit, usually left occipito posterior is unstable. Most of it will become left occipito transverse after some time with the contractions. But if it's right occipito posterior also, you have to give enough time. It depends on the overall patient, the size of the baby. Up to 3.5 kg we can easily deliver, and the height of the mother. Height of the mother should be ideally above 150 centimeter, because anything below 150 centimeter nowadays is little difficult to deliver, because the babies are all becoming big nowadays. Now here you can see I have kept this one transducer in the suprapubic area, and you can see the orbits, the two orbits. So here back is on the back, facing back, and this is called direct occipito posterior. So it is, baby is direct occipito posterior, but you can always wait, because if the baby is small, this baby will be born probably as, if it remains like that, will be born as, if it flexes well, will be born as face to pubis. Next, you want to see the attitude. Okay, so first we'll note the position. It's not enough just to see the position of the baby. We have to see the attitude, whether we all, earlier learned sinciput, occiput, sinciput higher, all that, all that is very difficult, and nowadays patients don't cooperate also. So better is use ultrasound, and then, it will become a habit, and it becomes very easy to diagnose attitude of the fetus. So here what we do is, we locate the back of the fetus. You can see there are two spine appearing. You draw a tangent to the spine and a tangent to the occiput, and then you measure that angle. Understand that angle? If it is, this is also done by transabdominal ultrasound. So it is useful, and it tells you, and that is called the occiput to spine angle. Now, if the baby is head is completely flexed, okay? If the baby is completely flexed, you will find that this occiput spine angle will be like more than 109 degree. So the bigger the angle, better. That means the chin is touching the baby's chest and it is nicely flexed. So this is a good sign. Now here you are seeing that head is deflexed. So when you draw the line here, and to the occiput, it is coming less than 109. Okay, that means it is showing it is in the pelvis, it is not flexed. It is not a good sign, but it may improve as the time passes by. Don't scare till you reach at least 8 to 9 centimeters. But that's the time actually, sometimes so many times you find the baby's head gets flexed. Same way when it is occipito-posterior also. Because sometimes, like in its occipito-posterior, the patient, when you come to labor room in the morning, whole night she was in labor, and you find this baby is now in occipito-posterior. Then, to make a better decision, you can do what is called, to determine the attitude in occipito-posterior also, you can do what is called chin-chest angle. That is, you draw a line on the sternum. I will show you exactly like how it is done. You can appreciate that you draw a line on the sternum and draw a line on the chin. So this chin-chest angle should be between 35 to 90 degree. That means you draw a line on the sternum and on the chin. and this will tell you, like if it is flexed, no, the angle will be less, and it is a good sign. So this is a baby which is initially you do, now this may be like, the patient has reached second stage, you want to take a better decision. So what you do is, first you place the position on the suprapubic area, and then when you do place, you will see the orbit. You can appreciate the two eyes which are seen as round orbits. Then you rotate and make it longitudinal, okay? And then you will find that, you will get that the face of the baby seeing. You can see their nose, chin, seeing, and this is called the profile of the face. So you can draw a line now, once you see that, draw a line on the chin and on the sternum to get the chin-chest angle. Now, in occipito-posterior, once you see also, to make a better decision whether, if it is direct occipito-posterior and whether you will be able to deliver or not, whether you can wait or better to do cesarean, what you have to do is, you have to do, like here, this is a good flexed occipito-posterior. That means, what you have done is here, in the transabdominal scan, you are not, what you are doing is, when you are doing the scan, you are not seeing the spine of the, here, I will show another picture where you will see the spine in occipito-posterior. Now here, in the when you transperineal scan is very useful, the same transabdominal probe, you can you can keep a powder-free glove. Okay, powder free. That means otherwise it will spoil your transducer. You put jelly on the curvilinear transducer, and then put this glove, and then again put jelly, so that then you place it longitudinally in between the two labia, and then you will see here the orbit. Here you are not seeing the orbit, so when you are doing, orbits are not seen here. Can you see? This is the head, okay? This is only the head of the baby. So this baby, if you wait, this baby will be born as face to pubis. No worry at all, okay? So you can easily deliver this baby by waiting. Like if it is below 3.5 kg and she's a tall lady, you will not have any issue and you can easily deliver this baby. Now, this baby is to be taken up for section. See, bro presentation can be diagnosed, but suppose you are called, like whole night she was in labor and then you are asked to see in the morning to take a decision. That time you can use this ultrasound and make 100%, because when this caput and all, very difficult to make out this is bro. So what you can do is, when you do transabdominal ultrasound, you will see the orbit. Then when you do transabdominal scan, you will find that here the spine also is seen. Can you see the spine? This means the chest is thrust forwards and you can see the spine, and when you do transperineal scan, you are seeing the orbit also. This baby has to be posted for cesarean. Okay, this is 100% a case of bro presentation. It can be like, because bro presentation sometimes, if you miss and take a wrong decision and put forceps, you will not be able to deliver. So if you see spine on the scan like this, because in the previous picture, this picture and the previous picture you have to compare. The previous picture did not have spine and it was a well flexed head. So you can wait. Here you have to take up the patient for cesarean, otherwise you will end up with obstructed labor. Now, face presentation is easy to diagnose. Actually, while doing PV only, you will see the mouth as well as the soft orbit. So actually, only thing is, I will just say that you got a doubt by PV, then you want to confirm, you do an ultrasound, you will get occiput to spine angle, which is less than 109 degree, which will tell you that this is 100% a deflexed head. Now the third use of doing ultrasound is for finding out the actual descent. When there is a caput, the ISWAG guideline has given two parameters which are very useful, that is angle of progression and head perineum distance, which will tell you how to measure these angle and derive. Like there is a chart also which will tell you that, okay, this angle, definitely the head is down, okay? And you can be 100% sure, you can wait further for the patient. So there are two important parameters, that is angle of progression and head perineum distance. So what is done here is, here a transperineal scan is done. Transperineally scan is done. You have to put the transabdominal probe, cover it with a glove and put jelly and place between the two labia till you see the pubic symphysis and the full head, that is the upper tabula and the lower tabula of the head. So what is done after you see the image, you just have to move little, then you will get the pubic symphysis, then you draw a line on the pubic symphysis, then from the lower end of the pubic symphysis, you draw a tangent to the baby's head, like that, okay? And the inner angle is measured. So here I can say it is about 150 degree, like that, okay? So then what is, so you can see exactly, that is the pubic symphysis which is imaged, and the head, it is drawn, and this angle is measured. So it is drawn from the inferior border of pubic symphysis to the skull. Now ISWAG has given a guideline on labor, and in this there is a chart. You can use this in the labor room, you can paste it. Once you get that angle, no, you are 100% sure. Suppose you got an angle of 127, that means the baby is at +1 station. So like that you can be 100%. This is an objective way. Like one person doing this angle, whole labor room knows this head is at +1 station. So the same thing we grouped this angles, so that because we are not using their -5 and +5, because ACOG uses 1111 centimeter. The distance from pubic symphysis to the perineum is 10 centimeter. So we clubbed that into our way of describing. That is, when it is between 107 to 116, it is 0 station, and between 117 to 132 is +2, and so you know that when it is +2 station and all, you can wait really. Like, another maybe little bit with of oxytocin, it will become +3, and you can maybe safely apply vacuum and deliver the patient. Now you can, suppose you get a doubt with angle of progression, you can even also do the head perineum distance. So same way you cover, but here the transducer is placed on the ischial tuberosity and it is placed transversely. For angle of progression, it is placed longitudinally, and here it is transverse, and you place and give little pressure. What I do is I give little pressure so that it comes very accurate, till you give pressure till you see the lower end of the fetal head. So this is how it looks when you take the image. So a compressed head perineum distance of 2.5 centimeter will correspond to +2 station. +2 station, okay? So your angle of progression and this both should correlate. And then you know that without compression also you can do, but I prefer to do it with compression because it really gives real good objective assessment of the station of the fetal head. And you can also see one more point, that is, we all know that head delivers by extension. So now this baby is almost going to deliver. Okay? So in occipital anterior position, when head is pointing upwards like that, no, that means head is really down. Okay? And the angle of progression also is very large. Now when the head is really horizontal, it is only in the mid pelvis. And if head is pointing, downward, head is downward, that means it is really high. So all this information will help you to make a better decision, especially when you want to put an instrument. So why we should know this much of intrapartum ultrasound? Because we become better decision making and safe vaginal delivery. So main use will be you will know the position of the fetal head position, because when it is occipito-posterior and baby is looking above 3.5 kg and she is just 150 centimeter, probably you have to make a decision now only, after 2-3 centimeters, maybe better take up for a cesarean. You have no hopes that this patient will progress. Now, it will also, the head flexion of the fetal head will always help you tell whether, if it is in occipito anterior and all, you will do occiput to spine angle. If it is occipito posterior, you will do chin to chest angle and find out how much of the flexion. And also the station is made out. The station now all the time, we did with PV station, but we can do it more objectively by doing angle of progression and the angle of progression and the head perineum distance. So when you have arrest of the descent or the second stage is prolonged, what will tell you that you can wait or you better take her up for cesarean? So one is, if it is occipito anterior and angle of progression is more than 120, and there is something called, when mother pushes, the angle of progression will further increase by 15 degree, that is called delta, and head up direction, which I showed you, the head up direction. All this can be seen with the ultrasound in the labor ward. And with this, you know that in another 40 minutes she will deliver. You can encourage her to deliver. Now this is a chart, taken from best practice. So whenever the first stage is prolonged, first you should find out what is the position of the fetus. Then you find out the flexion of the fetus. Then, so occiput spine angle more than 109 means it's a flexed head. And then you find out whether contractions are weak or whether it is, it's a case of CPD, you better take up for cesarean. If it's occipito posterior, you do chin chest angle and then find out if it is bro and all, better take up for cesarean. Otherwise, you can wait. If it is less than 35 degree, you can wait. In persistent, when it is remaining as occipito posterior, so what you will do is, if the spine is posterior and the station is high, you will get a very small angle of progression. And head is, the chin chest angle will be more than 35 degree. That means you have to post her for cesarean, nothing doing from down, because this patient you will not be able to deliver vaginally. So before applying instrument, in our labor room almost all of us are doing this, okay, because otherwise, it improves our decision making and all babies, will come out crying also. So if angle of progression is more than 140 and head perineum distance is less than 25 millimeter, you can easily deliver by putting vacuum or forceps. And head up direction is also a good sign to wait for vaginal delivery. Now this was one of the studies done, published in American journal, where they did a model along with head circumference of the fetus. It's just not the, you might have seen at term, no, we do an ultrasound to get the fetal weight of the baby, estimated fetal weight. Along with that, you should note down the head circumference. It should be for Indian women below 3, 4, 5. Okay? And if the angle is more than 146 degree, you will have a good success. And if at all, if the angle of progression is less by 115 degree and head circumference is big, more than 345, you will not succeed, in vaginal delivery. So this is another chart to how to decide whether to do in second stage cesarean or whether to do vacuum. This is by doing all these parameters which I told you. If it is occipito anterior, you have to see with pushing how much angle of progression will increase. And if you get occipito posterior and any suspicion that it is suspicious of bro or CPD, better take up for cesarean. So better to have a ultrasound in the labor ward, and better to do fetal head station by doing angle of progression and head to perineum distance and head direction, and determining the attitude by doing occiput spine angle and chin to chest angle in occipito posterior position. All this will make you more confident and better having a safe vaginal delivery. So, we did a study in 90 primigravida women, and we collected all the data, we analyzed, and we also got the similar findings to the literature, and we were able to publish this in one of the very good journals. So, it's one of the very good practice to start, because I also started because, we had to take decision in first, especially when it is prolonged first stage and second stage, and gave it as a thesis topic to one of my postgraduates. And most of the postgraduates who have used it also, now they have also learned how to do it, and they all find it very useful. Even after passing out, they are also doing it in their labor room. They say it's one of the most useful thing to learn. It is, actually in YouTube also there is a video. Intrapartum ultrasound. You can learn, and ISWAC practice guideline is there. You can read and learn. Both are very useful, and if you have the machine, it's just, first even I had a hesitation to start. Initially I did for 4-5 scans, then I knew I'm able to do it very well. Then we continued to do it. And now it's become a routine practice. Most of us, when we want to put instrument, we always do it, confirm, then do the instrumental delivery. Thank you.
Thank you, ma'am, for the excellent and nice presentation. And I think for both for the staff, audience, and PGs, it is a really helpful. And day to day in the labor room, we'll see all the obstructed labor, and this intrapartum ultrasound is we have to, each one of us should learn, and it was very nice, ma'am.
I heartily thank on behalf of Malnad High-Tech Diagnostic Center and SOGS, Dr. Shripad Hebbar sir and Dr. Jyoti Shetty ma'am for the excellent insight into how we can use the CTG and ultrasound in improving perinatal outcomes. I request Dr. Hebbar sir and Dr. Jyoti Shetty ma'am to come over to the dais and hand over a token of memento to our chairpersons of today, Dr. Ashwini Pai ma'am and Dr. Geeta Sushil Kumar. after extensive sessions on antepartum worries and intrapartum concerns, we now come to the most important but commonly neglected period, postpartum disquiets. So to chair this session, I now invite Dr. Ravish sir and Dr. Hema Mohan madam onto the dais. I extend a warm welcome to both of them. Dr. Ravish KR sir is a consultant physician, a fellow in diabetes from CMC Vellore and PGDMLE from NLSU Bangalore. He is currently the president of IMA Shimoga and the vice president of API Sayadri branch. A hearty welcome to you, sir. Dr. Hema Mohan ma'am is an associate professor in the Department of OBG at SIMS Shimoga. She has participated in various national and state conferences, workshops and CMEs and presented research papers and articles. She has been awarded the Karnataka State Award in the year 2021 for conducting the highest number of deliveries for HIV positive women. Thank you, ma'am, and extend a warm welcome to you. I request you to kindly introduce the speakers of today and carry on with the two sessions.
Post-lunch session. It's difficult to be a husband to an obstetrician at home, and being I am a president and attending a obstetric CME as well. Okay, and that was just to wake you all up. I am happy to introduce the first speaker of this session, Dr. Arvind St. He is MRCP. He did work in London for some time, then he came back to India. He has his own psychiatric hospital set up here in Shimoga. And he is a much sought person in social media as well as in various platforms, YouTube, newspapers. And he is a much sought person in counseling as well as preparing the mindset of people for exams and so many other things. He has won many awards at various levels. He is a busy psychiatrist here, doing very well. I welcome Dr. Arvind St. on behalf of MHDC and Dr. C. Lakshmi Madam to address us on postpartum psychiatric disorders. Over to Dr. Arvind.
Good afternoon, all respected seniors and colleagues. It's my privilege to present a topic on psychiatry in Shimoga OBG Society CME. I would thank all the Shimoga OBG Society members and especially Dr. Sri Lakshmi ma'am and Dr. Raksha ma'am for keeping me in track about the CME. I think when I was hearing all the lectures, the topics from the various seniors gynecologists here, I thank myself I didn't take OBG. So much of complications, but I really salute all of you for a great, wonderful service you are doing to the humankind, because under stress you are delivering a wonderful job. So moving on, so postpartum psychiatric disorders. This is usually sort of like many times psychiatric disorders as such is neglected in many parts of India as well as across the globe, and that's why we have forgotten the definition of health, which is the complete state of physical, mental and social well-being, not just the absence of disease or infirmity. The suicide rates are increasing. Almost 8 to 10 lakh people commit suicide every year, and more than 1.5 lakh Indians commit suicide every year. So apart from the complications of the antenatal progression of the fetus, the complications during delivery and post-delivery, we are looking at the other side of the motherhood, the psychiatric aspects of the motherhood. The onset of mental health symptoms during the journey of pregnancy and during the postpartum, it's usually the postpartum period, which is the most crucial period where many of the mothers develop either postpartum blues, depression or psychosis. if they had any prior history of depression or bipolar disorder in the past, that would put them at more risk. So during the postpartum period, 85% of women experience some type of mood disturbance. That doesn't mean it's a pathological depression or a pathological psychosis. It's a very risky period for psychiatric disorders because it's 20 times more that women experience psychotic or manic episodes in postpartum periods. And most of the symptoms, the majority are postpartum blues, which are short-lived, and sometimes they can progress to depression or psychosis. So this is the spectrum. The commonest is the postpartum blues, next is postpartum depression, and the puerperal psychosis. So let's focus on the postpartum blues. I think post-lunch session we are all having blues. Let us wake up and listen to this. So low mood, mild depressive symptoms that are transient and very self-limiting in nature. They will have symptoms of fearfulness, irritability, anxiety, labile mood, decreased sleep. They are just recovering from the process of delivery, and they have to adjust to the new norm that there is a crying baby next to them. They have to feed them, and the kind of the physical exhaustion what they have gone through. So usually the symptoms of postpartum blues develop around 2 to 3 days of childbirth. They peak within few days, and most of them resolve within 2 weeks. That we need to understand. And 50 to 85% of women experience this in the first few weeks of delivery. So more than 50% women do have postpartum blues, and as I said, it starts within a few weeks of delivery. And postpartum major depression is approximately 4 to 11 times more common among who have developed postpartum blues. There is a progression from postpartum blues to postpartum depression. So if the person doesn't have any postpartum blues, they are unlikely to develop postpartum depression. So usually the person, the mother who has developed postpartum blues, there's a high chance that they can get into major psychiatric disorders like major depression or puerperal psychosis. The exact etiopathogenesis is not well known, but the hormonal changes, typically probably the gynecologist will know better than me. They say decrease in estrogen, progesterone and prolactin in following delivery, and there is an elevated monoamine oxidase levels in the brain. Monoamine oxidase is the enzyme which catabolizes the SSRIs, the serotonin, the dopamine and the norepinephrine, and the decreased serotonergic activity in the limbic system of the brain. So who is at risk that we need to understand? Usually we call it PMDD, premenstrual dysphoric disorder. The ladies who are going through menstrual cycle related mood changes. Usually they get irritable, clingy, we have to be very careful in our houses as well when somebody is going through menstrual cycle. So those people who are having mood changes around menstrual cycle, history of major depression or dysthymia. Dysthymia is subthreshold depression. Depression is something which is significant symptoms of low mood, anhedonia, anergia. Dysthymia is a subthreshold depression. It's just like a pre-diabetic kind of a condition where if you ask a dysthymic patient, they will say, I've never enjoyed my life. My life has always been misery, boring, something like that. So mood changes associated with pregnancy and larger number of lifetime pregnancy and family history of postpartum depression as well. They all put risk of getting into postpartum blues or any other complications. So treatment by diagnostic criteria itself, postpartum blues are very self-limiting. So they require more of validation, reassurance and psychosocial support. But we have to be very careful that we need to evaluate for the risk to self and risk to the baby. What happens is usually these tend to get into postpartum depression, or they might have suicidal thoughts or homicidal thoughts as well. They might throw the baby away. I have come across few cases like that. So they should be carefully screened for, as I said, ideation, suicidal ideation, paranoid behavior, homicidal ideation towards infant. And if insomnia persists, CBT or pharmacotherapy can be recommended. So I think the first line of treatment here is reassurance and counseling. Counseling is like, it has become a very general term that everybody is a counselor. We are the only qualified ones. So you need to sit with them, talk with them, understand their pain, misery, and what is going through their psychological and the social aspects. What is the change which is happening within the family? What are the conflicts within the family which is coming out? That we need to understand, because it depends on the mindset of a person, how they respond to criticisms or other things. For example, if a mother has just delivered and the mother-in-law walks into the hospital room and probably is more focused on the baby rather than the mother who is still in pain. The mother who is probably having a negative mindset can think that I am unlikable, nobody likes me. That's why the mother-in-law or the husband side, nobody is taking care of me. But if a person, so that is a thought. The thought is just next is the emotion. If somebody has a negative thought, their emotion becomes like depressed or anxious. The consequences will be, the behavior consequences will be, they can be irritable, they can be aggressive as well. In the same scenario, if we put it in a positive kind of a mother, where she thinks that maybe they are overwhelmed by the cute smile of the baby, that's why they're not looking at me, it's okay, let them have their time, they'll come back to me. So that's a positive mindset, how they take the situation. And the succeeding emotion would not be depression or anger, it would be complacent and be confident about their emotions. The behavior would be trying to reach out to the other members of the family to rebuild the connections. So prognosis, as I said, it's typically mild, transient and self-limiting, and we have to be careful about the progression into depression or psychosis. The next aspect is postpartum depression, which probably is increasingly becoming more common. So typically it emerges over 2 to 3 days, 2 to 3 postpartum months, but may occur at any point of delivery. And depression is clinically indistinguishable from the depression what you face in normal life. So what are the symptoms of depression? The 3 classical symptoms of depression according to ICD-10 or DSM-5 is low mood, anhedonia, anergia. So low mood, we always know that if you lose a mobile or some ring, we all will be a little bit low in our mood. But that doesn't define that the person is having depression. The depression is the pervasiveness of the sad mood lasting for more than 2 weeks. They're always preoccupied with the loss or the conflict and they don't interact well with the people. So that's the type of low mood we are looking into. And anhedonia. What is anhedonia? Anhedonia is loss of interest in previously pleasurable activities. Like previously I was interested in watching a movie or listening to music or going out with friends. Now I don't feel like. If somebody is putting on television, I feel irritable, I feel cranky. So that is called anhedonia. Anergia is excessive tiredness or easy fatigability. Other symptoms are ideas of worthlessness, hopelessness, self-doubt. Then if it becomes extreme, biological symptoms like low sleep, decreased sleep, early morning awakening, low appetite, then it can progress on to severe suicidal thoughts. They can act upon those thoughts. So these are the symptoms of depression. And significant anxiety symptoms can overlap with depression. They might have panic attacks, they might have autonomic hyperactivity and hypochondriac symptoms. And sometimes they might get obsessive thoughts of harming to baby and thinking that the baby is not mine, something like that. So it's most common medical complication of childbearing. It occurs in 10 to 15% of new mothers, and 1 of every 7 to 10 pregnant women and 1 of every 5 to 8 postpartum women develop depressive disorder, and there is no differentiation between socioeconomic class or race. So this is the prevalence of postpartum psychiatric disorders. 83% don't have any kind of depression. 9% can have severe depression and 8% can have moderate depression, and these severe depressive patients can move on to puerperal psychosis or postpartum psychosis. So again, as I told, this rapid shift in the hormonal environment which leads to these kind of disorders, but there is no consistent correlation between estrogen, progesterone, cortisol or thyroid hormone levels and depression. But if there is a past history of hypothyroidism or past history of mood disorder, they are at risk. So the risk factors are probably similar to the postpartum blues, probably marital conflicts. If there is a conflict, interpersonal conflict between husband and wife or with the in-laws, probably that will also trigger postpartum depression. So what is the treatment for postpartum depression? I think it's a continuum of postpartum blues. What we have to understand is, should not neglect it. That's the most commonly things which happen is, many of the patients are not adequately referred to psychiatrists. Most of the times it is taken it as a normal transition from delivery to becoming jittery and irritable and losing sleep. I think we need to assess them for depression and psychotic symptoms and risk assessment, risk to the mother, risk to the baby, and risk to the society. Recently what happened was a 1 month postpartum lady actually took her baby to vaccination to SIMS. After a few minutes, she called their brother and the family saying that the baby is not with her. The whole family was shocked and they were running around and they took the police help and they were searching. People who are from Shimoga will know that opposite to the SIMS there is Suvarna Samskriti Bhavan, there is a road, and there are few vacant sites there. And this mother had kept the baby on a vacant site, unattended. And she just called the family saying that I don't know. So this is the kind of seriousness the postpartum depression or postpartum psychosis can impact the baby. Later the baby was found in a very crucial condition, but later the baby was saved. So the mind can act in so weird ways. They might think that the baby is not mine, the baby is devil, the baby doesn't belong to me, the baby is going to bring bad luck to family. And I had seen one case in Nottingham in UK, that this postpartum depressive patient who had come for follow-up had actually threw the baby from the window and the baby actually died. So non-pharmacological therapies are useful. First we tend to use interpersonal psychotherapy as well as CBT. CBT is one thing where it acts on now and here, not like our psychodynamic psychotherapy or Sigmund Freud, where you think about all childhood traumas, childhood difficulties having an impact on your current mood. CBT is something where you work on here and now, like your situation is there, your thought, emotion and behavior. So first, as I explained that when a mother-in-law walks into the room of a delivered baby, how they react and how they take that thought, proceeding, succeeding, there is an emotion and there is a behavior. So you need to change how they perceive the thought and how they feel about the thought. So that is CBT, and it requires to be done in weekly sessions for 8 to 12 sessions. And non-pharmacological intervention may be attractive to patients who are reluctant to go on psychotropic medication because of mild complications. But pharmacological management does work, and the major line of treatment is our SSRIs, serotonin specific reuptake inhibitors. Example, escitalopram, fluoxetine, all these medication, or SNRIs like desvenlafaxine, mirtazapine. Tricyclic antidepressant we don't use much. They were used classically like amitriptyline, nortriptyline and all. Benzodiazepines are more of symptomatic medications to help them with sleep and to reduce anxiety. So this is the CANMET clinical guidelines. So first line is CBT and IPT, interpersonal psychotherapy. The second line is monotherapy with antidepressants, escitalopram, sertraline and other combination of SSRI, CBT and IPT. The third line is you go on to the next level of second line of antidepressants like bupropion, desvenlafaxine, duloxetine or classic TCS, clomipramine. But if they don't respond, the problem with most of the SSRIs are they tend to cross, and the lactating women, it can get into the baby as well. So usually, but there is no kind of serious contraindication. In pregnancy, there are definitely contraindications that if you give a mood stabilizer like lithium to a pregnant woman, they can develop Epstein anomaly like cardiac complications or other fetal complications. But during postpartum phase, most of the antidepressants are relatively very safe because very minute levels reach the baby. So if ECT, which is which has got a very bad press in the media and the other places, but it's a wonderful treatment and very accurate as well as very quick actually, because most of our antidepressants like SSRIs, they have a latency period, not like your antibiotics or your painkillers which work within few hours. our antidepressants take at least 1 to 2 weeks. There is a latency period. So usually after 2 weeks they work to their maximum potential. But ECT works immediately and takes out all the suicidal thoughts or risky, homicidal thoughts. So how long one should continue antidepressants? This is a common question from various physicians and the gynecologists. Like many think that the duration is very crucial. Once it starts working after 2 weeks, they tend to resolve all the depressive symptoms within a month or so. But many discontinue medication, thinking that now I'm fine, why I should be taking this medication, I'll become addicted on this, all this kind of like prejudice and stigma about medications will be there. But actually, once there is a complete remission of depressive symptoms, you should continue the antidepressants for 6 to 12 months. That is very crucial. Otherwise, they will have a relapse of depression or they might get into bipolar disorder. So prevention, I think prophylactic interventions like counseling during the time of pregnancy and assessment of psychological disorders before pregnancy, and women with history of bipolar disorder. Bipolar is two poles. Like depression is a unipolar disorder. Bipolar is something like you have episode of depression and you have episode of mania. Like many person might have, he'll be excessively happy, grandiose in nature. He'll have 100 rupees in his pocket. He might think he's a billionaire. So, or you might think that he has got special powers from God, he can bring on rains, he can cure people, all these things, grandiose thoughts. So that is, they'll have an episode of mania and they'll have euthymia, normal mood, then they can get on to depression or either ways. So for women with history of postpartum depression, prophylactic antidepressants are also prescribed. So this is the summary of baby blues versus postpartum depression. As I said, onset is 2 to 5 days in baby blues. This depression is usually more than 2 weeks, and duration lasts for 2 weeks. This can last up to 12 months. Prevalence, baby blues are more common. Depression is quite less. As bile dysfunction is self-limiting baby blues, but this postpartum depression definitely requires psychiatrist intervention. The last one in the series is the postpartum psychosis. This is the most crucial aspect, and this is a medical emergency actually. It's the most severe form, and but this reported prevalence is very less, 0.1 to 0.2%. The nosological classification, it's confusing whether it could be called as a short psychotic disorder or a schizophreniform disorder, or it's a part of mood disorder, because many of the mothers who develop postpartum psychosis or puerperal psychosis tend to have bipolar disorder in future. So there is a debate about where it should be included. So majority of the women with puerperal psychosis develop these symptoms within 2 weeks. And the mean age of onset is 26.3 years. So these are the classical symptoms of psychosis. So they'll have hallucinations, they will have delusion, they'll have confusion, they'll have suicidal thoughts, severe mood swings, paranoia, and insomnia. So hallucination, as we all know, it's a false perception. There's only one lady sitting in the front row. I might see 2 or 3 sitting there, so that's visual hallucination. Or I might think that people are talking against me, or they might be talking about cricket or movie or about their groceries or saris, but this lady might think that, oh, these people are conspiring against me, they are trying to take away my baby, they are trying to hurt me, they are going to inject me something. So this is called delusion. The delusion is, what is the definition of delusion? Is a false fixed belief even on evidence to contrary. Even if you give proof, the lady won't agree. That we need to understand. You can't counsel a person who is having psychosis. Like if the person is having an hallucination or delusion, you just need to acknowledge and treat it pharmacologically or in an ECT way, but you cannot, sit with them, try to change their mindset. That is what many people tend to do. It's like, swimming against the tide. It's not going to work. So some people can have delirious kind of thing, like, they might get confused with the time, place, and person, and they might have severe mood swings, they might be happy at times, they might have, very cranky at sometimes. But what is more crucial is the suicidal thoughts. There have been incidents that, suicides do happen during this postpartum depression and psychosis. So they might have delusion of preference, persecution, jealousy, grandiosity, which are incompatible with the mood. like delusions of bizarre character can happen, tactile and visual hallucinations can happen, and severe mood symptoms of depression, mania or mixed episodes can happen. As I told, delirious symptoms can happen. The risk of suicide increases almost 70 times in the first year after birth. So this we need to understand. And suicide attempts might be very aggressive as well as irreversible. So they might end up committing suicide, because most of these suicides, females are more attempters and men are more completers. There is a recent study in NCRB about number of suicides that happened in 2008 to 2023 in Karnataka. More than 60,000 people committed suicide. Out of that, 40,000 were men and hardly 20,000 were women. Women are more attempters if they have history of any, emotionally unstable personality disorder, where they are very impulsive, they are very emotional, there is a chronic feeling of emptiness. They will have, and if there is any upset, they will tend to have cuts on their forearms. They tend to have an increased risk of suicide, but their completers are more men. So although rare, infanticide can happen, and it has been reported in 4% cases. Pathogenesis is probably the same. Risk factors are probably the same as for other disorders, but congenital malformation, perinatal death during delivery, these probably have a high risk of mother developing postpartum psychosis. So treatment, as I told, it's a medical emergency and requires immediate medical intervention and hospitalization in a psychiatric hospital, and usually treated with mood stabilizers, antipsychotics or ECTs, and benzodiazepines are used. Most of the mood stabilizers are totally contraindicated during pregnancy. As I told, lithium, sodium valproate and carbamazepine are the 3 classical mood stabilizers used, which tend to develop, sodium valproate and carbamazepine, if used in pregnancy, can have neural tube defects, spina bifida and other things. And lithium, if it's used in pregnancy, can have cardiac abnormalities like Epstein anomalies. But majority are relatively safe in postpartum period, so that can be used. But they can interfere with the prolactin levels like risperidone or haloperidol. They can elevate the prolactin levels and tend to disturb the lactation process. Quetiapine is more safer compared to all other antipsychotics, and modified ECTs are generally tend to be safe. So prognosis after single episode, 75 to 85% of symptoms are fully recovered. They respond very well actually. Even the depression takes time, but psychosis, they usually respond within few days to week. Of the patient diagnosed with schizophrenia, 50% recovered after postpartum psychotic episode, 33% had recurrent episode, 5% become treatment resistant of large number of puerperal and non-puerperal recurrence. So it has been reported that 65% recurrence in long-term follow-up study. So these are my references, and thank you so much for having me here. And I would like to invite any of the questions from the audience or from the chairperson. Thank you so much.
I don't think anybody is hallucinating that they are having a question.
They have already asked the question. Yes, ma'am. Okay, I think the history of depression or person having an emotionally unstable personality, as I said, especially during the teenage, this emotionally unstable personality traits tend to develop, where they have a chronic feeling of emptiness. They are very, easy to make friends. They make friends very easily, but if the friends, comments about their dress or something, they becomes very sort of like antagonistic with them, and they tend to be very jittery. So, history of this emotionally unstable personality who have repeated psychotic symptoms as well as quasi-suicidal attempts. Person having that personality traits, history of depression in the past, any family history of depression, or history of medical conditions like thyroid and other abnormalities, tend to have more risk of developing depression or any postpartum psychiatric disorders.
Thank you, Dr. Arvind.
Thank you, sir. Thank you so much.
Covering the topic.
Raksha.
To hand over a token of memento to Dr. Arvind for that excellent talk.
this. I was not confident in the past.
Me too. Sir was my professor also.
Yeah.
I kindly request the chairpersons to introduce the next topic and speaker to the audience.
It is well known that we doctors work very hard but are always under stress. But unfortunately, we are not aware of the medico-legal aspects in our day-to-day practice. For this, I request Dr. Kantika, who is a retired member of National Consumer Disputes Redressal Commission. He doesn't need much of introduction because he is a very well-known personality among us. So welcome you, sir.
Good evening, everyone. My seniors, the distinguished speakers today, and since afternoon, I came across the OBG aspect and just now the psychiatric aspect. Definitely both subjects are tough. And as Dr. Arvind told, he has not chosen OBG. I will say I am very lucky, I have chosen only pathology. So both are tough subjects. With this, I think some problem here. So anyway, I thank the organizers. I thank the organizers for this session, and we are at the last moment. I will take from here.
Sir, 1 second.
The medico-legal issues in our clinical practice, because as a medical professionals, we should know what are our responsibilities and what are the liabilities if we commit some wrong at some stage. You should be alert or conscious. The society, the knowledge, the electronic media, then this Google, everything. The patient base is very conscious. They know each and every aspect. You might have experienced, the patient will come to you Googleized and he will ask, "Doctor, why you have not done ultrasound or this and that?" Whether they will ask a lot of questions. So now it is the time we should be very, very cautious to deal with such patients. Medico-legal aspects, you think nothing will happen as long as there is no litigation.
Off ಮಾಡಿದ ಬಂತ ಸರ್ ಇಲ್ಲ ರಾಜು ಪ್ರೊಜೆಕ್ಟರ್ ಆಫ್ ಮಾಡಿದ್ದೀರಲ್ಲ ಆನಲ್ಲಿದೆಯಾ
So my friend Dr. Ravish knows many legal issues, and he is one of the alumni from National Law School also.
Okay.
Today I would like to highlight few points.
6 CME.
Those are crucial for OBG and any practitioner. The doctrine of consent, the reasonable standard of practice, and third is doctor-patient relationship. Where we fail, where we mean doctors fail, Where doctors fail, we'll see, and how to deal with. Whether many times the suicidal tendencies, what doctor said just now, it is everywhere, it is obvious. Many doctors, they are worried, they have left their practice if one litigation is hit to them during their practice.
Sir, 1 minute.
He will be psychologically upset. Definitely, he cannot concentrate on his day-to-day activities or practice.
Sir, just see once, na. Ella download ಮಾಡಿದ್ರೆ ನಾವು
ಡಿಸ್ಪ್ಲೇ ಟೈಪ್ ಮಾಡಿ ಅಲ್ಲಿ ಡಿಸ್ಪ್ಲೇ ಸೆಟ್ಟಿಂಗ್ಸ್ ಸರ್ಚ್ ಕೊಡಿ ಡಿಸ್ಪ್ಲೇ ಅಂತ ಬರೀರಿ ಇಲ್ಲಿ ಹೋಗಿ duplicates.
Yes.
Microsoft open.
One is false accusation.
PPT.
Remember, there is a
slideshow.
ಇದು PDF ಅಲ್ಲಿ ಬಂದಿದೆ.
Slideshow.
PDF ಬಂದಿದೆ ಸರ್.
PPT ನೇ ಇದೆ. PDF ಮಾಡಿದ್ರಾ? Okay, no problem.
Let's okay.
Let it be PDF.
ಅಲ್ಲ ಬೇಡ ತೊಂದರೆ ಇಲ್ಲ. ಅಲ್ಲ PPT ಇದೆ.
I will do that. Let it be, sir. Let it be PDF. Doctor is negligent, but sometimes something goes wrong, and it will be labeled either negligence or in other way, and the patient will go for the litigation, and court will decide whether he was wrong or not. And there is a perception, if there is a case before the Consumer Commission or court, doctors are invariably punished. This notion you should take it out. I will just release your pressure on your mind. We will discuss the crucial points. Just I explained doctrine of consent, reasonable standard of care or practice, and doctor-patient relationship. Only on this, all three, the entire thing is revolving. Why there are litigations or allegations? Whether we fail somewhere, failure to diagnose, not screening or identifying high-risk conditions like gestational diabetes, preeclampsia, or maternal infections. Yes, definitely this is the lapse. Inadequate monitoring, delayed interventions, whether I should suggest, because patient party, their relatives, they are pressing for normal delivery, but the indications are seizure, then doctor will be in the catch-22 position, fixed position, what to do and what not. The duty of doctor is go ahead, what his conscience says, but provided he must take the informed consent. There are two consents: informed consent if the patient party, they are not willing, then record the negative consent, then your problem will be solved. Then mismanagement of the complications like PPH and other, if there is extensive hemorrhage or atonic uterus, what to do? But at every stage you have to inform the attendant, we are going to do hysterectomy because it is a patient is going in DIC or something, this is the final remedy. You inform and go ahead. Then the many common cases are filed before the National Commission, hypoxic encephalopathy. There was a landmark decision of the National Commission. I will narrate that. Then the challenges before us, false accusation, the high-profile cases like Archana Sharma's suicide. See, the patient died, post-delivery death, but it has taken political scenario, and finally she thought, and she was booked under criminal liability, and she ultimately committed the suicide. This should not happen, because why doctors are doing this? It is the Dr. Arvind should answer this. How to counsel them, how to tackle such issues is a very tough job. Then proving the negligence, proving professional misconduct versus unavoidable complications. It remains central challenge because often these things will be proved by autopsy. Many times patient relatives, they say, no, we don't want post-mortem. But later on, if they file the criminal complaint, that time this starts and they put the onus on the hospital or doctor, they have not suggested the post-mortem. Then how to come out from this? Record it. Medical record are most vital documents. This is one of the case decided by this hospital. Treating doctors are expected to aware unexpected errors. This is very important. We should know the unexpected events which can occur, because later on you cannot take the defense. It is a known complication. When you are aware of known complications, the court will see what you have done to anticipate or treat those complications. I will discuss this case in the next slide. This is the 2005 case decided, I think, in 2020. She herself was the doctor, Rupa Datta was the doctor, and she died due to mismanagement during childbirth and illegal abortion. The patient, her husband and in-laws, they filed the case before National Commission for 3 crores and the criminal case was filed. And issues were medical care, lack of medical care, and they have not followed hospital protocol, the MTP, and compensation for wrongful death was awarded. What happened in this case? She was a doctor, she worked in that hospital as a senior resident. The senior gynecologist she consulted, during first pregnancy, they performed karyotyping. There was minor aberrations, but she did not want to continue the pregnancy. So she approached her senior means her where she was working, under whom the senior gynecologist, and madam, I want termination. The termination was not indicated and it was 26 weeks. Now, the hospital, in good faith, hospital avoided, at the first instance, hospital avoided, but finally she was her resident student, so she agreed and they performed MTP. Unfortunately, she was suffering from bronchial asthma, episodes of bronchial asthma attacks very recently. The pulmonologist certified, okay, you can go ahead, but they performed, and during operation she suffered bronchospasm and died. The child also died. The baby also, it is just 26 weeks, and this is also scenario. Now, the questions are whether this is wrong or right. They have violated the MTP Act because conducting MTP, the doctor's defense was she herself was a doctor and she was aware of all the complications and she forced us. Now the question before us, before the National Commission, if somebody forces, whether you will do that? No. By any means you should not proceed, or you should not indulge in any illegal act. This attracted criminal liability also. Then secondly, the bronchospasm. She was unfit and the doctor clearly certified if she had any episode recently, she should not go for any surgical intervention, or guarded surgical intervention should be there. The next case, this is also Indu Sharma versus Indraprastha Hospital. The patient herself was BMS doctor, primary infertility, conceived, and at the time of delivery, syntocinon was induced for the induction of the labor. The allegation was excessive dosing of syntocinon, delayed decision making of emergency scissor section resulted into birth asphyxia, cerebral palsy, and severe mental retardation to the newborn. The hospital held liable. Hospital was, the award was 1 crore, 90,000 as a vicarious liability on the hospital, and Dr. Saloni, I think Verma, yes, Saloni Verma, she has to pay 10 lakhs. And the commission imposed punitive cost also for the unprofessional conduct, including tampering with the medical records. What happened here? Just Madam and Dr. Hebar, they have highlighted about CTG and other things. No monitoring. CTG was not monitored. They have not produced before the court, but they have created the document and produced creating the documents, tampering the documents. It is a very severe offense, and court will not pardon such incidences. This is a very recent case, Parikshit Dalal versus Santosh Hospital. The very unfortunate, the mother died, the baby died. Before our surgery, while taking to the operation theatre, something happened in the operation theatre. The mother fell down and sustained fractures. The baby died, and the defense was from the hospital, the anesthetist defense was, it was some anaphylactic reaction. No doubt, the court was digging the issue. The matter was sent to AIMS for opinion, All India Institute of Medical Science. They have given clear opinion. There was a fall, and the post-mortem findings were almost 2 liters of blood and clots intra-abdominally and in the intra-pelvic. She sustained fracture, sacroiliac joint fracture, and this thing. The PM findings were clearly indicated. Then why such thing happened? Now who is responsible? Whether gynecologist, anesthetist, or the hospital? The court exonerated the gynecologist because she had no role. She told, we need to go for scissor, that's all. But the preparation, the hospital failed in their duty of care, maintaining the instruments, the staff, and other things. And the anesthetist who just deposed, it was an anaphylactic reaction, and he could not explain the court which and what, and they have tried to conceal the PM findings also. So such instances happen, and this is a very new recent case. Now the child born with severe brain damage died in December. Now this case is ongoing. So with this, I think my duty was to make you careful, not to worry, because the patients are more aware of their rights, they are more knowledgeable, and equally we have equal duty towards the patient and the patient safety. Don't think that my every wrong is punishable. Something goes wrong, some complications happen, but you have to fight because when you receive the court or some summons or notice, you must attend, and don't be afraid. Consumer laws are there, everywhere laws are there, but don't afraid and go to such an extent to stop my practice or under depression. This many things happen. So with this, I think this is the last slide. So with this, time is also short. It's very vast topic. Then any questions you can, I'm very happy to answer also. Thank you.
Thank you very much, sir, for highlighting the
session. I now request the chairpersons to kindly hand over a memento to Dr. Kantikar, sir. I also request Dr. Kantikar sir to kindly hand over the memento to our chairpersons of today's session, Dr. Ravish sir and Dr. Hema Mohan ma'am. With this, the end of the mind-blowing, mind-boggling CME of today, where we have learned how to unite our skills and perspectives to create stronger, safer systems of care. I now kindly request the organizer, Dr. Srilakshmi ma'am, to convey the vote of thanks.
Finally, we have come to the end of this CME. I need to thank so many of you. Many thanks to Prahlad sir, who agreed, who has spoken very nicely. Thanks to Jyoti ma'am and Heba sir. Ma'am has got up at 5:30 in the morning and is here. Her talks were really informative, especially the second one, intrapartum ultrasound, was really informative. I'm very thankful to Dr. Lata Venkatram and also Dr. Srimati, who have come all the way from Bangalore. They had prepared well and they gave a lot of inputs as well. I'm very thankful to our own, my own extended family, that is Shimoga OBG Society. Nagraj sir is with me since yesterday evening and constantly the support is, I'm very thankful to sir. Very thankful to our beautiful Raksha, and I request Nagraj sir to give a memento of appreciation to our Raksha. Bani. Yeah. Our Raksha, only her children are growing and becoming taller. Our Raksha has remained the same. Yes. Immense thanks to our President of OBG Society, Dr. Veena Bhatt. I fail if I don't thank all of you as audience who have stayed back till the last and had patience, and Vimla ma'am has still writing the notes for the last talk. So it is all worth taking the efforts if we have audience like this. And I'm very thankful to my Malnad, which has become more home. Only to take bath I go home actually. So Malnad Diagnostic Center, especially Biradar sir, who has given me free hand. Sir actually doesn't ask anything. I come at my own time and I do my things. And sir has given me the liberty to the extent that I only calculate my salary. Sir just signs the check. Because he knows if I ask, she will eat my head. So I'm very fortunate to be in first floor of Malnad since many times. This decision has definitely made increased my lifespan by first 5 years. Very thankful to a very good working environment. And thanks to all my sponsors, LifeCell, Bharat Serums and Malnad also. They have given me already money and they've told if anything excess, we will pay you later. So much of liberty. I hope I'm up to their expectations. Thank you so much. Thank you so much.
Thank you, ma'am. A big round of applause to Dr. Srilakshmi, ma'am, as well. And sometimes, against all odds, against all logic, we still hope. That is the takeaway from today's Perinatal CME, our Sunday well spent. Let's keep ourselves dedicated to learning, sharing, and growing, because when we elevate perinatal care, we elevate the entire future. Thank you so much.
And this entire session is recorded. I will share the recorded session in WhatsApp as well as in email. And all speakers and all chairpersons, I have taken photos. You can just put it FaceTime and download the required photos. Thank you so much.